Time's up, everyone. Please write your name and your college name in your answer scripts and hand it over to the PG next to you. The answers will be discussed now and the result will be announced tomorrow. இது செட் பண்ணிட்டு அது செட் பண்ணிட்டு அது
So, a short discussion on the answers. The first question is, this is a 2.5-year-old girl with, she was referred to a clinic with a limp. What is your diagnosis? Yes. So this is an AP radiograph, which is showing a dislocated left hip and dysplastic acetabulum. Actually, the Shelton's line is broken in the X-ray. The femoral lies lateral and superior to the inframiddle quadrant. So the diagnosis is developmental dysplasia of left hip. So how do you proceed? You can do open reduction with a shortening femoral osteotomy or a pelvic osteotomy to give more cover to the femoral head. You can do open reduction using modified anterior approach or synovial approach, which is a Francis Bikini approach, and spica casting can also be done. So what is the safe zone? Say it is a zone between the maximum abduction, which can cause AVN, and minimum adduction that can cause uh, dislocation. So we can go to the next question. So this is a 9-year-old boy presented in the emergency with a history of fall leading to an injury to his elbow. The radiographs are taken in the emergency, and what is your diagnosis? So this is a displaced lateral condyle fracture of the distal humerus. And the classification that we use is Milch classification. So fracture that exit to the trochleocapital groove is type 1, and fracture that exits through the trochlea, that is radiograph is type 2. Whatever radiograph that we gave is type 2. So in this case, the fracture line appears to enter the joint line at the lateral crest of the trochlea, and there is lateral displacement of the lateral condyle fragment more than 2 mm. So this is an unstable fracture. Open reduction with care is necessary. And if you are not able to identify the fracture in normal AP and lateral use, undisplaced fracture is better addressed through oblique use. And this fracture is more prone for delayed union, non-union, elbow stiffness, and growth stiffness. So the next question is, a 14-year-old male presents in the emergency room with history of sudden onset swelling in the right knee, no history of trauma or fever. And this is the X-ray. What is the most probable diagnosis? So this is hemophilic arthritis. And what is the classification? What are the two radiological features that is seen? Epiphyseal enlargement and widening of intercondylar notch. And the classification system used is Arnold-Hilgartner classification. And the diagnostic test to confirm the test is serum factor 8 levels. Next question is restricted forearm rotation since birth. What is the diagnosis? So this is a congenital radioulnar synostosis. The classification system uses Clarion number and Pageant classification. And what is the aim of the treatment? To attain corrective rotational alignment with osteotomy. And one iatrogenic cause for this is dissection of interosseous space while fixing forearm bones, fixation of the bones for forearm using single incision. So what is the position of fixation for unilateral case? 20 degrees of pronation in a unilateral case. So next question is, what is the interpretive X-ray? What is the name of this implant? So this is a dynamic clip screw. And what is the principle of this procedure? This is, it converts the shearing forces into the compressive forces. The advantage of this valgus osteotomy is to increase the blood flow to the osteotomy, which increases the chances of union. And so what is the indication of this procedure? Indications are non-union neck of femur. And what is thoracic curve is usually right-sided, and factors affecting the progression of the deformity, the future growth potential of the patient, curve magnitude at the time of diagnosis, and curves in females are more likely to progress. The curve type W curves are more likely to progress. The classification system used is Menkes classification system. So next one is 30-year-old male had road traffic accident, pain and swelling around the right ankle. X-ray shown. What is your diagnosis? So this is a talus fracture. The classification system used is Hawkins classification. And this requires open reduction into fixation with the screw or plating. And the complication is avascular necrosis, ankle arthritis, and vessel injury. So this is a next question which shows a test. The name of the test is Coleman blood test. And it shows if it's, the calcaneal virus is still persisting after the test. And third question is, in what condition this test is used? What are the causes of this deformity? On inspection, the patient has a varus hindfoot with a high medial arch or pescavus deformity. So the hindfoot deformity on right is correctable with the Coleman blood. This shows that the subtalar joint is mobile and the varus hindfoot deformity is divided by excess plantar flexion of the first ray. So that is the thing. So what are the causes? Acquired causes and the neurological, with ataxia, spinal cord, spinal bifida, polio, peripheral nervous system, hereditary sensory motor neuropathy, muscular dystrophies, traumatic and neoplastic, congenital, idiopathic, arthropathic, and residual plaque for other reasons. So this is the next showing image which is describe this picture. So this is showing a planar valgus foot with the 2 toe sign. It can be congenital or acquired. The commonest cause of adult acquired flat foot is tibialis posterior tendon dysfunction. The tibialis posterior is the main innervator of the hindfoot. It also acts as an elevator of the midfoot as it inserts into the navicular bone. Forms second, third, and fourth metatarsal bases. Treatment is guided by Johnson staging. So tibialis posterior tendon dysfunction is the important pathology. Jack stress demonstrates hindfoot or subtalar flexibility in a flexible flat foot and is based on the principle of windlass action of the plantar fascia. So this windlass effect is the wrapping of the plantar fascia around the metatarsal head. It pulls the calcaneus towards the toes as the toes dorsiflex. So next question is arthroscopic image showing defect. So what is your diagnosis? It is osteochondral defect of the femoral condyle. And the classification system that is used is Autobach classification. Grade 0 is normal cartilage. Grade 1 is softening and swelling. Grade 2 is partial thickness defect and do not reach the subchondral bone and exceed 1.5 centimeter in diameter. Grade 3 is deep fissures at the level of subchondral bone. Grade 4 is exposed subchondral bone. So the restorative options are, if it's less than 4 centimeter, we can use microfracture or OATS. More than 4 centimeter, osteochondral allograft transplantation and ACA can be used. So microfracture heals predominantly with type 1 cartilage. So which is the commonest location? It is the lateral aspect of the middle femoral condyle. And the question is actually autologous chondrocyte implantation. Now we take a cartilage biopsy from the femoral condyle, you grow it with the culture, and you put it back into the place of rising periosteal flap that is a defect. And this is the last question. What is the diagnosis? So this is an ACL tear, and the commonest mode of injury is non-contact combined valgus and internal rotation injury. The two bundles are anteromedial and posterolateral bundles. And the tibial footprint is average of 15 mm anterior to PCL, just anterior to just below the anterior lateral meniscus. During the rollback mechanism, rollback is actually is to prevent the impingement of the femur in the posterior portion of the tibia during flexion, thereby increases the available knee range of flexion. So the combination of external rotation and rollback of the lateral femoral condyle permits the flexion angle reaching 120 degrees.
Thank you, sir. Our next session is on pediatric orthopedics. We will begin our session with a demonstration on clinical examination of pediatric hip by Dr. Arul Murugan, sir. Sir is an assistant professor at CMC Vellore.
So, good morning, everyone. So, I'm very honored to be in the podium. So, where once upon a time I was as a delegate there. So, I thank Pasupati sir and Singaradul sir and organizing team for giving me this opportunity to present in front of this big podium. And also, I thank Thomas sir and other team members of my unit. And last but not the least, my patients for helping me to come here and to present in this big podium on approach to pediatric hip examination. So the first session is going to be very monotonous. It's going to be, I'm going to speak to people, and the second session will be very interactive session, that is examination session. So what is my objectives in this? So I'm going to tell about how pediatric orthopedics is different from adult orthopedics. And I am going to tell about some hints for successful pediatric orthopedic examination. And I'm going to take through the history, examination, and how to arrive a final diagnosis. So how pediatric orthopedics is different than adults? So we should not think that pediatric patients are small adults. So they have totally a different biology and totally different anatomy. And also kids are brought by the parents and the kids don't come to us for treatment. So we are treating parents' complaints. So reliability of the caregivers is very important. So we have to, even though it is a parent, sometimes they will be outside and some guardians will be taking care of the patients, kids. So the guardians presenting complaint is more reliable than the parents in this case. So whenever the presenting complaint is unreliable, so we have to more rely on examination than the history for treating the kids. So coming to a hints for examination of the pediatric patients. So whenever the kids is going to enter our room, so it should be a warm, welcoming environment where it should be very clean and it should be neat and it should have some age-appropriate distraction tools. So and also we have to skip the white coat. There are some studies telling that whenever the kids see the white coat, white aprons, so their blood pressure and anxiety increases. So try to avoid avoid the coats when we are treating the pediatric patients. And also introduce yourself to the family members and to the kids and try to have a good eye contact to the family members and the kids. And do not be looked overrushed. Just be calm enough to hear all the complaints and try to explain to them. And take advantage of every minute and try to 10 minutes test the unaffected side first. Whenever you feel that the affected side is going to cause pain to the parents, and perform the painful range of motion at the last. So these are all the some of the hints for examining pediatric patients, so that the patient we cannot make the child to be calm, and we have to adapt some methods to make the child calm with us. So what is the final goal of this exercise? So we are doing history and examination. So what is the final goal? So we have to have a clinical diagnosis or a differential diagnosis. So the diagnosis will be of two parts. One is anatomical diagnosis, and the next one is a pathological diagnosis. The anatomical diagnosis will be obtained by examination part of the history taking, and the pathological diagnosis will be from the history. So what are all the anatomical diagnoses we come across in the hip? So first is synovitis, arthritis, oxyverum, ankylosis, unstable hip, and femorosteal impingement. So if it is a different types of anatomical diagnosis, that then there should be different types of pathological diagnosis also. It can be broadly classified into infection, inflammation, developmental, congenital, traumatic, and tumor. So you have to be so in this one. So any of the broad pathological diagnosis can lead to anatomical diagnosis. For suppose if there is infection of the hip joint, so infection of the hip joint can initially present to us as synovitis. After that, it will become septic arthritis. As the days goes on, it will become ankylosis. So whenever the patient recovers from the infection due to growth arrest, there can be a coxa vara or coxa valga, or whenever the total head is completely resolved, so they can present as a unstable hip. So each one of the broad category of this pathological diagnosis can be any one of the anatomical diagnosis. So similarly, infection, whenever there is a juvenile rheumatoid arthritis or transient synovitis or post-traumatic synovitis, reactive arthritis, so initially they'll be having synovitis. As if you're not treating and if the child is not very cooperative, they'll be going for arthritis and finally leading to ankylosis. So in history taking, the history should be focused on each one of this thing. So if there is infection, the child will be having fever, difficulty in weight bearing, and difficulty in moving the hip joint. And if there is inflammation, inflammatory pathology will be mostly early morning pain, and it will be multiple pain. And developmental will be from the birth. And it also the patient will be giving a significant history of trauma, and also we have to ask that whether the child could able to walk or do the daily activities after trauma. Then only significant. Sometimes they can come with the non-significant trauma and tumor also can present with any of the anatomical diagnosis. So that's about the anatomical. for your you have to go and clarify and you think about it and to digest it. So, on your age group, then we should think of developmental dysplasia. That is more common in the female. So, in 4 to 8 years age group child, whenever the child is presenting with painless limping, then we should suspect this disease. So, that is more common in males. In 12 to 15 years, then skiffy is more common in the age group, but also males are more common. In 10 to 15 years, especially in South India, idiopathic condylosis of the hip is more common. That is common in females. All the presenting complaints in the hip joints, the child or the parents will complain to us. So one is the pain of the hip, pain in the hip region, swelling, limping, stiffness, and shortening. These are all the primary presenting complaints the child will present to us. What are the associated complaints? There can be loss of weight or loss of appetite. So these are the primary complaints, and these are all the associated complaints. So for every primary complaint, we have to take history of presenting. So we have to elaborate every primary complaint by like this. So when the patient is complaining with pain, we have to ask for what is onset, duration, progression. I'm sure that yesterday you might have went across this exercise. So I'm repeating once again so that it will be reinforced in your brain. So site of the pain, radiating or effort pain, aggravating relieving factor, early morning pain, night cries, seasonal variation, diurnal variation, and pain affecting daily day-to-day activities. So there are some specific things in pain. So whenever there is an early morning pain and multiple joint pain, so there are high chance that it can be inflammatory pain. So whenever there is the pain while exertion, during early part of exertion, it can be a joint pain. Whenever there is a delayed exertional pain, it can be due to muscle weakness like abductor insufficiency. Whenever there is a night pain, there are high chance that it can be a malignant tumor or osteoblast. So TB of the hip joint will present to us with night cries. So there is a difference between night cries. So night cries means the child will wake up out of pain. And night pain means the child will be having difficulty in falling asleep. So the hip, especially in the pediatric patients, many of the kids will not present to us with hip pain. So they will be having referred pain. So we will be focusing on the knee joint instead of taking an X-ray of the hip joint, which will be very obvious. We will be treating the knee joint for a long time. So whenever the child is having referred pain to the knee joint, whenever the knee is normal, try to take a hip X-ray to see for any anatomical pathology. So the hip joints get innervation from the obturator nerve and femoral nerve and sciatic nerve. So whenever there is an anteromedial type pain, so that is the obturator nerve which is causing the referred pain. Whenever there is an anteromedial type pain, then the femoral nerve is causing the referred pain. Whenever the buttock pain or posterior type pain, then sciatic nerve is causing the referred pain. So for swelling, we have to ask for site, onset, duration, progression. So we have to ask for the site of the swelling, whether it's a scarpa triangle swelling or a posterior hip swelling. So what are the causes for scarpa triangle swelling? It can be infection, inflammation, tumor, or hip subluxation. If it is a posterior, it can be either hip dislocation or myositis ossificans. So here there will be important questions will be asked to you people. What is a thing which is coming first? Whether it's a pain or swelling which is coming first. If it is a pain, then there is high chance that it will be malignant tumor. If it is swelling, then there is high chance it can be a benign tumor. So coming to the tumor, once again, we have to ask for onset, duration, progression, diurnal variation, and associated factors like pain, restriction of movements. So the causes for limping are broadly categorized into pain. Pain can be of any cause, and muscle weakness. That is abductor insufficiency and shortening. Shortening can be of any cause. So painless limping is classically seen in Purpose disease, and painful limping is commonly seen in infection and inflammatory conditions. So coming to the stiffness, once again, onset, duration, progression, and associated factors like pain, difficulty in performing daily activities. So we have to specifically ask about difficulty in sitting cross-legged, squatting, and sitting in the chair. So coming to the shortening, once again, we have to ask for onset, duration, progression. And what are the causes for shortening? It can be due to dislocation, it can be due to growth arrest, it can be due to altered anatomy of the neck, or it can be congenital. Whenever there is a proximal femur growth arrest, the shortening will be less. When the distal femur growth arrest, shortening will be more because the distal femur has high growth potential than the proximal femur. So in case of PFD or congenital short femur, the proximal femur a dimple which will be seen in the lateral aspect of the femur. So that is an important inspectory findings in case of PFOD in congenital short femur. So after asking all this history of person, we have to ask about the difficulty in performing daily day-to-day activities. That is in 3 domains. That is daily day-to-day activities, occupational and recreational. In daily day-to-day activities, we have to ask about difficulty in performing household ambulation, squatting, sitting cross-legged, clothing, toileting, etc. And in occupational, we have to ask for difficulty in going to school and commuting ambulation. In recreational, we have to ask for difficulty in playing with the peers. So the thing which is different from pediatric hip and the adult hip is we'll be asking about history of birth history and developmental history. So antenatal, we have to ask about consanguineous marriage, spontaneous or induced pregnancy, order of pregnancy, abortions. So everything has some thing about the problem what the child is having. So whether there is any drug intake, smoking or passive smoking, alcohol, radiation exposure, hypothyroidism, gestational diabetes or eclampsia. Intranatal, whether it is a pre or a full-term delivery, whether it's a hospital or home delivery, whether it's a normal or LCS, whether it's normal assisted or unassisted delivery, that will tell whether it is the second stage of it is prolonged, what is the birth weight, the child cried immediately after birth, history of ICU admission, whether the child was stools and meconium, and any neonatal surgeries. In the postnatal history, we have to ask about history of whether the child was able to breastfeed normally, any pathological jaundice. The pathological jaundice can be easily asked by history of exchange transfusions and history of proper vaccination. And we have to elaborate on development milestones. What is the gross motor, fine motor, social and language. So these are all the red flag signs. So whenever the child is not able to perform these activities beyond this age group, then there is then we can tell the child is having delayed either gross motor, fine motor, or language and social milestones. And we have to ask about past history and personal history. This is about at the end of the history, a provisional pathological diagnosis should be made with a brief summary. So coming to the examination, so maybe from this point of time, we can interact and you can tell your findings in these kits. So we coming to the examination, we have to start from the head-to-toe examination. So the first thing is head is facial dysmorphism. Is there any facial dysmorphism seen in these kids? So some of the facial dysforms are anterior and posterior hairline, whether hairline is receding or it's proceeding. Whether is there any hypertelorism? Hypertelorism means intercanthal distance is increased. It can be easily remembered whether if we can able to fit a third eye in between the inner canthus, then we can tell there is hypertelorism. Low set ears. Low set ear means if you are connecting medial and the lateral canthus and it be extending laterally, usually the upper one third and the lower third of the ear, it will be crossing at the upper one third and the lower two third of ear. If the ear is totally below the intercanthal line, then we can tell it's a low set ear. We have to see for the flat nasal bridge. We have to see for frontal bossing, and we have to see for the prominent and long filtrum, cleft lip, cleft palate, high arched palate, protruding tongue, mid or lower face hypoplasia, and short neck. So maybe for this kid, you can see any facial disform you can see. அது கொஞ்சம் மேலே தூக்க முடியுமா? என்னுடைய இது இருக்குல்ல. Okay. So I'm not seeing any hairline abnormality. It's a normal anterior hairline, but I can see a prominent forehead. There is a forehead prominence, and there is a hypoplasia of the mid face and lower face. I can see a flat nasal bridge, and also I can see a low set ears. Okay. So these are all the some of the facial and the neck is normal. I'm not seeing the, I feel that filtrum is normal for these kids and neck is normal for these kids. So you have any things extra you can tell? Okay. Next. It's not working. Okay, next. Now it's changing. Okay, I'm not doing that. Okay. So maybe in this child, you people can comment some facial dysformism. It's a very prominent thing which is seen in between the two eyes. There is a lot of space. Okay, so that is a hypertelorism, and I can also see flat nasal bridge. I can see a long philtrum. I can see a short neck, and I can see a low set ears. Okay, so yeah, some of the syndromes will have some of the facial disorders which is specific to them. Okay, so if you could be able to see all these things, and you can correlate with some of the syndromes whichever you know, even though it is not in our field. Okay, and then the next thing is anthropometry. We have to check for the height, weight, BMI, upper segment, lower segment ratio, and arm span height ratio. So everything is BMI is mainly used for SCIFI. The SCIFI patient will be having high BMI, and upper segment, lower segment ratio, and arm span height ratio will be useful for skeletal dysplasias. So coming to the general examination, neurocutaneous markers. So what is this? So what is this and what is this? Yeah, this is called hypertrichosis, right? That's a tuft of hair which is seen, and this is a midline swelling. It can be either of either meningomyelocele or some it can be the other thing also. Okay, so that is a neurocutaneous marker here. So what is the abnormal thing which you are seeing here? So you are seeing a big swelling in the posterior aspect of the buttocks, right? So that is called lipomeningocele. Okay, so that is classical of sacral agenesis. So these are all the some of the neurocutaneous marker we have to. So whenever we are examining the hip joint, we have to make sure that we are seeing the spine also. So we have to check for capsulospot, neurofibroma, tuft of hair, midline back swelling, midline sinus, and midline appendages. Okay. So coming to the ligamentous laxity. So I guess many of you will know the criteria. The two criteria are Wynn-Davis criteria and Baton score. So Wynn-Davis will be having 5. One is the ability of the. So this is about that. So this is the first thing. The ability of the patient to passively flex the great thumb to the forearm, and dorsiflexion of the four fingers parallel to the forearm, and hyperextension of the elbow, hyperextension of the knee joint, and dorsiflexion more than 45 degree. So these are all the 5 components in Wynn-Davis criteria. If 3 out of 5 is, we can tell the child is having ligamentous laxity. So in case of Baton score, this is not there, but he is telling that hyperextension of the fifth toe, flexion of the great toe, extension of the elbow, extension of the knee joint, and he is putting ability of the patient to bend forward with the knee in extension and be able to touch the floor. So this is also that is Baton score. It has a 9 score. 5 out of 9 is positive. If 5 out of 9 is there, then it's positive. So coming to the general examination of the hip joint, I guess everybody will be aware of this. So we have to start with exaggerated lumbolosis. How can you tell exaggerated lumbolosis? If we can able to insinuate our toes beyond the midline, then we can tell that there is a exaggerated lumbolosis. And we have to tell about the attitude of the hip joint, whether it's flexed, abducted, external rotated, or neutral, and the attitude of the knee joint and ankle and foot. And we have to tell about the wasting of the thigh and calf muscle, whenever it's obvious. And also we have to tell whether there is any obvious shortening we are seeing. It can be either the affected limb or the unaffected limb, depending upon the abduction or adduction deformity. So coming to the inspection from the front. So we have to check for the level of the ASIS. So in case of adduction or abduction deformity, the ASIS level can be different. In case of abduction deformity, the ASIS will be at the lower level. In case of adduction deformity, the ASIS will be the higher level. And we have to see for the carpet triangle whether there is any swelling or visible pulsation. Skin over the scar and skin over the scarpine triangle. We have to see for scar, sinus, fistula, any engorged veins, etc. From the side, we have to check for the level of the greater trochanter if possible. Sometimes it's very challenging whenever it's obese kids. So that time you need to come in level of the greater trochanter. So you have to see for the supratrochanteric hollowness and skin over the lateral aspect of the thigh. From the back, we have to see for visible swelling, gluteal atrophy, gluteal fold atrophy, and skin, how the skin is. From the inside, we should not miss the inside, that is the medial part of the thigh. So from the inside, we have to see for the skin fold. Is there any abnormal skin fold? And we have to see for the skin. Sometimes there can be a discharging sinus, which will be missing when you're not seeing the inner aspect of the hip joint. So coming to the palpation from the front, we have to palpation has to start with local warmth tenderness wherever it can be. It can be anterior, posterior, lateral, or medial. So we have to check for the joint line tenderness. I hope that everybody will be knowing what is the joint line, how to localize the joint line, and we have to check for the pulse. So suppose if the pulse is equal on both sides, can we tell the vascular sign of Narath is negative? We can tell like that. So what is vascular sign of Narath? So I'm giving you the scenario. So the pulse is palpable, bilateral, equally on both sides, equal volume and intensity. So can you tell the vascular sign of Narath is negative in this case? So vascular sign of Narath is described only for abnormal pulse, not for the normal pulse. Whenever you are feeling a normal pulse on both sides, that is equal volume and intensity, then you have to tell only that pulse is normal on both sides, which is palpable, equal in volume and intensity. You should not tell that vascular sign of Narath is negative. If you're telling vascular sign of Narath, then it's automatically it means that it is positive. Okay. So from the side, we have to check for the from the lateral aspect, we have to check for the local warmth, tenderness. So tenderness can be classified here into bitrochanteric and petrochanteric tenderness. What do you mean by bitrochanteric and petrochanteric tenderness? Bi means right. Bi means both. You have to keep two hands on both sides and compress. So that is called bitrochanteric tenderness. So along this line, wherever the pathology is, it can cause pain. Petrochanteric means you are examining only the printer. So that is called petrochanteric tenderness. You have to check for the level of the GT. So by this time, you should have marked all the landmarks. So somebody can tell how to mark the landmarks. So maybe you can tell how to mark ASIS. A blue shirt, you can tell. How to mark ASIS. Okay, we have to palpate along the inguinal ligament. Yeah, good. First bony part too. Yeah, that's correct. That's correct. That's good. Yeah. So how to palpate the greater trochanter?
Palpate along the shaft of the femur.
Sorry?
Palpate along the shaft of the femur.
Palpate along the shaft of the femur.
First dip felt in.
First dip felt. So it can be told in both ways. Okay. So even for ASIs, it can be told in both ways. So palpate along the inguinal ligament, the first bony point, what you're feeling is the ASIS. You can also feel from the iliac crest. The first dip we are seeing is the ASIS. You can tell in both ways. Okay, that's good. Yeah. So how will you palpate the ischial tuberosity? Maybe he can answer.
Place the patient in lateral position.
Yeah, sure. Good.
Flex the hip and knee to 90 degree.
Yeah.
Palpate the bone most prominent.
So we have to palpate along the hamstring muscles. Okay, we have to slightly flex to some 20 degree or 30 degree, palpate along the hamstring muscles. The first bony point, what you're seeing is the ischial tuberosity. Okay. So by this time, you should have marked all the bony landmarks, whichever you wanted to draw the lines, all those things will be coming right. So you have to show to the examiner by drawing the lines. Okay. So we have to tell, by this time you might have drawn all your lines and you will be knowing what is the level of the GT. Okay. And what is the difference between thickening and broadening? Maybe you can answer. You can circulate the mic. What is the difference between thickening and broadening?
So thickening seen in APV.
Okay.
So
broadening means when you're palpating at the anteroposterior diameter of the trochanter, that will tell you the broadening. When you're palpating the lateral aspect of the femur, when you say you are having a normal on the other side, okay? Always you will be having a normal femur on the other side. You have to compare always, okay? So whenever you are feeling any abnormal things in the affected femur, in the anteroposterior diameter, if anteroposterior diameter of the trochanter is increased, then you can tell that GT is broadened, okay? Thickening means you have to palpate the lateral aspect of the femur and you have to see whether there is any irregularity. So that is the case, then you have to tell that there is a
Broadening.
okay. So from the back, you have to check for the swelling. You have to palpate for the swelling. So here, so maybe he can answer. So if you are palpating a swelling in the back, okay. So it can be either myositis ossificans or
Posterior
posterior dislocation. Yeah, good. Okay. How will you differentiate both of the things?
In posterior dislocation of moves with the movements.
Yeah, good. Okay. Yeah, that's great. Okay, good. So whenever you are palpating the femur head, if it is moving with the movement of the shaft of the femur, so that is posterior dislocation of the hip, which is whenever it's not moving, then it is in myositis ossificans. Okay. Then side we have to check for the local warmth and tenderness. Okay. So from the coming to the movements, so movements has to be always start with the fixed deformities. So you just not jump into the movements. Okay, we have to start with whether the child is having any fixed deformities, whether the child is having any fixed flexion deformity, flexion adduction, abduction, rotation deformity, rotation deformity. So what test will be doing for fixed flexion deformity?
Thomas test.
Thomas test. Good. So okay. So there are some alterations in Thomas test. Whenever there is whenever the patient is having knee flexion deformity, can you do Thomas test? No. What is the alteration for that? So we have to take
into the couch and
sorry. We have to
patient in
position is for that is called prone style test. Okay. So that is called a prone style test. That is for bilateral flexural flexion deformity. So when the patient is having associated knee flexion deformity, you have to take the patient to the edge of the table. Okay. So we have to take the child is having knee flexion deformity, right? Whenever you're taking the patient to the edge of the table, so the hip is going to extend. You're understanding, right? So that is the alteration you have to do whenever there is a hip flexion deformity in associated knee flexion deformity. So we have to tell the range of motions. So no need to tell the full range of movements. We can tell that both the things are bilateral and symmetrical. If there is any abnormality, you can tell there is short of this, more of that. You can tell all those things. And always you should finish with pain, spasm, or crepitus. So this is going to tell whether it is a synovitis or arthritis or ankylosis. Okay. So how will you tell it's a synovitis?
Patient in the position of ease, flexion, abduction,
So the
external.
patient is when you are doing range of motion. So there are some specific terms to diagnose as synovitis, arthritis, and ankylosis. So yeah, at the extreme. So whenever you are doing range of motion, whenever the patient is having pain at the extreme range of motion, okay. So suppose you are flexing the hip at 120 or 110 degree, the child is having pain, but the child is painless 0 to 110. So you can tell it's because of synovitis. Okay. So how will be the arthritic? Maybe you can pass back. Yeah. How will be the septic arthritic pain?
pain in all movements.
Even jog of motion will be having pain to the patient. Okay. So how will be the ankylosed pain? Can the sound ankylosis patient hip can have pain? The sound ankylosis hips can have one crepitus. So what do you mean by sectoral sign? What do you mean by sectoral sign? Next person can answer.
Differential load.
Yeah,
Rotation will be different.
Yeah. So so in what condition will be having sectoral sign?
Sorry. If there is any abnormality in the femoral head.
Yeah, that's what. If it is patchy involvement of the femoral head, okay. Whenever you are having a patchy involvement of the femoral head, especially pertis, okay, or AVN of the femoral head, that time you will be having sectoral sign. Okay. So this Brennan sign. Yeah, axis deviation. What is it? You can pause here. So what is adrenal sign? When you are flexing the hip joint, usually it should go to the opposite shoulder, right? That is normal. If the patient is taking to the ipsilateral hip or away from the ipsilateral hip shoulder, then that is a adrenal sign positive. Okay. So we have hip extension also. Okay. So we should not forget that. We should always check for hip extension also, especially in case of skiffy. There will be a change in the arc of motion. So they will be having decreased flexion, but they will be having high flexion of the hip joint. So never ever forget to examine the extension of the hip joint. Okay. So come to the Thomas test. These are all some basic tests you should be knowing in and out. Okay. So what are the prerequisites for doing Thomas test? So you should have a hard couch, right? You should have a hard couch for doing a Thomas test. Maybe okay. So how will you do Thomas test? So we have to keep on hand in the back of the spine, and you have to flex the opposite hip until up to the lumbar lordosis is obliterated. We should not flex beyond the lumbar lordosis is obliterated, because what will happen if you do beyond that one? You will have false positive flexion deformity, right? You are going to flex the opposite, right? Am I right? You are going to have a false positive flexion deformity, or you are going to quantify your flexion deformity more than what it is. Okay, so you should not flex the hip joint more than limitation of the lumbar lordosis. Then we have to ask the patient to hold the opposite side, hip by the patient, and we have to passively extend the hip joint. If we can able to extend fully, then there is no hypertrophy. Okay, and if we are not able to extend the hip joint, then we should measure what is hypertrophy, and we should tell to the examiner. Okay, so that is about hip hypertrophy. That's what I told you. If there is a associated knee deformity, we cannot do with the patient lying like this. We have to make the patient knees beyond the edge of the table, so that the knee will bend and the hip will extend if the hip can able to extend, and you have to measure the flexion deformity. So in case of bilateral hip FFD, we have to do Pounds-Stehley test. Okay. So for doing Pounds-Stehley test, we need two peoples. So one can be the patient attender and one can be the examiner. Okay. So we have to flex both the hip joints, and we can give one hip joint to the patient attender, and we can hold the other hip joint, and we can extend the hip joint until we see the pelvic movement is happening. Okay. When the start of pelvic movement, we have to measure the flexion deformity. Okay. So that is about stability. We can do the same thing on the other side also. We have to leave this leg down to hold by the examiner, patient, and the other hand to be held by the examiner. So that is called Pounds-Stehley test. So you should not be many of the times as a PG, I never did all these things. Okay. So I never took a goniometer and measured us. I just eyeball into. But sometimes your examiner will be trying to poke you. So that time you should not be wondering where to keep the goniometer in measuring each of the range of motion. Okay. So in case of flexion, your goniometer one arm should be parallel to the couch and other should be parallel to the femur, and your center of the thing should be at the level of trochanter. When you're doing the abduction measurement, your center should be at the level of hip joint, and one should be parallel to the patient trunk, and another should be at the level of the femur. The same thing for adduction. For rotation, you can do either in interrotation or either in hip inflection or hip in extension. So I did this with hip inflection. So the center of the goniometer will be at the center of the knee joint, and one arm is along the trunk, and another arm is along the shaft tibia. So that will be giving you rotations. So coming to the measurements. So we have to, so first we have to start with the apparent measurement, and next we have to go to the true measurement. So how to do apparent measurement? So who is holding the mic? So when you so whenever you are having objection deformity, so what will be your apparent measurement? The affected side will be long or short? Long. Good. Yeah, that's good. So you can give. So whenever you are having objection deformity, affected side will be long or short?
Short, sir.
It will be short. Yeah, good. So that is not the so for measuring the apparent deformity, so how will you measure the apparent deformity? So what is the points for measuring the apparent deformity? Yeah, it can be either sternum or sternum notch. It can be either. It should be one bony point. You're gonna take umbilicus because umbilicus is you have to take a midpoint. Okay, it can be xiphisternum, sternal notch. Umbilicus is also one central point, but that is a soft point. That's not a bony point that can change while you're measuring. So we are not taking that umbilicus. You can either take sternal notch or xiphisternum. From xiphisternum to
Middle condyle.
Okay. So from xiphisternum to medial malleolus. Okay. You have to measure on both sides and we can tell what is a LLD. Okay. So that is about apparent measurement. Okay. So coming to the true measurement. So true measurement can be breakdown into three. One is supratrochanteric, infratrochanteric, and leg measurement. Okay. So even though we tell it is a true measurement of the femur, what we are measuring is not the true measurement. So if you want to measure the true measurement of the femur, how will you measure?
You have to square the pulse. Then from
Yeah,
G
okay, that's okay.
from
So
G
true measurement of the femur is from the superior aspect of the head to the medial condyle.
joint.
That should be the true measurement, right? I mean, you are getting my point. It should be from the top of the femoral head to the medial femoral condyle. That should be the true measurement of the femur. But you cannot do that in this case because you don't know where is the superior aspect of the femoral head. So that's why you are taking a surrogate of Bryan's triangle in this case. Okay, supratrochanteric shortening, you're understanding, right? So the femoral length, you are breaking down into supratrochanteric and infratrochanteric. Okay, and tibia, it will be this. You are having the bony landmark for tibia, the medial joint line to the most prominent point of the medial malleolus. Is it? Am I right? Am I right? Yeah. Okay, good. So that's what. If there is any pathology in the neck, so it will be a supratrochanteric shortening. If there is any pathology in the femur, it will be infratrochanteric shortening. Okay. If people are following or okay. So there can also be a shortening from the foot also. Okay. So whenever there is a fibula hemimelia, tibia hemimelia, where we will be seeing there is an absence of the talus or coalition of the talocalcaneal joint. So in that case, this measurement is going to give a wrong measurement. So the good way to measure this by doing a block method. So we have to build blocks below the leg and we have to see for the bilateral ASIS at what point of block the ASI is at the same level. So that is the LD the patient is having. Okay. And then you can break down into whatever the level. Okay. So for hip case, you can break down into supratrochanteric, infratrochanteric, tibia, and the fourth one is foot. Okay, if you want to measure the foot, you can measure the foot also if you are suspecting some pathology. Okay, and we have to do a circumferential measurement. So how will you draw the Bryan's triangle? Maybe he can tell. How will you draw the Bryan's triangle?
Sir, making a 2 point, one at greater trochanter and another at anterior iliac spine, and you joining both this point and draw a perpendicular line from the anterior iliac spine towards the couch, and joining these two line, it's canvas abyss.
Okay. So first of all, you should mark the point correctly. Okay, that is the most important thing. So sometimes you will be not correlating with your findings and some problems can happen. So you have to spend your good amount of time in marking the points. Okay. So after marking the points, you're just going to connect everything. Okay. And you're going to get the values. Okay. It's like doing a study. So your data collection should be very like that. So your marking the point should be very important for doing these measurements. Okay. So as he told, so the first line should be connecting the tip of the GT to the ASIS, and the second line will be from ASIS on perpendicular drain, and the third line will be from tip of the GT horizontal to the floor. Okay, so that is about Bryant's triangle. Will the Bryant's triangle help in bilateral hip case? Okay, it will be helping right in bilateral hip case. So what is called the reverse Bryant's triangle? Maybe whoever is holding the mic can answer it. What is the reverse Bryant's triangle? It can be reversed in some cases. What is the case?
More superior migration.
Yeah, good. So whenever there is an unstable hip, like dislocation or proceptic sequelae without head, the greater trochanter will be migrated so far from the ASIS. So you have to draw the triangle in the other way. So coming to the circumferential measurement. So how will you measure the thigh growth? In median joint line, you have to take 10 centimeter equally on both sides, and you have to measure the circumferential measurement. So why are you taking 10 centimeter? Why can't you take 15 centimeter, 20 centimeter?
Synovial hypertrophy.
Synovial hypertrophy. Okay, maybe some other person can answer. So vastus medialis obliquus is the first muscle which is going to atrophy, right? Among the quadriceps, vastus medialis obliquus is most muscular in the distal portion of the thigh. So that is why you are taking distal third of the thigh. You can also measure in the proximal third, but you have to identify whether there is any muscle wasting or not. Okay, whether the thigh has started for muscle wasting. And for the tibia and for the calf, you have to see whichever is the maximum girth, you have to do it on the other side as the same level from the medial knee joint. So I told you, so you answered right. So Bryant's triangle is not useful in bilateral case. Okay. So these are all some of the alternatives for Bryant's triangle. Okay. So shoemaker's line. So can somebody can tell how to do a shoemaker line?
From GT.
Yeah.
To connecting ASIS and along the opposite side of the.
Yeah, we have to continue the line medially. Okay. So from the tip of the GT to the ASIS, and we have to connect and we have to continue the line straight medially. Okay. We have to do it on the both sides. So what is normal?
It should intersect at the umbilicus, above the umbilicus.
At or above the level of umbilicus. Okay. So if it is below the level of umbilicus, then we can tell there is what is it interfering?
Short.
It is a GT overriding. Okay. If it is on both sides, then on both sides it will be below the level of umbilicus. So sometimes it is not useful in obese patient, and when there is a umbilical surgery or something is done for the umbilicus, so we cannot rely on these things. So what is Cheney's line?
GT to GT.
Yeah. Maybe the other person can answer. Yeah.
Sir, it is from the ASIS to both the opposite sides, and
you have to connect both the ASIS
and the tip of the GT.
Tip of the GT.
Usually it should be parallel.
Yeah, usually it should be parallel. If it is converging on one side, then we can tell that the affected side has superior overriding. So mostly it will be done for, it will be useful for unilateral cases. Okay. Shoemaker line is useful for bilateral cases. Okay. Bilateral hip pathology. So what is Nelton's line?
Sir, so the ischial tuberosity.
Yeah, good.
The ASIS
yeah.
is marked, and the line crosses the tip of the greater trochanter.
Yeah.
If the line GT is above, then it is superior migration.
On both sides similarly. Okay. So this will also help in bilateral cases. Okay. The tip of the GT, we have to mark 3 points. Tip of the GT, ASIS, and ischial tuberosity. We have to connect ischial tuberosity to the ASIS. We have to see at what level of the trochanter the line is passing. If the line is passing at or above the level of trochanter, then it is normal. If it is passing below the level of trochanter, then it is abnormal. Okay. What is this? Kothari's parallelogram. That's all, sir. Some 10 minutes, sir. Kothari's parallelogram. Okay, this will be useful for unilateral cases. Okay. So we have to, first of all, it can be done in unsquared pelvis. We have to connect both the ASIS and one line along the center. Okay. and we have to pass a perpendicular in both the ASIs. So this will be giving your abduction deformity. Okay, that is quadratic in the indirect way of measuring the abduction deformity. So coming to the special test, Trendelenburg test. So the prerequisite for doing a Trendelenburg test is the patient should be able to stand for at least 30 seconds and there should not be no fixed coronal plane deformity. Then only you should do this test. Otherwise, if you cannot able to do this, then we can tell the Trendelenburg test cannot be done with this patient. So if the patient cannot able to stand for 30 seconds, then we can do an assistant Trendelenburg test. Okay. And telescopic test and Barlow test. So Trendelenburg test will be positive whenever there is a problem in the lever arm, fulcrum or power. Okay. So in either of the mechanism, if there is a in that case, even though there is any, even whenever it will be useful for telling instability. Okay. So in telescopic test, we have to keep the hip in 10 or 20 with a 90-degree flexion, 4 fingers at the level of the greater trochanter. We have to do a anteroposterior compression. Okay. If we are feeling some laxity, we have to compare on the other side. You can tell it's a positive. Autonomy and Barlow. Barlow should not. That is, we are dislocating. Barlow is dislocating the located hip and locating the dislocated hip. Okay. So other special tests are Galeazzi test or one knees at lower level and another knees at the higher level. It can tell that the femur is short on the side. So coming to gait. The gait can be told in it. Okay. So everybody can contribute in this. So can somebody tell what is the gait? Who is holding the mic? You can answer. It's easy. The patient is stands, right? The patient is having short stance on the left side. Weight bearing on the right side. What is happening to the other ASIs? So when the patient is weight bearing on the right side, the left ASIS is dropping down. So this is Trendelenburg gait. Okay. Whenever Trendelenburg is positive, it's unstable. Okay. So it's an unstable bilateral unassisted Trendelenburg gait. So you can tell what is his gait. The left side is affected. The left side is affected. So what is this? Short limb gait. Good. Whenever the patient is weight bearing on the affected side, the other side pelvis is not dropping. Only the shoulder is moving up and down. It is a short limb gait. So it's a bipedal unassisted short limb gait. Okay. So what is this gait? So just watch the left. Yeah. What is it? Circumflexion. Good. The child is having cortices. The child is having cortices fibrosis. So the child is walking in circumflexion. Okay. This will be okay. You can answer if you. What is a child keeping? Where is a child keeping the hand? Yeah, the child is basically having myopathy. Okay, proximal myopathy. So the child is stabilizing the knee from buckling. Okay, the child. This is called hand to knee gait. Okay, so stable unassisted myopathy gait. Okay. So what is this? Yeah, gait. How will you define crouch gait? So the hip, knee, and ankle. The hip and knee flexed throughout the stand phase. and uncle is dorsiflex through the giant space. So that is called crouch gait. Okay, it's a stable paper and a crouch gait. So what is this? The child is not having valgus thrust, but the child is having valgus. Okay. What is this gait? Varus thrust gait, right? Varus thrust. When the child is weight bearing, there is a jerk happening at the level of the knee joint, so the lateral joint is opening. So that is a unassisted varus thrust gait. So this is very easy. What is this? Yeah, high stepping. The child is having, actually the child is MMC child, the child is having full drop. The child is having high stepping gait. Okay. So we should not forget to examine the other joints like sacroiliac joint, lumbar spine, contralateral hip, ipsilateral knee, ipsilateral ankle, and we have to check for the neurovascular bundle and lymphadenopathy. The hip joint is drained by deep inguinal lymph nodes, okay, and also by the iliac lymph nodes. So the test for sacral joints are Patrick test and Ganslin test, okay. So it can be, whenever there is a hip joint pathology, sometimes the patient can have pain while doing this test. So we have to be very careful before performing this test. So we have to tell about the final diagnosis. Finally, what is your pathological diagnosis and what is your anatomical diagnosis? Okay. Okay, I'm done with it.
Yeah, it's a good presentation. I thank Dr. Almurugan for giving a wonderful, useful presentation for the postgraduates. So I think you have demonstrated also, no? We'll have a short case in that you can say anything next time. Thank you for that. Wonderful.
Thank you, sir. I request Professor Anthony Vimalraj, sir, to come up on stage and felicitate the speaker. Thank you. Next session, we have a long case presentation by Dr. Prabhakaran, final year postgraduate in Madras Medical College.
Hi, from Thomas. Yeah. Hello to Thomas from my side. Cover him up. Cover him. Very good.
Hello. Good morning. Good morning. Hello.
ஏசி ஆஃப் பண்ண முடியாது. ஆஃப் பண்ண முடியாது. கஷ்டப்படுறான். குளிர்துறான். அப்புறம் கோஆபரேட் பண்ணு. கொஞ்ச நேரம் வெளியே குறைச்சிட்டேன். உள்ளே குறைச்சிட்டேன். இல்லை நீங்க வெளியில இருந்திருக்கலாம். கரெக்டா உள்ள கொண்டு சொல்லு. பேண்ட் ஏதாவது போடுறியா? டவல் டவல் பேண்ட் போடு. பேண்ட் போடு. நீங்க தான் பேண்ட்டுங்க. blankets கொண்டா பாருங்க. உட்காந்து.
Good morning, sir. I'm presenting a hip case. Kalai Chelvan, 5-year-old male child from Chennai. Informer's mother and reliability is good. Came with complaints of limping for the past 6 months and history of presenting illness. Initially, the limping was noted by the relatives when the child started to walk, and it was ignored by the parents. And followed by that, parents viewed it seriously. Patient came with chief complaints of limping for the past 6 months and history of presenting illness. Initially, limping was noted by the relatives at the time of patient started to walk, but it was ignored by the mother, parents, and followed by limping was serious for the past 6 months by the parents. And limping was non-progressive, painless, and patient was able to walk without any aids. No restriction of functional activities. Patient is able to walk upstairs, downstairs, able to fully squat and cross leg without any restriction. And patient has no complaints of swelling and stiffness. Has history of shortening present, sir. And no history of trauma, no history of evening rise of temperature, no history of fever, and no history of chest pain, breathlessness, and cough. No history of redness of eyes, burn, maturation, and no history of soreness of throat. No history of multiple joint pain and swelling, no history of spontaneous bleeding, and no history of spontaneous swelling in any joints present. And birth history. No, sir.
You said the limp was noted as soon as he started walking.
Walking.
When did he walk? Was it a late?
No, sir.
No.
Milestones were normal, sir. And patient was started to walk at the age of 15 months, sir.
Yeah. So when the patient started walking at 15 months, the mother noticed a limp, painless limp.
Birth history. Patient is a preterm child, born at 36 of gestation. Through a local occasion, the baby did not cry immediately after the birth. Postnatally, patient was on NICU admission for the 2 months, and at the 45th day, patient had undergone surgery for breathing difficulty in the left side chest region, sir. And postnatal, after that, there was no similar complaints present. Family history. Patient has a sibling which is normal.
No.
Yes, sir. All the developmental milestones were adequate for up to the age in all the 4 domains, sir. And
physical.
Yes, sir. Patient was on ventilator for the 2 months.
Intubated for 2 months.
Sir.
Okay, intubated for 2 months.
2 months. Family history and no significant family history. Patient has an elder sibling, she is normal, and no similar complaints present, and no relevant past history present. And
when did the mother notice the limping?
So the relatives, initially the relatives noted the limping at the walking age, sir, but parents ignored it, sir.
Walking age.
Walking age, started to walk
when he started walking.
Yes, sir. but parents ignored it initially. For the past 6 months, viewing it seriously. So they came now. Sir.
So it is not progressive.
No, sir.
So why the parents took it more seriously for the past 6 months? Any particular reason?
The patient has complaints sometimes of long pain after
that's what I'm asking. Okay.
long standing play after a long duration of playing.
So till 6 months back, he was painless.
Painless.
Now he's complaining of some pain.
Pain after playing, only playing, sir.
Okay.
To summarize, a 5-year-old male child with painless limb and with the shortening present, probably a unilateral hip pathology with due to congenital etiology, congenital or developmental etiology.
How do you say from the history without examining that it is unilateral hip pathology?
Patient has complaints of shortening in the left hip. Left
can come from limbs from anywhere, no? How do you say it is from hip?
You shouldn't be very sure about that, because see, there are many other reasons. See, based on your history, what are the things you thought about? Okay, it could be a hip pathology. What are the other possibilities?
So any diagnosis?
Not the diagnosis. See, what are the problems which came? What are the possibilities?
There
is usually history of ICU admission, respiratory distress, and admitted and intubated.
Any infection?
Yeah, very good. One is infection. Anything else? Mental dysplasia.
So it could be a developmental problem. It could be a sequelae of infection. Okay. So you said there was a respiratory insufficiency. Okay. So whether it could be any other, even hypoxic insult to the brain. So, okay. So you should not narrow it down to one pathology based on a history alone. Okay. So you should probably it could be a hip pathology, but there are various other causes. It could be a neuromuscular condition. You're clear?
Yes.
So even in a neuromuscular condition, you can have a shortening of the affected side.
Some pathology related to infection. Okay. So how will you tell that? So the child will be having some pain, swelling, and restriction of movement. Okay, whenever there is a hip infection. Okay, so in this case, how will you justify? They ignore that hip, right? You are suspecting some hip pathology, but they didn't find that there is a infection if it is a post-septic. Okay, so what is the justification you're going to give now?
So patient had not take any treatment at the time, so no any history of medication.
Actually, the child is intubated for 2 months, right? So nobody might have noted that there is a hip septic arthritis, and also the child might be on continuous IV antibiotics during that time. So whatever the infection it is there, that might have resolved by IV antibiotics without our intervention. So that is one possibility of having a hip septic arthritis that is ignored due to the child is intubated for prolonged duration.
General examination. Baby is alert, active, and obeying to commands, and no pallor, icterus, sinuses, clubbing, and lymphadenopathy. On head-to-toe examination, the neurocutaneous markers are absent, no generalized ligamentous laxity, and arm span to height ratio is normal, and upper segment to lower segment ratio is normal. On local examination, patient was examined on standing, supine, and sitting position. Head in center, shoulder at same level, and no scoliosis, and no exaggerated lumbar lordosis present, and bilateral anterior superior relaxation at same level. On sitting, the left knee is posterior and proximal to the right knee sitting position, and on supine position, bilateral anterior superior is same level, and an attitude hip in neutral, knee in extension and externally rotated compared to the opposite side, and ankle in equinus position, sir.
Also, is facing
outwards, outwards towards the wall of the room, sir. An examination proper. Patient was examined on inspection. No exaggerated lumbar lordosis present, bilateral anterior superior relaxation same level. On anterior aspect, there is no fullness present and no scar, sinuses, dilated veins present, and a bilateral femoral, and the lateral aspect, there is obliteration of supratrochanteric hollowness present, and greater trochanter is comparative to opposite side more proximally seen, sir. And no dilated veins, scar and sinuses, and posterior aspect there is no fullness visible and no dilated veins, scar and sinuses. On palpation, the inspectory findings are confirmed.
What about the shortening?
On attitude,
Shortening.
and attitude there is a shortening.
Short.
Attitude there is a shortening of left lower limb and muscle wasting present in the both thigh segment and the calf segments.
How does he stand? With equinus of the ankle or with both feet plantigrade?
Equinus, sir.
So you have to say that in your attitude also. Did you say that?
Yes.
You did. Okay, fine.
Also, whenever you're seeing from the back, you should see for the gluteal fold. Okay, is it symmetrical or asymmetrical? Okay, if it is asymmetrical, then there is something going on. Usually there will be gluteal atrophy. So that will be having asymmetrical gluteal fold from posterior. Okay.
And the other thing is there is nothing called the supratrochanteric hollow. You can just say that the greater trochanter appears prominent. Normally we don't have hollows there.
Palpation, inspectory findings are confirmed. No exaggerated lumbar lordosis present and bilateral anti-superior iliac spine at same level. On anterior aspect, the tenderness present in the base of the Scarpa's triangle and no warmth, and bilateral femoral pulses are felt equally. And on the lateral aspect, there is a petrochantric tenderness absent, bitrochantric tenderness present, no warmth, and trochanter is smooth and proximally and posteriorly migrated compared to the opposite side, and there is broadening present and no thickening present, sir.
How do you say it is proximally and posteriorly migrated?
Comparing trochanter is more comparing opposite side, it is more proximal, and trochanter is felt more posteriorly.
Actually, there is one measurement. There is one measurement for that what Sari is telling.
Just to summarize, you said the GT is gone up. The tip of the greater trochanter is proximally migrated.
Yes.
There is broadening of the trochanteric region.
Yes.
And tenderness also.
Tenderness present in the base of the Scarpa's triangle, sir. And bitrochantric tenderness is present, and anteriorly base of the Scarpa's triangle tenderness present.
So nowhere in the history we elicited pain as a history, but you're finding tenderness, which is unusual.
Yes, sir. In his history,
or many people have examined him one after the other. Is that the reason? So where does he have tenderness? In the Scarpa's triangle also?
Yes, sir.
Great trochanter also?
Yes.
Both?
No, sir. Bitrochantric tenderness present, sir.
Bitrochantric. So it's limited to the hip joint?
Yes.
Okay.
On palpation, posterior aspect, there is no palpable mass present and no SI joint tenderness present, and no SI joint tenderness present. Then on movements, bilateral femoral pulse felt equally.
No, you said trochanter is broadened, but it's not thickened. Any information you want to give?
Anteroposteriorly, it was there was the broadening, sir. No, medial-laterally there was. I was not able to elicit anything.
That means it is more.
It was more posteriorly
moved.
So you are not telling about the medial side. Okay, how is the medial adductors? How is the medial skin? Is there any sinus discharge? Anything is happening in the medial side?
Normal, sir.
Yeah, you should tell about that thing. Okay. Sometimes you will miss something happening there. There can be a discharging sinus. Okay, in case of TB hip, that you will miss. It can be a scar, puckered scar, which will be there. That you will miss. Okay. So always see the medial joint, medial aspect of the hip joint. Okay.
Movements, there is no fixed.
Sometimes adductor tightness also may be there. Yes. In pediatric age, it's also very important. It's always better to look on the middle side.
Movements, there is no fixed deformities. Flexion of 0 to 130, 130 degree is present and associated with the pain from 70 to 130 degree and associated with spasm present, sir. And abduction 0 to 10 degree and adduction 0 to 60 degree present. And in extension, external rotation from 0 to 50 degree, internal rotation is not possible. And in flexion, internal rotation comes from 0 to 10 degree and an rotation 0 to 45 degree present, sir.
Just repeat it. It's too fast for me.
Adduction to flexion 0 to 130 degree present, sir. Associated with pain, sir. extension 0 to 10 degree present, sir. Then adduction and abduction. Abduction was 0 to 10 degree and adduction 0 to 50 degrees, sir.
Adduction is 0 to 50, abduction is 0
0
to
to 10 degrees.
Okay.
There was abduction restriction, and in internal rotation restriction was there. An extension, internal rotation was not possible. External rotation from 0 to 50 degrees possible, sir.
Internal rotation in extension is 0.
Not possible, sir.
0.
0,
but,
sir.
But there is no rotational deformity.
Yes, sir.
There is no rotational
yes, sir.
deformity. On flexion, what happens?
Internal rotation 0 to 10 degrees is possible, sir.
It increases on flexion.
Yes, sir.
Ah.
And external rotation from 0 to 45 degree present, sir. Measurements, there was apparent shortening of 3 centimeter present and true shortening of 2 centimeter present. It was confined to supratrochanteric region. The base of the Bryan's triangle substantiated the 2 centimeter true shortening, sir.
Why is the max not correct?
Shortening was
3, sir. 3 centimeters.
What is the reason for the difference between both?
When do you get a difference in that case?
Sir, there is no fixed deformities in the hip.
No deformity.
Why there is a difference?
Was no, but no adduction deformity was not there, sir.
When you get into trouble in the exams, you have to be very careful. Okay, so because you are making a point saying that apparent shortening is more than the true shortening. So you should have rechecked it again and again.
So 0.75 to 1 centimeter there was apparent shortening was there.
Well, how do you explain that?
The true shortening is where? Femoral,
Supratrochanteric area, sir. Femoral and tibia is equal, sir.
Can you think of a reason?
Probably femur segment I could have missed.
You made a mistake, you're saying. You're already you're confessing.
Femur, there was a shortening in femur segment, it could have.
You said there is a thickening, everything in the trochanter, no? The reason, because supratrochanteric region will.
But still, just imagine between true and apparent, what is the difference? You're taking the tape from the ASIs and putting it in the umbilicus. That is the only difference you're doing. Apart from obviously getting the leg, squaring the pelvis, which is not relevant here because the pelvis is square.
0.7.
What has changed in these 2 points? Sometimes if the tip of the GT is overgrown, you might get a difference in the Bryan's. Okay. Very counterintuitively, if you find there is shortening, but there is a GT overgrowth, some conditions do cause that. Then you can get a shortening of the Bryan without actually a true shortening, because the GT actually has migrated up and not the entire supratrochanteric femur. That possibility is there. But like sir said, no, these are death holes. These are difficult territory. Yes. That's the question, sir. We are trying to asking here. Here also
Bryan's triangle measurement is from the tip of trochanter to the base of the Bryan's triangle. The tip of trochanter is overgrown. So that is why the true shortening becomes less compared to the apparent.
But then only supratrochanteric part should change. You know, suppose you measure from ASIS to medial malleolus, that difference should not occur. So just imagine a case where the supratrochanteric area is equal, but for some reason the GT is higher on this side. The limb length will not change, but the Bryan's will change. Are you getting what I'm saying?
You measure the true measurement of the femur and tibia, no?
But here's
Then what's the difference?
That is not compatible.
Also difference is there?
I think yesterday somebody said it very wisely. I think Singaravaadivalu sir only said it very wisely. Some things you must, I think Naveen said it yesterday. It's a game and you must know how to play it, isn't it? I want to say anything further.
Special test, telescopy test negative, and Trendelenburg test positive, and Shoemaker's line, it crosses opposite and below the umbilicus. Cheney's line converging on the left side, and Nelton's line, the greater trochanter is above the line, sir. On spine examination normal, no distal neurovascular deficit present.
Can you demonstrate the Trendelenburg test alone?
You can put him on top or bring him sideways.
சட்டையை கழட்டிக்கிறியா? சட்டையை கழட்டிக்கிறியா? ஷர்ட்.
Come this side. Bring him here to the center, please. Yeah, bring him here. It's for your colleagues to see. Yeah, keep him turned like that. Watch him.
கழட்டியப்பா.
So if there's shortening, what should you do in Trenelberg? There is obvious shortening here.
Assisted.
Not necessarily. If there's shortening, why should you do an? The assisted Trenelberg is if you cannot stand for 30 seconds. If there is significant shortening, what should you do? You should compensate the shortening. You should put some block or some wear a footwear on that side. Okay. The shortening must be because with shortening itself, you will get a dip. You will get a dip. Yeah, let's see.
இந்த கால் இருக்குல்ல, இந்த காலில் வச்சு நில்லு, இந்த காலை தூக்கிக்கோ, இந்த காலை தூக்கிக்கோடா, இந்த காலை தூக்கிக்கோ. நெல் விட்டுறாங்க. இப்ப இந்த காலை வச்சுட்டு இந்த காலை நில்லு. நெல்
Actually, it's tilting the body, sir. Yeah, it's
கை பிடிச்சுக்கோ.
tilting by. Why is tilting the body?
What's your word?
Positive or negative? Positive. So we agree with that. Majority means we have put a dress on him.
Why is tilting the trunk?
Towards the affected side, patient will lurch.
Why is tilting the trunk now?
Reduce joint reaction force. The same side lurch will be there.
He is shifting the center of gravity. He is shifting the body weight to the other side.
Gait unstable.
One more thing. Suppose now you have examined the child for 10 seconds, right? Okay. So what are the things to say that Trenelberg test is positive? So suppose now you are seeing at the first insert, you are telling that the opposite pelvis is dropping. So you are telling it's positive. Suppose it's a synovitis, the child can able to stand for some time. The child is standing on the affected side and now the pelvis is lifting. Within 30 seconds, the pelvis is dropping. Is it positive or negative? That is also Trenelberg positive. We should ask the patient to stand for at least 30 seconds. So that is why the criteria for doing a Trenelberg test, at least 30 seconds, the child should be standing. Okay. So there are some gradings of doing a Trenelberg test with 30-degree flexion and 90-degree flexion. And we have to ask the patient to lift the pelvis on the other side by using the other muscles. Okay. So in spite of doing all those things, if the patient couldn't be able to withhold the pelvis up for 30 seconds, then it's positive. Okay. It's not just that instance of thing. Okay. So you should know that.
Gait unstable, unassisted, bipedal, Trenelberg gait present, sir. Morning class.
No, you tell us. You can't say in the exam, no, morning class. You have to tell the reason why you said it's an unstable gait.
Patient was not able to maintain the center of gravity, sir. So.
Okay, we have a Trenelberg gait is a simple question.
Yes, sir.
An example of an unstable gait.
But you said the telescopy test was negative.
Yes. Telescope test negative.
Trenelberg gait, gait.
I mean, for the audience, can you just describe what you mean by the Trenelberg gait? Now he's got a pathology on the left side, correct?
Yes, sir.
Huh?
Opposite side sags down, sir. On when the patient on affect.
That is the Trenelberg test.
Yes.
Now we are asking what's the gait. Trenelberg gait. What's the gait? Trenelberg gait. 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 Trenelberg gait
when the patient affected when the affected leg is on stance phase, the opposite leg, opposite pelvis drops down, sir.
And the body lurches to
Body lurches to the same affected side, sir.
bring the center of gravity to that limb so that it enables the child to walk. Okay.
But gate, the body will shift towards the same side.
Same side, affected.
Shift the center of gravity to the same side to prevent the fall.
Fall from opposite. Distal, there is no distal neurovascular deficit and no palpable lymph nodes. Spine examination normal. Ipsilateral knee and contralateral hip examination normal, sir.
So summarize your findings.
A 5-year-old male child with chief complaints of limping, shortening present. On examination, had no fixed deformities. Patient had
Important history. You have to tell the important history also. No, he had a prematurity, ICU admission. Surgery was done. He was in ICU for 2 months. No, so it is very important history as far as the children are concerned.
On history, patient had limping and shortening present. On patient was a preterm born with postnatally patient was on 2 months NICU and history of surgery done at the end of 45 days for respiratory difficulty, and patient had normal developmental milestones as well as initially limping was noted at when the patient started to walk, sir. On examination, there was no fixed deformities. There was restriction of internal rotation and abduction with exaggeration of adduction and external rotation present, and true supratrochanteric shortening of 2 centimeter present. So probably.
What is your anatomical diagnosis? What is your etiological diagnosis?
The exaggeration, you're saying you compared with the opposite side.
Yes, sir.
But you didn't tell us in the findings. Okay. So remember that. Okay. Another thing is important, this child, because a preterm child, okay, it's important because the left side is affected. It's important you do a neurological examination of the left upper limb to rule out which condition.
Cerebral palsy.
No?
Cerebral palsy.
Whether it's a spastic hemiparesis, you understand. So you have to do a neurological examination of the left upper limb. It's very important. Okay.
Diagnosis would be coxa vara.
So you examine the right hip. And did you compare the movements?
Yes.
Okay, you feel it is exaggerated. Adduction and
adduction and external rotation
is exaggerated. Okay.
Anatomical diagnosis would be coxa vara. For pathological diagnosis, I would like to give differential diagnosis probably due to developmental etiology, and second one is Perthes disease. Perthes disease because patient had complaints of pain in the base of Karpat's triangle for the past 6 months.
You said the limping is noted when the child started walking. Yes. So why do you want to say Perthes disease?
First diagnosed developmental coxa vara, sir.
Developmental coxa vara. When do you note the limping in developmental coxa vara?
When the patient starts to walk.
No. You don't see limping when the patient started walking. Usually it's limping is noted later. Maybe around the 4 years or 5 years only, we will see limping in a developmental coxa vara.
Congenital coxa vara.
Congenital coxa vara. Anything? You said the important history of prematurity, admitted in NICU, all these things.
I think what else?
Developmental dysplasia of hip.
Developmental dysplasia.
See, you're jumping.
Post-septic sequelae.
There's of infection.
So most probably we'll think of some septic sequelae of hip. Can the septic sequelae can present like this?
Yes, sir.
What are the post-septic sequelae of the hips?
What are the
possibilities of post-septic sequelae?
Perthes.
No,
I'm talking about
type.
Septic sequelae.
Anatomically, you tell. Yeah, post-septic sequelae can be what form? Either can be
coxa vara, unstable, dislocated, subluxed or dislocated hip.
So can you fix a post-septic problem?
Ankylosis.
Ankylosis, very good.
Yes.
Bony or fibrous ankylosis. Get ankylosis in the newborn child. You get ankylosis after septic arthritis in a newborn. Why?
Cartilage.
Cartilages. What do you call that arthritis?
Tom Smith arthritis.
Tom Smith.
I think in your Arul, in your hip types we had done, even yesterday, I remember Professor had presented, we said ankylosed hip, coxa vara, synovitis. I think we must also include hypermobile hip, where where it occurs due to septic arthritis, or sometimes even some neurological disorders, paralytic disorders, you find the hip moves more than normal. So there is another variety, including all the coxa vara, the synovitis, arthritis hip. There is also the hypermobile hip without any fixed deformities. That is also an entity.
The dislocation or subluxation with no exaggeration of movements. Scopy test was negative, sir. So I ruled out.
And why do you want to say developmental dislocation of hip?
Or DDH.
No, your DDs should be very precise. No, you should not tell all the available DDs. You are telling developmental dysplasia, telling Perthes disease. These are all the things should not come here.
How would you explain your thickening, broadening of trochanter and tenderness?
When there is a medial epiphyseal arrest, the greater trochanter growth in there, greater trochanter epiphysis would have.
Sir is asking about thickening, broadening.
Yes. Greater trochanter overgrowth would be had.
The infection happens only in the joint. Any other infection?
No, location.
No. Location of it.
Can it be like instead of a septic, I mean, along with the septic arthritis, also an osteomyelitis of the proximal femur? That could probably explain your thickening regularity. But the tenderness, I'm not very sure why it is occurring. Yeah, what will you do now?
Usually infection of the neonatal period, not only in the joint, it can be originate from the proximal femur also. So the telltale evidence will be there always. You have to think in the possibilities in mind. Okay. That's what Sir is explaining.
I want to revise the diagnosis. It is
Congenital coxa vara, probably to congenital etiology.
Congenital.
Oh, see, see, when you make a
congenital.
Pointers are that way. You may be wrong. It may be congenital. At least you must have that possibility.
The diagnosis always you must say from your clinical findings. You must say from your what is the listing from the history. Maybe X-ray will be wrong. We'll see some other diagnosis in the X-ray. But what is you are arriving from the clinical history and examination? You have to correlate everything and tell the diagnosis.
One more clue. Most of the time, you should get a very vague findings and presentation is also not very clear. Mostly it will be a septic related only because that is very fast and more destructive. The changes will be not fitting to any of the category. So in that case, with all these features, better to stick to sepsis.
Any children with prematurity, low birth weight going into the ICU, first thing you would think of infection.
So you can boldly say that anatomical diagnosis left coxa vara. I feel that it is a supposed septic sequelae. That will be your first diagnosis in this child.
Yes.
Anybody from the crowd?
The classification. You start seeing the X-ray.
Do you know any post-septic sequelae classification? Any named classification?
TK Shanmugasundaram sir classification.
That is for tuberculosis, man.
Tuberculosis.
Post-septic, it's not tuberculosis.
Even from our Indian perspective,
One Indian famous doctor has also classified, one Chinese doctor is classified.
What will you do?
Can you see the X-ray?
Take an X-rays.
You can send the child out.
Very could it be?
Then it was not a couple of days before.
X-ray of a immature child showing the pelvis and with bilateral hip joint. There is a decreased neck shaft angle, and if facial region there is a.
How do you say there's a decrease in neck shaft angle? You don't see a neck at all, hardly. So first you tell the obvious findings first, So your diagnosis may be Coxa-Vara, okay. But you tell us what are the obvious findings first?
That's a neck resorption is present, and
So
trochanter is proximally
discontinuity in the
migrated.
neck. Okay, next. What about the lines, other sentence line?
Sentence line is broken, sir.
Oh.
And greater trochanter is proximally migrated.
Sentence line, I don't think it's broken. No? It looks continuous for me. Okay, carry on. Just describe about what all the bone you palpated, no? GT.
You should not tell like that. You should know the landmark and
From pubic along the
inferior border of
superior pubic ramus, and along the neck of femur and towards the shaft of femur.
Yeah.
Which X-ray you will comment about sentence line? Any X-ray can you comment about the sentence line? You want any specific X-rays?
X-ray.
I am saying that I can't comment about this sentence line in this X-ray. Traction X-ray. Why?
Internal rotation.
Internal rotation. We need an internal rotation view to comment about that. We don't know whether it's taken internal rotation or not. What has happened to the proximal femur, trochanter, neck? You are able to see the physis. What has happened to the head? What has happened to acetabulum, thyroid cartilage? You may.
There's a acetabular. It's a head.
Just compare with the normal side. Acetabulum is normal or it is shallow?
Shallow, sir.
Okay.
Acetabulum is shallow. Head is head.
What happened to the physis? The head is larger or smaller? I am giving a clue.
Larger.
It is slightly larger. Okay. Can you be able to see the physis?
The physis is more vertically oriented compared to the.
No, I'm not able to see the physis in this X-ray. So what has happened to the neck?
Decreased neck shaft angle.
Oh, no. What has happened to the neck?
Neck resorption is there, sir.
Is neck length is normal?
No, sir.
What do you call the neck length is short? What do you call that condition? Any name for that?
Proximal. Proximal femoral.
No. The neck of the proximal femur is short.
Coxa breva.
Coxa breva. What is the normal neck length? Do you know what is the normal neck length? No. It is 1 head diameter. 1 head diameter. Then what do you see in the neck?
The resorption of neck is there, sir.
Look like some radiolucent line is seen with irregular newborn. Trochanter GT.
Proximally migrated, and there is the thickening presence, sir.
It's called broader.
Acetabulum shallow, sir.
So the acetabular neck is slightly more on the left side when you compare it to the right side. Okay, so you should know what is the. Okay, you have a shortening of the in the femoral migrated. The trochanter, triradiate cartilage, and all looks so. There is some shallow and cells increase from the left side. Okay. So, what is your diagnosis final after seeing the X-ray?
You want any other view? You want only one? The lateral. What has happened to the
facial separation is there. Facial separation is there, sir.
Facial separation. And you want to revise your diagnosis? Huh?
Thank you.
What is the version? Just come. It is antiverted or retroverted?
Retroverted. Preoperative planning will be done, sir.
Does it,
To see the next
control or you want to revise your diagnosis, pathological?
I will take an MRI.
Why?
Your diagnosis was post-septic sequelae. The diagnosis was post-septic sequelae, coxa vara. Don't you think it fits in?
Yes.
Huh. So you say that, answer that question. I think it looks like a post. They're all also features of probably a proximal physis growth arrest also in the future you will see because of a short neck. Okay. What will you do?
Valgus osteotomy. I will see neck shaft. I will see the neck shaft angle, sir, and Hilfrener and epiphyseal angle. If it is more than
The AP again.
Put the AP X-ray again.
valgus osteotomy,
Distal femur.
intertrochanteric regions.
Yeah, you would do a subtrochanteric valgus osteotomy. What is the purpose?
To first to establish dysplasia is also there, sir, for the containment of the
No, it is exactly the opposite.
shearing force.
What is the neck shaft angle? And if you do a valgus, what will happen?
Shearing force will decrease, sir.
There is no shearing force.
The vertical physeal line is present, sir. So we'll convert the vertical into more horizontally.
Why is it not? Is it a non-union neck femur? There is a coxa vara. We are correcting it by doing a valgus osteotomy. What will be the good effect after doing coxa valgus osteotomy? The neck shaft angle will improve. The shortening will marginally improve. Agreed. And actually the GT also will become a little down. So the abductors become stronger. What is the negative thing about it? In this case, in this particular case?
Increasing the grade.
When you are correcting into valgus osteotomy, no, will that produce any complication?
You said that the acetabulum is shallow. It is shallow is not the word you use.
Subluxation.
It will
subluxate.
Subluxate out. So how you need to address that also. Already you have a large head and a shallow acetabulum. Now you're putting this into valgus. So you're going to uncover more of the head and slip it out, isn't it? How will you address that?
Pelvic osteotomy is
need to do some
shelf osteotomy or
you need to do some improve acetabular
coverage.
Either by a Dega or a Pemberton, whatever. Pemberton probably is not a good idea here because of head is large.
Age, yeah, more than 5 years, so we'll probably go shelf osteotomy or caries osteotomy.
No, I will not agree. There was all salvage, isn't it? Both Chiari and shelf are salvage osteotomy.
When you congruent hip, no, we can do some other.
Exactly, it's a congruent hip. We can
congruent hip.
So even a Dega, Salter, or even a triple, if you feel that the child is too mature, a triple you can rotate the entire this thing, or if you really want a PAO kind of an osteotomy also. But I would suggest that the child also needs an acetabular procedure along with the subtrochanteric valgus osteotomy.
Why the child is having less internal rotation and more external rotation? What is the reason? Do you think you need to include in this surgery?
Retroversion.
Yeah.
Retroversion is there.
The patient is having retroversion. That's why internal rotation is less. Okay. So on the other side, you have to make it equal on both sides, right? So you have to do valgus plus derotation osteotomy to make it equal.
Retroversion of the hip. Can you see? You tell one clinical condition where you will see the retroversion of the hip. Where?
Developmental dysplasia of hip.
No.
Common
condition, retroversion.
No, other than this
adolescent. எத்தனை இயர்ஸ் பண்றீங்க? Come on. இன்னும் முடிக்கலையா?
Walk without going right. 12-year-old boy.
Moral anti-vaccine.
Yesterday also we demonstrated a case பா. ரெட்ரோவேஷன் வந்து எப்ப அதிகமா நடக்கும்? எதெல்லாம் நடக்கும்?
Moral anti.
Always the thought process will be blocked in the examination and he is good candidate but he is trouble. Okay.
Obese individuals.
Slip the capital from
Slip the capital from disease.
What will be the prognosis you will tell the parents after you do a valgus osteotomy this child?
Recurrence. Shortening will be corrected, sir. The recurrence, so hip congruity is maintained, so probably osteoarthritic changes will be not there future. Later stages only the osteoarthritic changes will be there.
No, can you expect a recurrent shortening and limp in this child?
Yes, sir.
So because treatment doesn't finish with your osteotomy alone, you understand that?
Recurrence is that.
Okay, so because there is a physial, most probably there is a proximal femur physial arrest. You understand? So there can be a recurrent shortening even after your procedure. Okay, so that has to be told to the parents, because or else it leads to lots of dissatisfaction. They think that once you correct it, everything will become normal. You're clear? So you have to tell the parents that there is a problem since childhood. So we may require serial multiple procedures. So all that you will have to inform the parents. Any other procedures, if you are a middle exam candidate, any other procedures you are aware about in such a thing where the trochanter is large, broadened?
Trochanteric epiphysiodesis.
Or trochanteric. Have you heard of any procedure called as femoral neck lengthening?
Yes.
What do you do in that?
In femoral head and neck resorbed cases, AMPA reconstruction.
No, that is not. Okay. Anyway, leave it. We'll stop.
Okay, thank you.
Good presentation.
Yes. Necklace.
Rather than valgus, we can leave it and fix it to line. As it is, then advance. Because already displayed here the established.
So, the name is. Yeah. Dr. Girish, sir. Dr. Suresh Babu, sir. No, Dr. Jagdish Menon, sir.
Give it to somebody. Already given, man.
Check. Hello. Hello. Check. Sir, okay, va? Hello. Speak. Hello. Speak again. Hello. Sir.
Next, we have a presentation on nerve injuries by Dr. Srinivasan Rajappa sir. Sir is the HOD of hand surgery at Sri Ramchandra Medical College.
Go down sound. Thank you. Yes. Right. So you're done, right? No, I think you're all able to hear me. I can hear you, right? You're able to hear me? Thanks. Okay. Am I coming? If I'm coming in the way, please let me know. Okay. And good morning, all of you, and I'm delighted to be here. And at the outset, I'd like to thank the organizing committee of this program for having invited me over. And a special thanks to some of the PGs who supposedly mentioned or suggested my talk in this. And I'm grateful to all of you. And thank you, the audience, for choosing to come here. And I hope you will fondly benefit out of being here and listening to all of us. Today we'll talk on the examination of the median, ulnar, and the radial nerves. For some reason, this seems to be the holy grail or the bugbear, the most difficult part of an exam. Examination is not only the day. Is this working? At any time, if you can't hear me, please raise your hand up. It's okay to do that. Okay. So today we will look at examination of the median, ulnar, and the radial nerves. It's not very difficult to do it, but I have also tried and simplified. Or that slide moving. Try moving. Then trying. Okay, let's not kill time. I think I know what's there in that slide. The exam is not a very useful place. Okay, the exam is very different from your conventional practice or what you will be doing on a regular basis because of the following reasons. You have very limited time. Say, for example, in my practice, I take about 15 to 20 minutes to examine a patient with radial nerve, document what I have, and tell the patient the problem and the plan. Whereas in the exam, it's a complete somersault. You get about 5 minutes to find out what's going on, make a diagnosis, and many times write a small case sheet. So you're strapped for time. The second problem is that there's too much information to remember because you've already examined 2 more short cases and you have to remember all that, document all that, and you should be able to keep it in a presentable format. So a lot of information, the hard disk up not holding all that. So you're struggling a little bit there. See, the environment is just absolutely hostile. Okay, if anybody has any doubts about it, you have to recalibrate a little bit. You're going to have the guns and the daggers out that day, and you're going to be nervous. So the environment is very, very hostile. So it's important that you put yourself in that environment again and again. It's like being in the finals of Wimbledon. Okay, so you put yourself again and again in that environment so that, because the fundamental point here is that your brain is not working. Your spinal cord has to work, okay, because everything is happening at the spinal level, okay, because there was a question which was asked in the previous presentation. So what does a valgus osteotomy do? So the thing is, the answer has to relay in the spine, that it converts the shearing force into a compressive force and so on and so forth. So the environment is hostile, so you better be ready for it. The final thing is that, as I mentioned, it's very, very different from what you do in your regular practice. So the format here, if you follow this format, you're likely to get out of the exam, you're likely to get a pass. This is not a gold medal format. I think in the exam, you should try not to get a gold medal because you go there through the back door and you sneak out through the back door. Don't get into the red carpet there. The red carpet there is full of blood, okay? People have been slaughtered, and don't go there and get slaughtered. Get in through the back door, sneak out through the black door, okay? So which means don't tell you, if somebody tells you radial nerve palsy, you stop with radial nerve palsy. Don't tell them post-traumatic radial nerve palsy partially. Let the examiner ask the question. In some ways, you should be smart to lead the exam. You can actually lead the exam. Okay, say radial nerve palsy and stop. Then the examiner will ask you, why do you think he's got radial nerve palsy? That's much better than going into tendon transfers because you've seen what a tendon is only the day before the exam. So that's not a great situation. Okay, so be a little smart there. So when we do an examination of the peripheral nerve, we only need three things. What is the nerve which is affected, or what are the nerves which are affected? Where is it affected, or in other words, the level of the lesion? The other thing is, what is affecting it? Is it a compressive neuropathy, or is it a traumatic neuropathy, or there's a nerve tumor which is causing paralysis, and so on and so forth? Only three questions we are trying to answer when we examine a peripheral nerve. And our examination is going to be tailored to answering these three questions. Okay. So here's a general format for every nerve injury. You can apply this format for every nerve starting from the greater occipital nerve to the lateral plantar nerve. From head to foot, you can apply this format. And this is a very simple format. If you remember this format, you will most probably not miss anything in the exam. At least you will get in through the back door and get out of the back door. So the first thing you ask is the onset of, was it a gradual onset or was it a sudden onset? A sudden onset is usually traumatic or something like a Saturday palsy where the patient woke up the next day with a wrist drop or an ulnar nerve palsy or so on and so forth. If it is going to be a gradually developing, you're going to think in terms of something pressing on the nerve like a compressive neuropathy or an idiopathic neuritis, a brachial plexus neuritis, a Parsonage-Turner type of problem. So the onset is likely to give you a lot of clues about which direction you're going. Now, symptoms are usually positive symptoms or negative symptoms. Positive symptoms can be pain and burning. Okay, burning in particular, this is apart from the exam. When some patient tells you that when a cloth touches me, it's burning. When I sit in the air-conditioned room, my pain gets worse. Please don't brand that patient a lunatic. They are the positive or the hyperalgesic symptom of a nerve problem. So that immediately points to a nerve problem. You can also have negative symptoms like paralysis or weakness or numbness. So all these can actually coexist many times, especially if you're dealing with traumatic neuropathy. The next thing you're asking is the problem getting better or is it worse? Now, why do we ask this? Really very simple. If it's getting better, you stop. You don't have to do much about it. It's already on its way to recovery. If it's getting worse, then depending on the time period, then you might have to ask for relevant investigations. You might have to intervene surgically or splinting or so on and so forth. What is the functional difficulty a patient has? Because a nerve problem can be many difficulties. A nerve problem can just be managing the pain. You will, for any one of you seen preganglionic brachial plexus problems which are recovered, they will tell you just take the pain away. The paralysis. Pain is not managed. Patients who are having treatment are fully functional, most often than not. Their problem is a cosmetic deformity. Patients with radial nerve palsy who have a grasping objects, they can't grasp the objects because the wrist is not. So it's very, very important for you to identify what problem the patient has. Don't do a claw correction on a patient who has no cosmetic problem. It's not a very smart thing to do. And finally, look at problems. They could have had treatment for Hansen's disease. They could be diabetics and so on and so forth. So this format is very useful. Just ask these questions and you'll be fine. As far as examination is concerned, again, there's a format to follow. It's slightly different from the format you do in a general orthopedic examination, which is inspection, palpation, then you special tests and so on and so forth. In inspection, you look for deformity and attitude. This will most often than not give you the clue to the diagnosis. Look for muscle wasting. This again will indicate where the problem is. Look for trophic changes and look for scars, especially if they are along the course of the nerve, and especially if they are at right angles to the course of the nerve. So what do I mean by that? Now, these are classic examples. Now, you look at this. This is a normal hand, and this is what? Claw hand, okay? So claw hand, again, the question will be, what is claw hand? Please today go home and say this to yourself, or say this to a mirror, or say this to a wall or a friend 100 times. Okay? Repetition is mastery. Okay? So what is claw hand? It is not extension of the metacarpophalangeal joint, because this is extension of metacarpophalangeal. It is hyperextension of the metacarpophalangeal joints and flexion at the interphalangeal joints. Please, for heaven's sake, if you are sitting here, and please don't think this is absolutely elementary. Today you have the time to think. Everything is relaying in your brain. When you are going to the exam hall, you have left your brains in the hostel room. So it has to relay in your spinal cord. And relaying in the spinal cord is done by repetitive repeating again and again. So hyperextension of the metacarpophalangeal joint and flexion of the interphalangeal joints. Why this is happening, we'll come back to that a bit later. That picture is, you're not going to call it wrist drop anymore. From today onwards, you're going to call it wrist finger and thumb drop. Why? We will come back to that, okay? Wrist, finger and thumb drop. A radial nerve palsy produces what? Wrist, finger and thumb drop. It's not a wrist drop. Okay, if it's a wrist drop, the wrist will drop and the finger should be extended. A radial nerve palsy produces a wrist, finger and a thumb drop. So that's something to take home. Now you look for trophic patient who burnt the index finger because of loss of sensation. They try to hold a cup of tea or anything like that. So they burn the finger. So look for that. This is not ulnar nerve palsy. What palsy is this? If you watch closely, the diagnosis is written on that finger. Okay. Just watch it closely. This is what palsy? This is median nerve palsy. Okay, the median nerve innervates the sensation there. And you get thenar wasting. That's the muscle wasting I'm talking about. Now, if you look here, what muscle is wasted? The intrinsic muscles are wasted. Okay, now what I want you to do is, let's do a small exercise. All of you look at the back of your hand. The back of your hands are chubby, okay? What do I mean by chubby? You barely see the extensor tendons. The shape of your hand is like a square, okay? Okay, the shape of your hand is like a square. What contributes to the sides of that shape is a very bulky first dorsal interosseous muscle and the abductor digiti minimi on this side. They both are innervated by the ulnar nerve. So if they both are not working, or if they are wasted, you will see that the hand becomes a bit of a triangle. The second thing which happens is that the extensor tendons, the metacarpals, all become prominent because the interossei which are sitting in between are all wasted now. So whenever you see muscle wasted like this, you know what palsy this is. Okay, this is ulnar nerve palsy. Next, you come to palpation. In palpation, so let's go back to the previous slide. So this is the format in inspection. You look for deformities and attitude, look for muscle wasting, trophic changes, and scars. So you go back to palpation, you do only three things. You look for, palpate the nerve, palpate the course of the nerve, and palpate the bones along the course of the nerve. Only three things. Palpate the nerve, palpate the course of the nerve, and palpate the bone along the course of the nerve. Now, why do I say that? When you palpate the nerve, you look for three T's: tinel, thickening, and tenderness. Now, why is tinel important? If you tap the course of the nerve from distal to proximal and there is a scar and you get a tinel sign, you don't need an EMG or a nerve conduction study to figure out which is the level of the lesion. The nerve is lying there. That's where it is cut. That's where it is compressed. If you have a patient with carpal tunnel syndrome, you tap from distal to proximal, from the middle finger right up to the transverse carpal ligament, you will get a tinel at the level of the proximal border of the transverse carpal ligament. That's where the nerve is pressed. Okay. So tinel is very important. Tenderness is again important because the nerve could be acutely inflamed for whatever reason it is. A non-compressive neuropathy or an infective neuropathy like Hansen's with an abscess, you can have a very tender nerve. The other thing is thickening. Okay, if a nerve is thickened, then it sort of indicates a chronic process. In our situation, it's predominantly Hansen's disease. Now, palpate the course of the nerve. You can have a schwannoma, a neuroma sitting along the course of the nerve, which can be the source of the problem. So it is important that you palpate along the course of the nerve. And it's also important to palpate the bones along the course of the nerve. You can have distal humerus fractures where the ulnar nerve is entrapped in a massive myositis there. So if you do not pick up the myositis clinically, then it's going to become a problem later on. So this is what you do on palpation. You palpate the nerve, remember the 3 T's, palpate the course of the nerve and palpate the bones along the course of the nerve. Are we clear till now? Anybody is having any doubts? If you have a doubt, we can stop and go back to that. What I do not want is that you listen to me. At the end of my talk, you should be able to tell somebody that these are the 5 points I learned from this talk. If you're not able to write down 5 points, you just heard me. You never listened to me. There's a lot of difference. Okay? The next thing is neurological examination. We are not neurologists. Okay, let's get that very straight at the beginning itself. We are orthopedic surgeons, so our examination will be to sort of examine a peripheral nerve. So you're going to do a motor examination and you're going to do a sensory examination. What's very obvious here is that I have not done any special test, because the moment you touch a patient and do something, it's special only. So everything is special testing. Okay, so there should be absolutely no confusion regarding this. So what do? We start with examination of the median nerve. In the median nerve, you go from radial to ulnar. Why I'm saying this? In the ulnar nerve, you go from ulnar to radial. This examination is meant to get you pass mark. Again, this format is not meant to get you a gold medal. Please remember that. So what is the first muscle you will examine in the median nerve? You check the flexor carpi radialis. I'm very fond of the book S. Das, but I beg to differ with Professor Das in the way he writes about how to check the flexor carpi radialis. S. Das says that to get the flexor carpi radialis working, you flex the wrist and you radially deviate the wrist. I'm throwing up a challenge to everybody in the audience. Anybody's wrist can do it here. If you can do it, you come with me, because I have a case report for the Journal of Bone and Joint Surgery. My institution will give me a promotion. I'm not going to give you the money they give me, okay? So, anybody's wrist can do it. You just can't do it. The wrist is not designed to flex and radially deviate. On the other hand, the wrist is designed to extend and radially deviate. Everybody can do extension and radial deviation. Anybody who cannot do it, again, come with me. Okay, that's the downgoing motion of the wrist. Okay, so you can flex and radially deviate. The other problem which happens is when you flex the wrist, you put all into contraction. So you don't know whether the flexor carpi radialis is working or the FDS. So the best way to ask the patient to straighten the finger. So when you straighten the finger, you will see the flexor carpi radialis coming up on the radial side. And a small note here, the flexor carpi radialis is a much more central tendon than you think it is. The flexor carpi radialis is not on the radial border. It's almost in the center. Again, this becomes important because when you do a modified Henry's approach, you go on the artery and some make slightly radial and you actually be on the radialis. Go slightly and the vein is the radial artery, whereas the radial artery is on the side. Okay, so that's just a little bit. So you straighten the fingers and the flexor carpi radialis goes into an isometric contraction and you can palpate the tendon there. Now you have to understand one thing, the MRC grading is not very good for hand and small muscles. For example, you cannot do this and say this is anti-gravity checking of the intro. Not the way the hand works. So in the hand, you can only say whether the tendon is not acting and weak, or whether it is normal. So those are the only 3 things. But don't go and say this in the exam. You'd shoot yourself in the foot. You sort of bring it up in some way, grade 3, 3 plus, 3 minus, whatever you want to say. So that is the way to check the flexor carpi radialis. The next thing, you come distally, you come to the abductor pollicis brevis. The abductor pollicis brevis is a muscle which produces palmar abduction. Again, there's a massive amount of confusion here. What is abduction? So the fundamental thing to remember here is that there are two types of abduction. One is palmar abduction, the other one is radial abduction. This is palmar abduction, which means if you look in this plane, the thumb is in line with the index finger, and then the thumb is at right angles to the palm. Okay. Now this is the abductor pollicis brevis. Now why abductor pollicis brevis? Because the other muscle, which is called flexor pollicis brevis, is a flexor of the metacarpophalangeal joint. You can see the metacarpophalangeal joint is straight. If somebody is flexing the metacarpophalangeal joint when bringing the hand or touching here, that median nerve is not working very well. So for opposition or palmar abduction, metacarpophalangeal joint should be straight. And the abductor pollicis brevis is the muscle which is most often than not, watch my words, most often than not, because sometimes it is still innervated by the ulnar nerve, innervated by the median nerve. So when you do the pen test, you're putting the abductor pollicis brevis into contraction, and that's how you do it. Now compare this abduction and this abduction. This abduction is at right angles to the palm. This is palmar abduction. This thumb is abducted and extended. You can see the EPL coming up there. And this is at the same plane as the palm. This is radial abduction. This is a function of median nerve. This is a function of what now? This silence is stunning. It's a function of radial nerve, right? All of you do a thumbs up. Okay, that's radial nerve. Really as simple as that. Okay, so you have to understand the difference between palmar and radial abduction. The next thing is you stay in the thumb, and then you ask the patient to fix the interphalangeal joint. Again, the thumb does not have a distal interphalangeal joint. The thumb has, okay. So the flexor of the flexor pollicis longus, you ask the patient to flex the interphalangeal joint, and you can apply or not apply resistance depending on the power. Next, you come directly to the flexor digitorum profundus. Okay, the flexor digitorum profundus of the index finger, okay, is asked by asking the patient to flex the distal interphalangeal joint or not against resistance. Function of the FDP of the index finger. If you have time, if you're still up for it, do this. This is not absolutely necessary. This is an FDS of the ring finger. My suggestion is that you stop with this, because then the next question will be, how will you neutralize the FDPs of the finger? What is quadriga effect? Now you're beginning to dig your grave, okay? You have to understand that the examiner in the exam does not come with a gun. That's a perception amongst PGs. He's going to fail me. You know something? Every candidate comes there with a suicide vest. Okay, threatening to ignite the suicide vest. So don't go and pull the trigger on yourself. So I will just explain this. What I'm doing here is holding the little finger, FDP, and I'm asking the patient to flex the finger. You will realize that the finger is not flexing at the distal interphalangeal joint, because I have held the FDP of the middle and the index finger and the little finger. Mind you, you can't do this to the index finger, because the index finger flexor digitorum profundus is a separate. Okay, so be mindful of this fact. Right, so median nerve sensation. Again, we know the median nerve supplies many times the 3.5 digits. Again, don't go and examine sensation here, and all. This is not a presentation on sensory examination of the median nerve. This is a presentation of median nerve examination. So you have only 30 seconds to do it. Go to the index finger there and look for sensation there. That is the autonomous zone, and you'll be fine. Okay. After this, you have to know this. This is functional anatomy of the median nerve. Okay. Intentionally, I have not shown the arm here. Why have I not shown the arm here? It's a fun fact, okay? There is no branch of the median nerve, ulnar nerve in the arm. So you don't have to worry about it, okay? So the branches come off only in the proximal forearm. So what is the first branch which comes off? The anterior interosseous nerve. So the anterior interosseous nerve supplies the flexor digitorum profundus of the index finger, flexor pollicis longus. That's enough. Okay, let's not go into pronator quadratus and all the other things. Okay, flexor digitorum profundus or the index finger, flexor pollicis longus. The FDS branches are given off here. You come distally, that's the palmar cutaneous branch. This is the muscle, the flexor, the abductor pollicis brevis branch. This above the level of the lesion will work. Nothing below the level of the lesion will work. That's fundamental neurology. So if you have the median nerve cut here, nothing distal to this will work. If you have the median nerve cut here, this will work, this won't work. It's just really as simple as that. Okay. So that's what is there in this picture. So let me pull somebody out. The person red shirt. We are going to just give it a shot. It's all right. See, the fact that you've gotten up itself, it's fantastic. Okay, let's give it a shot. If the median nerve is cut there, what will work and what will not work? Sorry? So nothing, as in, will my thumb bend like that? Why it won't bend? Because the nerve which is supplying the muscle which is going to bend it is gone. No? So why the thumb won't work? What is the muscle which makes you do this? Flexor pollicis longus. It is supplied by nerve. Okay. So if you here, it's going to work, right? That's what we mentioned. Make sense? All right. Will the FDS of the ring finger work? It won't work. What? Will the FDS of the ring finger work? Let me take you through this. Instead of looking at him, you look at me, okay. The FDS branch is given here. Okay, you're clear about this? The nerve is cut here. So will this work or it won't work? So we said everything this still won't work, right? So the FDS won't work. Will the FDP of the little finger work? Why? Fantastic. Okay, very nice. Have a seat. So these are the various places you can have a nerve injury. Now I'm not going to confuse you here, but I'll just add that a little bit. If you have the median nerve cut here, clinically, and the FPL is not acting, why is that? That's a flexor tendon problem. It's not a nerve problem. Because somebody can slash the wrist here and the FPL can get cut. Okay, so there you will go and explore and you look for the FPL and repair it. Okay, right. So now on ulnar nerve examination, which is an examination in the opposite direction. Okay, ever since I put this slide, I have changed tactics, so don't worry about this slide. Ignore this slide. Okay, you don't have to check the flexor carpi ulnar. The first muscle you will check is the abductor digiti minimi, which means the little finger moves ulnarly and the resistance is applied in the opposite direction. And you see the muscle coming up there. And you look for flexor digitorum profundus of the little finger. Okay, the patient flexes the distal interphalangeal joint against or without resistance, depending on the power you have got. Then you go a bit radially and you do the card test. You know, all of you know the card test, right? You put a card in between the two fingers and you ask the patient to hold it, and then you pull it. Okay, it is supposed to be tested against the patient's, against the examiner's intraossei. Say, for example, Arnold Schwarzenegger is my examiner, okay? He's going to rip me off that card test, okay? My intraosseous is not going to be as weak as that, as powerful as that. So I'm not very sure, but I think this is just, you know, it's working or you know it's not working. There's a little bit of, you have to figure it out. This is Fromen's test. So you ask the patient to hold something between the thumb and the radial side of the hand. Again, there is one massive confusion. Should the hand be like this, or should the hand be like this, or should the hand be this, whatever. Okay. Froment's original paper, the hand is somewhere in between. Okay. But the fundamental thing is that you ask them to hold between the ulnar border of the thumb and the radial border of the hand. I think you will get a positive result. Okay. So when the adductor pollicis is not working, the patient will use the flexor pollicis longus to do it. So this is a positive Froment sign. This is a negative Froment sign. Okay, so you think about that. And then you check for sensation. In the ulnar nerve is slightly different. You will check for sensation in two places. One is the little finger, which is the autonomous bone. You will also check for sensation here. Why is that? It's because of this. This is the picture of the ulnar nerve drawn in my hand. Again, arm has been intentionally not included because there is no branch of the ulnar nerve in the arm. The first branch is at the level of the elbow. It supplies the elbow joint, but everything else is distal. So if you look at it, that's a FDP of the ring and the little finger. Flexor carpi ulnaris. And look at that. That's the dorsal cutaneous branch of the ulnar nerve. That's a nerve you will see all the time when you're doing ulnar fractures. These nerves really exist. Okay. So you have to be careful about them. Because it's a nuisantical thing, hit that nerve. Patient border of the hand on something, they can't feel it. It's a very problematic thing, and that nerve is just notorious for neuromas. Okay, you do wrist arthroscopy, you will hit that nerve in that portal. You've got to be very careful. So that nerve innervates this side. Now, why is this important? If you have a cut here, that part will be anesthetic. If you have a cut here, that part won't be anesthetic. Say you have a Guyon's canal lesion, the dorso-ulnar part of the hand will not be anesthetic. So you sort of know when the dorso-ulnar part of the hand is not anesthetic, the lesion is very, very distal. So it gives you a clue to the level of the lesion. Right. So the same red line. So what will happen? Will there be a clawing if the nerve is cut there? Shall I ask the question again? Will there be clawing if the nerve is cut there? No, yes or no? You will have a clawing, but will the clawing be very pronounced? Okay, that's called the ulnar paradox. Fantastic. So if the nerve is cut here, will the FDP of the ring and little work? Perfect. If it's not working, the tendon. Okay, so simple. I think you're getting better at this. So now we come to examination of the radial nerve. The first muscle you will do is the triceps. Proximal to the triceps, there is no innervation for the radial. Okay, so you ask the elbow to be extended against resistance or without resistance and so on and so forth. Here you will have to know a little bit about grade 3 power, where you take the shoulder and the arm is over the head, and then you ask the patient to extend. And then coming distally, you will look for brachioradialis. Brachioradialis is on the proximal radial border of the forearm. The brachioradialis is activated by flexion of the elbow in mid-prone position. When you do this in a patient with radial nerve palsy, the patient will actually try to supinate and do it. That by itself will tell you that the radial nerve is not working well. As you come more distally, you check for wrist extension. Okay, wrist extension. And then you check the extensor pollicis longus. The extensor pollicis longus is a radial abductor and extensor of the thumb. The thumb has to come away from the hand in the same plane, and you see that tendon which is coming up, that is EPL. Okay, that's EPL. The next thing you come and do is finger extension. Now there's a little bit of confusion here. This is also finger extension. This is also finger extension. This extension is at the MCP joint and the IP joint, a function of radial nerve. This extension is at the metacarpal, is at the interphalangeal joints. This is a function of what nerve? Ulnar nerve. Okay? Because many times after a humerus fracture, there will be a dressing till here, Post-operatively, there'll be a wrist drop. Through the dressing, you will see the IP joints going like that. And you will go and tell your boss that it's all working very well. But your boss would have come yesterday night and figured it out. Okay, because he's more worried about the radial now because you operated on the radial. Okay, it's just a very, very common thing. When you all become bosses, the same thing will happen. Okay, so remember that. So radial sensory examination, again, the dorsum of the first web. That's the autonomous zone for radial sensory nerve. And remember this, sometimes this place is innervated by the lateral cutaneous nerve forearm. So in case there is no sensory problem there, again, don't panic. It is possible that that place is innervated by the lateral cutaneous nerve forearm. Okay, and that's again a clue. Suddenly you have a problem in sensory examination. The tip of the little finger is feeling normal, but there is a claw hand. The answer you should give the examiner is there is an anomalous innervation. You'll still pass. Won't get gold medal and all. Okay, you'll pass. Okay. Right. So level of lesion for radial nerve pulse. This is my attempt at drawing something like Frank Netter or Mauricelimo Crespi. Pathetic, but still done. Okay. So if you have a lesion there, what happens? That's at the level of the arm. Triceps branch is there, so elbow will extend. But everything else will drop. Okay. Wrist, finger, thumb drop. Wrist, finger, thumb drop. Okay. Here, brachioradialis will go, everything again, same. This and this are very, very similar. This is something you will see in a humerus fracture all the time. Okay. Because to hit the radial nerve that proximally, you really have to be very skilled. Okay. Because the branch to the triceps is very, very proximal. And then you come here, this is important for you to know. The branch to the wrist extensor is given there. So that branch will escape. So you do a proximal radius fracture, a patient has a scar in the proximal forearm. The wrist will extend, but the finger and the thumb will drop. So radial extension, radial nerve palsy is wrist, finger, and thumb drops. So just remember it that way, and you won't make a mistake. The misery is going to end. So in case sleep is to keep it very short. Okay. I think it's a good idea to follow the format. I think this format was made by me, so everybody can follow it if I can follow it. It's pretty simple. The level of the lesion, you should know how to do this. Everything proximal will work. Nothing distal will work. That's again important. Okay. This is the most important thing. So how do you practice nerve pulse? You're not going to get a patient with radial nerve pulse every time. So you have to ask your colleague, you have to ask your friend to say, show me PIN palsy. So anybody here can show me PIN palsy, pin palsy? Bharat, can you show PIN palsy? No, show it. So show the finger drop now. So the finger drops like that. Wrist will go up. And the finger will just extend like that. The finger will never be able to do an aeroplane. And they will never be able to do a thumbs up. So this is something you got to keep doing all the time. You got to keep practice. You should practice till you get a headache. Because you practice it once or twice, you're not going to get it in the exam. Okay. And finally, YouTube videos are again a very excellent source. I think you should watch them. You get a lot more information. I think it's very, very good. So thank you so much.
Thank you, sir. I invite Professor Manimaran, sir, to felicitate the speaker. Thank you, sir. Our next session is a short case presentation. Final year postgraduate from Medical College. To chair this session, I'd like to invite on stage Dr. Manoharan sir, professor at Karpaga Vinayaka Institute of Medical Sciences, Dr. Gopi Shankar sir, professor at JIPMER Pondicherry, Professor K.P. Manimaran sir, and Dr. Suresh Babu sir.
Hello, check.
Okay.
Yes. Good morning, sir. Myself, Arvind Manoj, final year postgraduate Stanley Medical College. I'm presenting the case of 2-year-old male child Pratik. Source of history, parents, reliable source of history. Presented with complaint of deformity over the right lower limb for the past 5 months, sir. Patient was of trauma 8 months back when he fell from a bed, after which local GH where he was. Patient presented with complaint of deformity over the right lower limb for the past 5 months, sir. Patient had history of trauma 8 months back where he fell from bed and was taken nearby GH, where he was put on a slab for weeks. After that, he was taken to Egmont Children's Hospital with slab for another 2 months. After that, taken off the slab and patient was allowed to mobilize. And parents started notice the deformity of the right lower limb, which was insidious in onset, gradually progressive. Not associated with pain and was walking with support, sir.
What is the nature of injury?
Fall from bed.
It's a
8 months back.
trivial injury or a significant fall or
Trivial fall, sir.
what age the child fell down?
8 months back. That's 1 year, 2 months.
1 year, 2 months.
To 1 year, 4 months. In the negative history, there was no history of any fever, night sweats, or weight loss or anything. Coming to past history, patient's parents noted deformity over the right lower limb at 6 months of age, and he was taken to GH where he was put on conservative management. At 1 year of age, he was given an ankle foot orthosis and was allowed to weight bear on that ankle foot orthosis. And patient was mobilizing on that ankle foot orthosis. No other significant past history. Birth patient is second born child of a non-consanguineous marriage, delivered by cesarean section for oligohydramnios, and patient was kept in ICU for 20 days for breathing difficulty. Family history: elder child 6 years, female child 6 years of age. No other significant family history. Parents or first degree relatives, no other significant history. Development history: patient has a delayed development history compared to the older sibling, with a delay of approximately 3 months in all 4 milestones. Vaccination history, complete vaccination history is up to. Coming to examination.
Yeah.
On examination, no pallor-rectus clubbing cyanosis. There is multiple hyperpigmented patches over the trunk in the anterior aspect and the posterior aspect, 9 in number, and there is no signs of hyperlaxicity or any spinal dystrophism. Examination proper of the right lower limb. Patient is examined supine position.
The shirt for the patient.
Patient was examined in supine position, attitude of the limb, hip in extension, knee in extension, ankle at ease. There was a deformity over the right lower limb at middle distal 1/3 junction with anterior and lateral bowing. There's no scar, sinus, or any other discharge. No increase, no visible veins or anything. On palpation, no tenderness, warmth, no warmth. There is a deformity over the tibia, deformity of the right both bone with the bowing towards anteriorly and laterally. Sir, actually there is three apparent shortening and no wasting of muscles. No wastage of muscles. Coming to, there is no deformity, so coming to movements of sir, all bony landmarks were palpable, and the knee joint and the ankle joint at normal level.
Have you palpated the bones, no? The tibia, fibula?
Yes, it is. There was no step. There was no step. There was no crepitus. There was no. There was abnormal mobility in anterior posterior direction and medial lateral direction. There was abnormal mobility in anterior posterior and medial lateral direction. Distance, sir.
See, see, missed out on that. You have to palpate the underlying bone. So, was there any bony thickening at which level? Where? At the site of deformity? Where was it? And then, see, remember, you have another bone also. You understand? Then you have the bony prominences. You have the malleoli, medial, lateral. You have to talk about all that. It is important.
So on palpation of the right tibia, the fibula was not palpable. The fibula head was palpable, shaft was not palpable. Palpating the tibia, there was the thickening of the tibia at the proximal end and distal end at the site of the deformity. And there was a abnormal mobility in both anterior, posterior and the medial lateral direction. There was no step, there was no telescope or distraction at the site of deformity. And there was the mobilities were transmitted. Transmitted mobilities were present. And medial malus and lateral malus were palpable. And so,
is there any pain?
Sir, on superficial palpation, we press very hardly, patient becomes uncooperative. Otherwise,
Check there is abnormal mobility.
There was no pain. While doing anterolateral and it is not much pain was there.
I examined the child is
There is
crying.
pain, severe pain when attempted mobile. It was slightly
Do
mobile.
you want to say there is abnormal mobility or some other word you want?
Abnormal mobility. Abnormal mobility.
There is no frank abnormal. There is no frank abnormal mobility.
Sir, fix it. Not fix joint.
Mobility in one direction. Because both bones are there, two bones.
Summarize the finding and tell the diagnosis.
Did you complete with distal neurological or vascular deficit?
Coming to measurements, sir. Measurements, there's a true and apparent shortness of 3.5 centimeter. The 3.5 centimeter. There is no muscle wasting. Upper cam suspension height ratio is 1:1 and upper segment segment ratio is 1:3:1. 1.3:1. And neurovascular, there is no distal neurovascular deficit, no palpable lymph node. 1:3. 1.3 is sorry. 1.3:1.
How did you measure where? From where to where you will measure for the upper segment?
Sir, patient's height was taken. Then from pubic symphysis to heel lower segment was taken and to subtracted from the height upper segment. Summarize, sir. 2-year-old male child with a complaint of deformity over the right lower limb with multiple hyperpigment patches over the trunk and trunk with mild abnormality, history of fibrous non-union of tibia, non-union of right vertebral tibia.
Any cutaneous markers over the body which you can correlate?
Cafeolar spots were present. Hyperpigment patches, cafeolar spots were present.
Sir, it is a non-union. What type of non-union?
So since fibrous non-union type pain.
Fibrous.
Fibrous non-union. Patient, there is not that much abnormality. It's limited abnormality, and the transferent movements are transferred from the lower to upper segment. So fibrous non-union.
So at the age of 1 year, 2 months only, the patient got the injury, right?
1 year, 5 years.
Usually, child will started walking at the age of 9 months or 10 months, or approximately 1 year. Whether there is a normal walk before the injury or not.
Sir, patient was given a foot orthosis, and patient was walking with that foot orthosis with support.
So you think there was a fracture prior to it?
No, there's deformity at the time. Then he was given. They told us the given for the deformity that.
So do you think it is not a normal bone prior to the patient
Yes,
walking, right?
Can be an abnormal bone.
Then you have to correlate with the other symptoms and come to a diagnosis, right? If the patient was walking prior to the injury, then any brace was applied, treated, then now he is corrected, maybe a non-union or something. But the patient, the baby was not walking at all. With the support only, it started walking, right?
Yes.
Then whether it is giving you a clue for your diagnosis?
Congenital pseudoarthrosis of tibia.
So you want to be more smart, right? You don't want to tell the diagnosis.
What type of fracture? You want what type of fracture?
Pathological fracture.
It's a pathological fracture. Why do you say it's a neurocongenital pseudoarthrosis? What is your?
So it's a finding in neuropathy. There is scaphoidal diagnostic criteria, fixed cellular spots, and any bony deformity, especially pseudoarthrosis of tibia. The two diagnostic markers neurofibromatosis. So it can be initially patient had deformity, that's anterolateral bowing. That's also in neurofibromatosis. So
The size of the capillary spots have you measured?
Sir, there are more than 5 mm is that in children and more than 15 adults. There are 5 that is more than 5 mm.
Can you mention any other condition where you will get the same capillary spots?
All-Bright syndrome.
What is the difference between these two?
Sir, in capillary spots, the margins will be regular. In McCune, it will be it will be crossing the midline in McCune Albright. It won't be crossing midline in neurofibromatosis.
So what do you want to do now?
Would like to take an X-ray for the X-ray of the right lower limb, AP lateral.
See, any other, what are the other neurofibromatosis? You know them, the diagnosis is obvious. So what are the other orthopedic manifestations you're aware about?
So patient can have scoliosis and other bony manifestation and sphenoid dysplasia.
The upper lip?
Bone will affect it. And the tibia.
Numerous.
Okay, so even okay, so because that is the main thing. So you should have looked for all that. You should have examined the spine. So that is where
examination
upper examined the X segment. You should look at the upper limb bones also.
So this is an anterior posterior lateral radiograph of a skeletally immature patient showing the knee joint and tibia, right both bone leg. There is a fracture at the middle.
Just tell me what is it a fibula is intact, no?
Yes, sir.
So you said the clinically you said a frank abnormal mobility in all directions. So now we won't find any abnormal mobility. Do you agree with our finding?
Medial lateral might, anteroposterior is there, sir.
Anteroposterior is there. Huh? Difficult. I think only
Examiner differs with you, you say just stop with that, huh? Okay.
The X-ray shows the middle distal one-third junction with callus present.
Callus is there, huh?
There is posterior, there is some callus formation is there, lateral, anteroposterior, some amount of callus is present. Margins, and there is a hypertrophic cortex with a narrowing of the medulla.
Medullary canal is
At medullary canal is narrowed in the proximal segment and
narrowing of medullary
and distal segment it's atrophic. There is a narrowing at the proximal fragment and there is almost closure of the distal fragment.
Is there any lesion in the tibia?
There seems to be hypertrophic of the cortex. Cortical hypertrophy.
Okay. So now what is your diagnosis?
Pseudoarthrosis.
Yeah. What type? You want to classify? Any classification?
Crawford classification, sir. Type it's dysplastic, sir.
Dysplastic. What is the other type in Crawford?
Non-dysplastic, sir. Where there is
difference between these two?
Non-dysplastic, there will be hypertrophy of the cortex and the medullary cavity will be narrowed. In there will be other symptoms like pseudocyst and pseudocyst formation in the tibia or pseudoarthrosis in
any other commonly used classification in the exam.
Palatal classification for palatal classification for complete.
Boyd's classification. You don't know the common Boyd's classification. Don't know. Don't know. In the exam.
2 years, sir.
2 years. Is there any pain is there or not?
I think, and you expect it to heal. So
we have to exercise the pseudo.
You say all that. See, when you're talking about management principles, you have to what are the basic steps?
We'll have to exercise the pseudo joint. Then we have to do internal fixation with bone grafting, so that there will be union.
Okay, so you have to exercise the pseudoarthrosis. Okay, then you will have to choose a fixation modality, and then you will have to definitely bone graft it to augment healing. Okay, so there are various controversies regarding each type. You understand that? Okay, so what about the prognosis?
Sir, less than 4 years, early onset has a good prognosis compared to late onset.
Okay. No.
In your practice, always explain the things to the parents. That is very, very important. They all will think it will heal in a single surgery. First and foremost, once there is a counseling session with the parent, that it is a difficult thing to manage. The child may require more than 2 or 3 surgeries. And up to the age of 12, 14, we need to be on a continuous follow-up. Even though there is a healing in the X-ray, you cannot leave the patient without the brace. These are all the dictums. First and foremost, after the confirmation, you have to talk to the parents. This is very important.
Okay. Why the fracture goes into non-union in neurofibromatosis? Why there is a very difficulty in getting the union? What is the reason?
So vascularity, decreased vascularity.
Decreased vascularity.
Pathological fracture, there can be a cystic lesion or something prior to the fracture, which can lead to decreased vascularity to that particular area.
Now, what is the basic pathology? How will you excise the non-union there?
We'll have to take out the pathological bone.
Only bone?
Soft tissue, soft tissue
What
also.
soft tissue?
Neurofibromas might be present in that region.
It is a thickened periosteum, hematomatous periosteum, which is increased osteoclastic activity in the periosteum. That periosteum with increased osteoclastic activity only eaten away the bone and causes the non-union. So you have to excise extra periosteum. The periosteum is very important. You have to remove the diseased periosteum. When you're doing surgery, you have to excise the periosteum also. Any medicines? Do you want to give any medicines? Can you use any drugs to prevent the recurrent fractures, to decrease osteoclastic activity?
Bisphosphonates.
Yeah, correct. Pamidonate injection. No, we used to give pamidonate injection. What type of fixation you want to do?
Do tense
nail.
Tense nail.
You said there is a sclerotic bone and the canal is very narrow. Is it possible to pass the tense nail? The growing child, do you have any?
After exercising we can go for a tense.
Thank you.
Thank you, sir.
Use the intramedullary fixation. You can use a telescopic nails or rush rods. Then you have to don't remove the implant. You have to keep the implant till the maturity, and also, as I told you, you have to wear the brace till maturity because the recurrent refracturity is very, very high. Thank you.
Thank you, sir.
So we have one. I have another short case presentation. For this, I'd like to invite Dr. Pavitran on stage. Sir is a final year postgraduate in Madras Medical College.
You can start. You can start. Yeah, you can. You keep presenting, doctor.
Morning, sirs. Myself, Dr. Pavitran from Madras Medical College. Is a 14-year-old boy who is a 10th standard student. Came to OPD with the chief complaint of pain in his right knee for past 7 months and swelling in his right knee for past 7 months and deformity in his right knee for past 5 months. Patient was apparently normal 7 months back, after which he had a history of a fall from height of 5 steps and sustained injuries to his right knee, which is a closed type of plaster where a bandage application was done from cough to mid joints. He was in pain and swelling, and after that he was the mother noticed deformity in his right knee, which is and then they went to nearby private hospitals where some aspiration was done, and then he forwarded to Rajiv Gandhi Government General Hospital for further management, sir.
Before the fall, he was walking normally. Yeah?
Sir?
Before the fall,
Sir, he was
walking normally.
walking normal.
Immediately after the fall, what happened? He was able to stand.
He was able to stand with pain, sir.
Okay. Was he able to walk?
Yes, sir. We able to walk, but with pain, sir.
Pain.
Patient was able to walk after the fall.
Yes.
Okay. Continue.
So pain is pain which is acute in onset and dull aching, but the pain not radiating, no history of diurnal variation, and no history of night craze, night pain, and the pain was reduced. Sir, now pain was reduced when compared to initial stage of the pain, and the swelling is also which is acute in onset, but the size of the swelling is reduced when compared to initial stage of the swelling. Sir. Deformity, which is a progressive nature associated with the pain, able to walk about 500 meter and then he feels pain, able to sit on the floor, but he has difficulty in squatting and able to climb the stairs. No history of fever, no history of abdominal pain, no history of loss of weight, no history of loss of appetite. No history of any.
There's no history of fever at all for the past 5 months.
Yes, no.
Okay, okay.
Past history not a known case of tuberculosis and diabetes mellitus.
See, as per your history, you said that 5 months back he had a trivial fall, correct?
Yes, sir. 7 months back.
7 months back, he was intravenously treated. The
Yes, sir.
splints were removed by the mother.
Yes.
And the procedure you said was done.
Yes.
What was done?
Aspiration was done, sir.
Oh,
But in Rajiv Gandhi Medical general examinations. No significant family history, sir. No significant family history. General examinations. Patient is
what did you think of based on your history? What was your thought?
Post-traumatic
After the fall, able to walk or what happened immediately? Can you elaborate that?
so immediately was for first half an hour he was not able to he was he falls, sir, and after half an hour I was able to five steps from steps. Yes, sir. Yes. 5 steps at his home, sir.
As per your history, you said that he was able to walk and stand after the fall.
With pains, yes.
With pain. Okay. So that may also that rules out any major bony injury. Correct or not?
Yes.
Oh.
Immediately after the fall or after?
So immediately after fall, for half an hour he was not able to wait bed, sir. But after half an hour, he told that he wait bed with pain, sir.
Okay.
And then he went, and then after and then the condition was done, sir.
After the removal of the splint, did the pain and swelling increase?
Decreased, sir. Pain and swelling decreased, and he was he was going to school, sir.
Okay, okay. After the removal of splint.
Yes, sir. And then
why did they take them for aspiration? Then you said something was done, nah?
Yes, sir.
When was that?
After 1 month for doing his activities, he developed a swelling and deformity, sir. Okay. For which they went to nearby hospital and aspiration was done, sir.
Oh.
Any bleeding disorder?
No, sir. No, sir. Bleeding.
What was aspirated?
Sir, patient didn't tell.
No. No fever as per history, sir. No history of any bleeding diathesis also.
Yes.
Any history of massaging before applying the splinting?
No, sir. No, sir. No, sir.
Okay, proceed.
So, general examination, sir. patient is conscious oriented afebrile from standing, sitting, and lying position. From front, bilateral shoulder at same level, but right side anterior superior iliac spine at lower level.
For short case, no need to tell all things.
Inspection in knee joint, linear scar present over the anterior aspect of the knee, which is healed by primary indentation of approximately size 15 centimeter. And another scar present, which is present on the anterolateral aspect of the thigh. Skin over the swelling is appears. The skin over the swelling is appears stretched and.
Like a swelling in the knee joint.
No.
Present the swelling around the knee joint. You're telling about the size and shape and everything. The knee joint is swollen.
Yes.
That you have to tell the word that is obliteration of suprapatellar pouch or parapatellar pouch, infrapatellar pouch. We don't describe in centimeters and
Patella, I couldn't able to make out.
The entire knee joint is swollen.
Yes.
All the pouch are obliterated.
Yes.
Okay. From the front, from the back.
The swelling
fossa.
Swelling present in the popliteal fossa.
Popliteal fossa also is obliterated.
Yes. Sir.
Okay. Any wasting in the muscles, proximally and distally?
So, I couldn't
Any
able
deformity, obvious deformities are there?
Yes, sir.
What deformity is there?
Valgus deformity present.
Valgus deformity. Any limb length shortening?
Limb length discrepancy present, sir.
Discrepancy means what is it? Shortening?
Shortening present.
Apparent shortening is there.
Apparent shortening present.
So coming to the palpation.
Palpation, warmth present, sir. Tenderness present at anteromedial aspect of the distal femur, distal thigh, and proximal legs. Sir.
Oh, you should be specific in which part you are palpating. You said warmth is there. Then coming to the bony palpation. What are the bone you palpated?
Sir, I palpated distal femur, sir, medial side and lateral side, sir.
Medial, what is there in the middle side?
Distal femur condyles.
You tell specifically, doctor, middle femoral condyle. Okay.
Tenderness present in condyle.
Okay.
And there's no tenderness in distal femur lateral condyles.
Okay.
And no tenderness in tibial tubercle, no tenderness in proximal tibia, sir.
So to tell there is a problem only in the distal part of the femur.
What about the bone? It's thickening, irregular, anything?
Medial side broadening present, sir. Surface of the bone is smooth, sir. Regular.
You mean femoral condyle?
Yes.
Okay. What other bone you palpated?
So I palpated the proximal medial side of the proximal tibia and lateral tibia and fibulus.
Is it normal?
Lateral femoral condyle smooth and regular, sir. But I couldn't able to make out the broadening, sir. I see friction is present. Lateral.
What about the patella?
Swelling, soft in consistency, so swelling.
No, patella.
Patella is subluxated laterally, sir.
No, you tell about the palpation of the patella.
Palpation.
Patella is
surface of superior surface of patella is regular, sir, smooth, sir. Patella tap test was positive, sir. Fluctuation test was positive, sir.
Patella tap is positive.
Yes. I couldn't able to see the mall tracking of the patella, sir. Mall tracking of the
mall tracking. Why you want to say mall tracking in this case? Have you palpated the joint, but you said about femoral condyle, tibia. What happened to the joint?
No joint length tenderness.
What joint you palpated?
So I palpated the medial tibial femoral joint and the lateral tibial femoral joint and patellofemoral joint. While grinding, there was pains. Patello grind test.
Are you able to palpate the undersurface of patella in this case?
Yes, sir.
Able to palpate. How will you hide the joint?
Sir, I flexed the knee and palpated the tibial tubercle and went along the border of the patella tendon, sir. So I felt on dips.
How will you confirm this is joint line?
I flexed and extended the knees.
You can rotate and flexion extension and find the joint line. So no joint tenderness.
No.
So only okay. Next. So inspection, palpation over. Then coming to movements. Yeah.
Movements. Flexion. Flexion up to 110-degree present, sir. Further flexion is painful, sir. Extension is extension.
Active movements or passive movements? So it will be very specific.
Active at 50 degrees, sir. From 50 to 110 degree, he was able to move, sir. Passively, I can extend the knee, sir, up to 0 degree. From 50 to 0, I can able to move, but without pain, sir.
You are able to extend up to the 0 or going into hyperextension?
So, going into hyperextensions.
Okay. Then flexion?
Flexion up to 110 degree it is possible, sir. Further, it is painful, sir.
Okay.
Initially, you were mentioned about the valgus.
Yes.
So when you are mentioned about the valgus, at the time of movement, during the flexion, whether the valgus decreases or increases or it is obliterating, you need to tell.
Yes. And knee flexion, the deformity is absence, decreased, absence, disappeared.
Disappeared. Why do you want to know this?
So whether the pathology, whether it is in a proximal tibia or distal femurs.
What is your inference?
So disappeared. So the pathology is in distal femurs.
Any abnormal mobility?
Yes, sir. Valgus test was a positive, sir. Lackman test was a positive, sir. Valgus test were positive, sir. Lackman test was positive, sir.
How will you do the Lackman's test?
Sir, I will relax the hamstring muscles. I'll relax the hamstring muscle and then knee in 20-degree flexion. I will give the anterior translation of the tibias.
You have to palpate the. You have to palpate the joint, no?
Yes, sir.
How much the tibia is moving? Are you able to palpate in this case?
Tibial tubercle. I palpate the tibial tubercle and yes.
It's completely swollen. Yeah. Okay.
Measurements. Craig's test was normal. Craig's test was normal, sir. I'll tell measurements. So, right side calf muscle, thigh muscle is increased when compared to left side, and right side calf muscle also increased when compared to left side.
Girth is increased.
Yes, girth is increased, sir.
How many centimeters?
Right side 35 centimeters, sir. Left side 34 centimeters. Thigh segment, calf segment 1 centimeter.
Length?
Length. I measured from anterosuprachial axis to medial joint line, sir. Right side it was 47, sir, and leg segment was 37, sir. Leg segment was equal, sir, both side, but thigh segment is increased in the affected limb, sir. But lateral side, I'm sure shows it was a shortened.
Okay.
Petalo quadriceps angle was 35 degrees, sir, in right side.
Why you want to tell about quadriceps angle in this case?
Patella subluxation.
Like subluxated.
Genuine algum, there will be increased quadriceps angle, so I measured.
Neurological examination, vascular, lymph nodes are there.
Lymph nodes, yes, inguinal lymph nodes palpable, sir. I couldn't able to palpate the popliteal lymph nodes, sir. No neurological deficits, sir. Thigh foot angle was normal.
What is his gait?
Valgus thrust gait.
No, is it antalgic gait or non-antalgic gait?
Non-antalgic gait, sir. He walks.
So no pain.
Yes. After sometimes he feels pains.
It's okay. What is your diagnosis?
14-year-old boy post-traumatic unilateral genuine deformity of 5 months duration with chronic synovitis.
Anyway, I mean, this is a difficult case here. Anyway, you have what neurology?
Yes, sir. But in inspection back, there was a scoliosis present, sir. But while sitting, it was a decrease. No, sir. While sitting, the scoliosis was corrected. Yes.
See, it's very important in this thing because see, nothing is fitting. You understand that here. You're saying that the trivial trauma, indigenous treated child was all right. Then, develop pain and swelling again. You understand that. So it may not be related directly. See, what trauma will produce such a valgus deformity and all?
Can a synovitis can cause this valgus deformity?
Yes.
You have examined the patient and you told there is some changes in the palpation in the distal condyle of the femur, right? You want to correlate something with that?
Facial injury can cause this deformities because of overgrowth of the medial.
But it's very short, now that time duration.
Yes, sir.
So okay, so all that is not correlating at all. So this is where you have to you have to open up your mind. Look for.
Synovial thickening present, sir.
Not able to do the patellar tab positive.
What is your differential diagnosis? You have to here is where you have to think more. So there is a valgus deformity. What do you think the surgery was done for 2 weeks back? You said it was done 2 weeks back.
Yes.
What do you think? What was the reason for the surgery? So it was done at an institution.
Because of the synovial life.
So what do you think? Looking at the scar, it is an anteromedial longitudinal scar. What do you think was the surgery done? So that also should give you tips again. What do you think? What could be the probable reason for the surgery?
Collection, fluid collections.
No. See, there's a long scar around 10 centimeter. What procedure do you think could have been done?
Arthrotomy.
Okay, it could have been an arthrotomy and synovial biopsy also. You understand? So you have to open up your thing. It may not just be a post-traumatic problem. Okay, looking at the scar, it was done at a premium institution. You understand that. You have to think of other possible causes for this swelling as well as a valgus deformity. So any other differential diagnosis? Now again, you have to start thinking, can it be infective? You understand? Whether it can be any inflammatory condition, any primary synovial condition. You understand? Then sir gave you tips. You have to be very smart in the exam. See, when they sir saying again and again, look at the spine and all. Why? Why did you look for proprioception? What is the reason sir was telling that?
So much of
swelling and pain. He is walking without any pain.
Pain. So what condition do you think about? See, having valgus deformity, you expect lots of pain, but still you say that he's walking reasonably comfortably well. What should you rule out?
Charcot.
Ah. So we have to think of whether it is a neuropathic joint. If you understand. So that's the way sir kept telling you, did you look at the spine proprioception and all? So you have to be alert to the clues given. You understand? So it is not just a traumatic pathology. You're clear about that.
Okay.
So you have to tell the examiner, sir, there is a scar, some procedure has been done. It could be a synovial disorder. Okay. It could be it could be infective. It's always any condition. Infection is always a differential diagnosis. Okay, because they have done a synovial biopsy. So, but then only thing, the history is not fitting because the pain reduced. Okay, in infective, you don't expect that history. Another important thing is whether it could be, again, because he doesn't have much pain, whether it is a neuropathic joint. So all these should run in the back of your mind.
Okay.
So much of swelling.
Synovial chondromatosis, pigmented ulnar synovitis. These look like a more of synovial pathology with a secondary bony support. Any X-ray is there?
X-ray.
You said there is a lengthening and increased girth of the limb and other thing. No, it is there from the beginning before the fall or
before the
did
fall.
you ask the parents?
Yes, sir. Before the fall, it was not normal, sir.
And there was no deformity before that.
Yes, sir. No deformity.
There's one congenital condition called hemihypertrophy. Sometimes it happens in neurofibromatosis. All this, they have a increased girth of the limb. Read the X-ray.
So, it is a plain X-ray showing a anteroposterior lateral view of skeletal immature bones of distal femur, proximal tibia, and proximal fibula. There's bony fragments present in the lateral.
Any other X-ray without the drain before the surgery? You have any X-ray? This is done after the surgery. No, you have any X-ray before any intervention? Yeah, this is better. Yeah. Then what are the findings?
The lateral side of the distal femur, there was a bony fragments.
Bony
There
fragments.
is a bony.
There are multiple bony fragments are seen on the lateral side. Anything else?
Medial side of the distal femur is enlarged. Enlarged. Sir.
In X-ray, you don't what is happening to the soft tissue. There's a lot of soft tissue swellings around the joint. So multiple bony fragments are seen. What happened to the femoral condyle?
Lateral.
Is that bony fragment continuous with the patella or is separate? Is there any valgus deformity in the femur?
Sir?
Is there any valgus deformity in the femur? Clinically, you told there is a genovalgum. No, is there any valgus?
No.
You also told, no, and the inflection disappears.
Yes, sir.
Is there any valgus in the femur? No.
Present.
Present. How do you say?
Sir, for that, I have to draw the
Lateral distal femoral angles. Lateral distal femoral angle. It's obvious that it is a valgus deformity in the distal femur. Soft tissue swelling. Some loose bones are there. Patella, I'm not able to see clear.
Was there any CT or MRI taken prior to the surgery?
Yes.
Intersurface of patella around.
Yes. CT scan and MR.
So what is the finding in the CT?
Lateral
You can see a lot of erosion in the femoral condyle, no? Lateral femoral condyle.
yes, sir.
Anteriorly, a lot of erosion. Some erosion in the undersurface of patella, the loose bodies.
Price is closed in the distal femur.
Closed. Closed. The synovial proliferation with there is bone destruction is also there with the loose bodies.
Yes.
Any blood investigation was done? You want any other investigation? Count ASR, CRP.
Purulent infections, I will and ESS. That has complete blood count.
Can it be tuberculosis?
But sir, but patient doesn't have symptoms and loss of weight, loss of appetite, and
Based on the what do you think based on the imaging?
MRI, you have any MRI?
yes, sir.
Okay, you can see the extensive. Okay, you can see the effusion. There is definitely a synovial hypertrophy. All that you can make out of the MRI. See what we are trying to tell you. See see if you look at the CT, there was a lot of sclerosis of the femoral condyle. See, normally what do you expect in active tuberculosis infection? What finding do you normally expect on X-ray and CT?
Edema.
So
Edema
there will be a juxta-articular.
Sclerotic or osteoporotic?
Bony edema presence.
See, on an X-ray, you'll find that there is a juxta-articular osteoporosis. Okay, the bones will be osteopenic in an active tuberculosis infection. But in the CT, you notice that there was sclerosis of the femoral condyle. So again, that is not matching with the active tuberculosis infection. You understand?
Yes.
Okay, so here you can see there is a hypertrophy of the synovium. Okay, you can see there is a effusion. So that is the reason why they have done most probably they have done a arthrotomy and a synovial biopsy. Okay, so we are still stuck. We are still not sure what it could be. A primary synovial disorder, as you said, like a PVNS or any other synovial pathology. It could still be, right? No.
Spite of all this bone erosion, the child is not having any pain. Still, probably neuropathic joint with the bone destruction.
Okay, so because you see,
Synovial tumor.
Synovial biopsy will give you a clue for the diagnosis, or it can straight away give the diagnosis.
spine, you said there was some scoliosis in the spine.
While sitting, the scoliosis is corrected. Sir.
Okay, okay. So
what is the MRI report?
Any MRI spine, so because it's all again matching with the neuropathic joint. The sclerosis, the distal femur, loose bodies. Okay, so there is loose bodies adjacent to the. Okay, so MRI, the spine is a must to rule out any intraspinal anomalies.
Thank you.
Thanks.
There was a fracture in the medial condyle.
Thank you, sir. I request Professor Parni, sir, to felicitate the panelists. Dr. Manoharan, sir. Professor Gopi Shankar, sir. Thank you, sir. Next, we have a presentation on examination of shoulder joint by Dr. Jay Ganesh, sir, Assistant Professor.
Good afternoon. கேக்குதா? Yes, sir. Good afternoon. கேக்குதா? இல்லையே. சரி. Okay. இங்கே இருக்கட்டும். Good afternoon. Today we'll have a short discussion about the clinical examination of the shoulder. So, history taking is very important and it gives us clue as to where we are looking for the pathology. So, the first thing that we are going to take into consideration is the age of the patient. Let's segregate it into two components, less than 40 and more than 40. So, which are all the conditions which are common in less than 40? You have instability, especially anteroinferior glenohumeral instability, glenoid labral tears, anterior and posterior labral tear, slap tear, superior labrum anterior posterior tears, long head of biceps tendon tear, and supraspinatus tendinosis and acute calcific tendinosis. And when the age is more than 40 years, you'll have to think about rotator cuff disease or tear, subacromial impingement, AC joint arthrosis, subcoracoid impingement, bicipital tendinitis, and adhesive capsulitis. Pain. When it comes to pain, you'll have to ask about the grade of the pain in VAS scale, whether it worsens at the night, whether it radiates from the neck, and what movements are difficult in activities of daily living. So the cuff and adhesive capsulitis will worsen at night. The radiation may be because of a cervical disc disease. Loss of abduction will suggest cuff tear, and global painful movements would suggest adhesive capsulitis. So it is very important to assess the amount of pain and the duration of pain and also the diurnal and nocturnal diurnal variation. So when you want to do a basic assessment of the shoulder, it's important to first clear this, and his trunk should be visible, and you should assess the patient for wasting, scars, sinuses, and prominences. And it's very important to assess the range of movement, and especially two components, the active range of movement and the passive range of movement, and do resisted isometric testing and proprioception. So when you're doing an inspection, it's important to inspect the patient from the anterior, lateral, and posterior aspect. In the anterior aspect, you're going to look into the bony prominence, some asymmetry, look for the bulk of the pectoralis major, look for the bulk of the deltoid muscle on the lateral side. And when you go to the posterior aspect, you should always compare both the sides and see for any wasting on the supraspinatus and infraspinatus fossa. And these pictures, for example, show the inspection from the anterior aspect from the posterior aspect showing a Sprengel's deformity, and from posterior aspect again showing wasting in the infraspinatus fossa. So always look for, and the next we'll go into the active range of movements. The first thing is elevation through abduction. Always be mindful of the fact that abduction happens at 1:2 ratio. 1 is the ratio happening in the scapula and 2 is happening in the humerus. So be mindful of the scapulothoracic rhythm, which is visible from the posterior aspect. So this is an example of, so this is active abduction. So active abduction up to 170 to 180 degrees is normal. So then what we follow is forward flexion. So forward flexion 160 to 180 degrees. Then what we look for is extension. Okay. So whatever happens, you should see from the sagittal plane, the coronal plane, the trunk should be in the midline. The trunk shouldn't sway. So when there is a pathology, it is prone for the patient to compensate by swaying. So should be mindful of that fact also. So external rotation 80 to 90 degrees. So compare it from the opposite side, and adduction, that is from 50 to 75 degrees, horizontal adduction, horizontal adduction, and also you should look for scapular protraction, retraction, elevation and depression. So one gross test, the screening test which we can do proceeding for specific test is aptly scratch test, where we try to put both try to touch the fingers at the back. Okay, right. Okay, pa. So what it does is on the upper arm and on the arm that is inferior, it checks the picture of the functioning of the shoulder. Okay. Now we'll the specific test, the test for supraspinatus, test for joint pathology, biceps tendinitis, and test for slap. First is the assessment of individual muscle test. We start by putting the upper limb in 90 degrees of abduction and forward along the plane of scapula 30 degrees, and then we are going to internally rotate it and ask patient to abduct it. So if he is having pain and the weakness, it is indicative of supraspinatus tear. You can test you towards the upside and check. So what it says is empty can test predominantly say the integrity of the posterior part of the supraspinatus tendon. And full can test, first one what we can do is a resisted external rotation test. So always compare it with other side. Okay. So another thing is on door sign. So where you ask the patient to keep in the position of convolular every way. So if there is a pathology like you see in the picture in the right side, is elbow will be above the level of the shoulder. So next one is external rotation lag sign. You passively rotate the arm, externally rotate, and you. So if the subscapularis is intact, the arm is going to come into internal rotation. So that is external rotation lag sign. One is this. The first test is belly press test. So so belly press, what happens is in normal patients, the palm is flat on the belly and elbow is either at the level or anterior to the trunk. Whereas in pathological patients, what happens is the elbow is behind the level of the trunk. So as you can see in the right side of this patient. The next one is Gerber's lift-off test. So you ask the patient to keep the dorsum hand posterior aspect of the Go check it. So you're going to see whether he is able to lift it off from the back. Okay, this says that his subscapularis is okay. Now you're going to check it by trying to now you're going to check it by pushing it inside if he's able to resist. That is how you're going to check the power. And in internal rotation lag strain, what happens is if you keep the patient's arm like this, it again goes back and touches the back. That is internal rotation lag strain. So next is you have a test for scapular function. The scapular elevation, you check for trapezius. Yes. So then you check for the retractors. Yes. So next for test for impingement. So arm is abducted to 90 degrees and degrees, and you do complete internal rotation. Now if the patient is having, as you go into internal rotation, if the patient is having pain, it is positive for Hawkins Kennedy test. So next you go for test for post stability. There are two tests we can do. One is jerk test, one is skin test. Jerk test do it with stabilizing the scapula and make the patient lie supine also, and you give a downward pressure with this arm and give a posterior pressure. If you feel a clunk or pain, it's positive for posterior instability. And test for impingement, that is painful arc test, you ask the patient again to abduct side. So between 60 to 120 degrees, the patient is having pain, that is positive for impingement syndrome, and between 150 to 180 degrees is mostly positive for acromioclavicular joint pathology. The next one is test for impingement test. In this test, you ask them to flex 90 degree, internal rotate, and you do passively while stabilizing the scapula. So the patient is having pain in the acromioclavicular joint. It's also positive for knees test. The Yoakum's test is you put the hand on the opposite shoulder and you elevate the elbow. So there is pain in the acromioclavicular region. It is positive for impingement. So next test is test for anterior inferior instability. These are actually provocative tests, not advised in acute patients. First one is apprehension test. Put the arm in 90 degrees of abduction and external rotation. You can also give a posterior force. If the patient complains of pain and becomes apprehensive, it's positive for apprehension test. Next one is relocation test. That is, you give a posterior force to the anterior aspect of the humerus and the patient feels secure. That is positive for relocation test. Then quantitative test, you can know how much lax there. That is done with anterior drawer test. You keep the arm in 80 to 120 degrees of abduction. 80 to 120 degrees of abduction, 20 degrees of forward flexion, 20 degrees of external rotation. So what you're going to do is you are going to grade the movement. Okay. So when 0 is when little to no movement is noted, 1 plus is in translation to the glenoid rim but not located. Plus is translocation is dislocation over the glenoid rim but with the spontaneous reduction when the force is removed. 3 plus is if translation is consistent with dislocation without reduction. So test for inferior laxity. So inferior laxity, the number one is the thing is sulcus sign. So what you do is keep the arm in neutral, but downward pressure. You are going to assess the acromihumeral distance and grade accordingly. That's like less than 1 centimeter, 1 to 2 centimeter, more than 2 centimeter. Next one is Gage's test or hyperabduction test. You stabilize the scapula and you abduct the shoulder. So as such, the glenohumeral joint true movement is only up to 90 degrees. And any further movement beyond 90 degrees, that is more than 105 degrees to be particular for Gage's test, indicates there is some inferior laxity. So always when you see a instability case, it's better to looking for bait and scaling, that is like looking for hyper extension of the fifth metacarpophalangeal joint, and passive opposition of the thumb to the volar surface of the forearm, and hyperextension of the knee, hyperextension of the elbow, and forward flexion at the trunk where the patient is able to keep his flat palm in the floor. So between 0 on hyper, you label it as moderately hypermobile. 5 to 9, you label it as excessively hypermobile. And slapped superior labrum anterior posterior tear. Actually, there are not many specific results for slap tear, but the one with the common consensus is O'Brien's test, that is active compression test. You ask the patient to do 90 degrees of forward flexion, 10 degrees of adduction, and ask the patient to further flex, and the patient is having pain, that is positive for O'Brien's test. Next one is a passive distraction test, where you ask the patient to hyper abduct up to 150 degrees and the forearm is in supination. So if the patient tries to pronate, he will have pain. That indicates superior labral tear. So next is test for biceps tendinitis. First one is Ergason test. Second one is speed test. Ergason test is specific for pain and also stability of in the biceps screw. So you go at 90 degrees, the forearm is pronated. You ask other we feel a popping sound or pain, it is positive for biceps stability as well as pain. Next one is speed test. Speed test, you ask the patient to keep the elbow in extension, degrees of, and ask the patient to, if the patient is having pain, that is also positive for biceps tendinitis. So other test is AC joint tenderness. So you ask the patient to put the hand, affected side hand on the other side, and you try to push and also palpate the AC joint at the same time. This is positive for cross-body adduction or scarf test. So that's it with my presentation. Thank you.
Thank you, sir. Next, we have a short case presentation by Dr. Arun Mondi, final postgraduate at Madras Medical College. I'd like to invite Professor Natarajan sir, professor at Panimala Medical Hospital, Professor Ram Prasad, professor at Stanley Medical College, Professor Suresh Kumar sir, professor at Tirunelveli Medical College, and Professor Vel Murugan sir, professor at Government Royapeta Hospital, on the stage for chairing the discussion. I also like to welcome Professor Palni sir, Unit Chief at Madras Medical College, to the panel.
Good morning, sir. Good afternoon, sir. Myself, Dr. Arun Mondi, from the postgraduate from Madras Medical College.
Usually in exam short cases, whenever we present, so most of the times you will be asked to tell the diagnosis, and then you will be able to assert it in your why you have made the diagnosis. So we'll go in that fashion for this case, as we are already running short of time. So now you will tell the diagnosis.
My diagnosis is 70 years old female with rotator cuff arthropathy and rotator cuff tears.
So whenever you tell a diagnosis, you should tell where it is present, number one, whether it is in the shoulder or elbow or wrist. That is number one, whichever joint is affected. And you have to tell the side, anatomical side, and then only you have to come for pathology. And then complications, whatever may be due to it, that also you have to include in the diagnosis. That completes your complete diagnosis. So you all the postgraduates, just to make after your examination, you make a diagnosis and rehearse itself before you are going for the exam. So that is very important. So you want to revise your diagnosis now.
Yes, sir. 70 years old female with left shoulder rotator cuff arthropathy due to rotator cuff tears.
Okay. So usually age we don't tell in diagnosis. So left-sided rotator cuff tear.
What is rotator cuff arthropathy? Is the arthritis in rotator cuff? What do you treat? Arthritis of the?
Arthritis of the shoulder joint.
Okay. That is due to
Rotator cuff tear.
not rotator cuff.
You understand?
Okay.
So again, you tell your diagnosis.
Left shoulder joint arthritis secondary to rotator cuff tear.
Okay. So this is how somewhat we need this. So the diagnosis should be clear. And then now you will ask the question that why you are making the diagnosis. In that you have to tell the relevant points which suggest your diagnosis.
Tell me history-wise, suggesting your diagnosis. History alone.
History-wise, patient was having complaints of pain over left shoulder for past 7 months. Before 7 months, she had a fall while carrying a water pot in the left side and sustained injury to left shoulder. But she was able to do immediately activities after using left upper limb after the injury, but with pain.
Diagnosis is positive points in the history.
Okay.
You are trying to present the case as a long case. அது வேண்டாம். அதான் சொல்றாங்க. ஓகேவா?
So whenever you are asked, now you have to tell the age, which is very, very relevant. Just as Jagani sir told. This is above 40 or below 40. Occupation, what was her occupation? What was he doing? How the injury occurred?
Okay. My positive history is a 70 years old female with pain over left shoulder and restriction of movements over left shoulder for past 5 months. Restriction of daily activities like wearing boots on the left side, personal hygiene using left hand, and hair combing using left hands.
Is a left-handed person?
Right-handed dominant persons.
You want anything about the pain?
The pain was progressive in nature, aggravated by daily act. Initially, side elevation was restricted, followed by further restriction of movements over the first 5. Then relieved by temporary medications.
Tool of diurnal variation, was it in any the pain anywhere related to rotator cuff arthropathy?
Sir, wrist was present, sir, and the patient was able to. The pain was also when on the patient turns on the lateral side while sleeping, left side while sleeping.
Do you have any differential diagnosis? Suppose it's a case of advanced capsulitis, arthritis shoulder.
Diagnosis. He's asking the question. How do you differentiate that with your diagnosis?
Sir, adhesive capsulitis, there is and the age is 70 years, at least more common in middle-aged women, and also she is having pain till now, sir.
Pain till now means what? What do you mean?
Sir,
the rotator cuff arthropathy, they will present pain, have pain from the beginning of the injury up to this time.
Yes, sir. she was able to do external rotation and internal rotation are possible, sir, up to 70 degrees of external rotation and 50 degrees of internal rotation is still possible, sir.
See, the question is how will you differentiate between adhesive capsulitis and a case of rotator cuff lesion?
Is it possible?
Pain is a common thing for both.
Is it possible in history?
She had a history of she has a history of self-fall, sir, and trauma to the left shoulder.
So what will happen to the movements in adhesive capsulitis? What will happen to the movements in?
In adhesive capsulitis, the movements are globally restricted, sir.
Which type of movement you are talking about? Active or passive?
In adhesive capsulitis, both active and passive shoulder movements restricted. In arthritis, active movement is restricted. Passive movements is more than active movement.
So that is the way you have to generally differentiate between these two conditions. Okay.
In history wise, it's very difficult. In examination, movements is the important key to differentiate between these two.
Okay, proceed with
the joints involved?
No, sir.
No, nothing. So, any constitutional symptoms are there?
No, sir.
Okay.
You proceed with findings, inspection, palpation, movements.
Yes, sir. Positive findings in inspection, there is muscle wasting in the supraspinatus and infraspinatus and the posterior deltoid muscles. Then palpation, anterior joint line tenderness presence, anterior humeral joint line tenderness presence. Movements in flexion, abduction 0 to 30 degree, adduction 0 to 40 degrees present, sir. Internal rotation up to 70 degrees present, external rotation up to 70 degrees present, internal rotation up to 50 degrees present. In passive, with passive range of movements, forward flexion is forward flexion and extension is same as active movement, sir. But in abduction, passively able to go up to 50 degrees, sir.
Not much a difference.
Not much a difference.
Okay. So all the movements are painfully restricted.
Yes, sir.
Except internal rotation.
So internal rotation is also restricted. Only pain is eliciting only at the end range of movement, sir.
You said you told me, that he had a fall 7 months back.
Yes, sir.
But for the next 2 months, he was all right. She started pain only. You said the deformity is only for the past 5 months.
Pain was initially, yes, sir. Restriction of movements after 2 months.
After 2 months.
Yes, sir.
So in rotator cuff tear, why are you so particular in rotator cuff tear? I say it is actually this can be a frozen shoulder, adhesive capsulitis. There is no definitive finding for you to say rotator cuff. It need not be even arthritis. You said in even frozen shoulder, you will have pain anteriorly.
Yes.
Why do you say arthritis?
Do you have any crepitus in moving the shoulder?
I could not able to appreciate any crepitus.
No crepitus. Okay.
Please demonstrate flexion of the left shoulder.
Yes.
So whenever you are asked to demonstrate a movement, you must position the patient, position yourself, and you have to use your hands where you will be keeping, and then you have to do the movements according to the plane, actively, passively, and then all these things.
So you will to demonstrate active flexion.
Yeah, you keep the mic down, and then you do the demonstrate. Whenever you are asked to demonstrate, you please do it. Because you have already done for the patient during your examination, you just demonstrate it. So after that, you do passively. So you have to stand behind the number one, and you have to stabilize the scapula. Then you do the forward flexion, and it should be done 15 degree little bit adducted so that in the true plane. Okay. Do it. So it is restricted. Both active and passive movements are same, and the flexion is restricted to 30 degree. Okay, fine. So demonstrate abduction. So they will tend to sway to the opposite side.
So that's why you have to stand behind the patient most of the time. You stabilize the suprascapular region with your hand, one hand, and the other hand, you can lead the patient to do the movements. The end point of your abduction is when the patient starts to lift the trapezium, the shoulder. Yes.
What, how do you, what is the diagnostic test for tear? Rotator cuff tear. You know, just, yeah. You said tear, no? Demonstrate. Yeah. She's holding.
Is she able to hold consistently for some
No,
time?
that is not needed. She's holding. So there is no drop arm test. Then why did you say the word tear? You are telling the diagnosis, you should establish.
At around 50 degree, patient is pain, and after 50 degrees, she is.
Can be signs.
See,
so you have no signs for arthritis. Even arthritis, you have only told tenderness. Maybe restriction of movements all around the world. But it can be even present in frozen shoulder.
see, there may be a degeneration in the rotator cuff muscles and their attachment. So that can cause pain. And subsequently, because of pain, the patient is not moving the shoulder. That may lead on to stiffness. So this pain and stiffness can get combined together and present like this. So if you want to say that there is a tear, that means I assume that it is a complete tear.
It's a pathological.
In that case, there should be no movement for that particular muscle. If she is able to do it actively, then you should change your diagnosis. Maybe a degenerative change. Degeneration may be there. That may cause pain. It may not be a complete tear. Even if there may be a partial tear, the remaining tendon may be intact. So before telling that there is a tear, you should confirm that that particular movement is not there or not possible actively.
The shoulder. She can abduct the shoulder. Okay.
Okay.
And in this case, in case of any painful shoulder, if you start doing any empty can or full can, everything will become positive. Seems to be positive. It's not originally positive. Any painful shoulder, if you do any test, it's not valid. Okay. Otherwise, asymptomatic shoulder, otherwise passive range of movement is full. In that shoulder only, you can get that classical drop arm sign and empty can and full can and all those things. Not in this painful shoulder. This is a painful shoulder. Okay.
Painful and stiff shoulder. Because
say that. That is the point I'm.
Okay. Movements are important, and active and passive movements you should do separately and for individually. And if they are restricted, means there is a stiff shoulder. And if there is only tear, then passive movements will be full. And you have to check for power of the muscles. So if the power individual muscles, as told by Jay Ganesh, you have to tell supraspinatus, infraspinatus, teres minor, or subscapularis. Depending on it, you have to tell what cuff muscle has been torn. You understand?
Yes.
So here it is a stiff shoulder. So probably if you want to tell it is due to rotator cuff, means very difficult to tell the power now because movements are restricted both actively and passively. You understand?
Yes, sir.
So what will be diagnosis now? Always diagnosis means, remember, any diagnosis should be having two parts. One is anatomical, the other is pathological. That is etiological. So etiological may vary, but anatomical should be very correct. For pathological, you can give differential diagnosis. For anatomical, there is no differential diagnosis. Okay. Now revise your diagnosis here.
My diagnosis will be left shoulder. Anatomical diagnosis will be stiff shoulder. Pathological diagnosis would be I would like to give probable diagnosis. First diagnosis frozen shoulder. Second diagnosis rotator cuff tear.
But again, you want to say rotator cuff tear only. See, this is a case of 70 years old, stiff shoulder with global restriction of all the movements, probably due to rotator cuff degeneration or adhesive capsulitis. That will be a fair diagnosis before going to the investigations.
Think of other diagnosis like TB shoulder, something like that. Apart from your
on exam, history was no any constitutional symptoms, and on examination there was no wounds.
It's uncommon to have shoulder TB.
Yes.
Not common.
How will you proceed? I would like to take X-rays, AP and lateral views of left shoulder.
Lateral, do you take it?
No, AP views.
So whatever you are going to tell, you tell. Okay. So please be aware what you are speaking in exam. All PGs for that matter. So don't say routinely anything. Okay. So
I would expect in this patient any arthritic changes or else proximal migration of humeral head, any cyst, bone cysts or anything. These are the things I would.
So you want to look for any reduction in the joint space medially, as well as proximal migration of the head of humerus touching the acromion. Okay.
Yes.
Right. Where is the X-ray?
And also look for any calcific tendinitis.
Yes. Okay.
This is plain radiograph of anteroposterior view of left shoulder of a skeletally matured individual. Aligned normally. In this X-ray, there is a proximal migration of humeral head and decreased. There is generalized osteopenia when a cortical thinning is present.
How do you find any changes pertaining to arthritis?
Sir, the joint congruities are normal. And also for joint space, I would like to take a glenoid view so that to look for joint space.
A glenoid view or some other name? Gracie. Gracie's view, true AP view. That is to offset the scapular this thing. Okay, so you have to keep the 30 degree, you have to keep medially and project it laterally, so that you will get a true view of the joint space, as well as the glenoid will be seen from front, not from the side as it is here. Okay, gracious view. There is no change in arthritic, the articular surfaces. They are all smooth and seems to be intact. The space seems to be maintained. Now, what is your thing? Actually, this X-ray was probably not taken in the right view, correctly
How do you
positioned.
know this is proximal migration of related to proximal shoulder joint?
So, there is a Molini's line broken, sir, and also there is a decreased acromiohumeral interval.
Again, it depends upon how you take the X-ray, weight, stress view, and all those things only. Small position patient can give a wrong diagnosis also.
Next, what do you want to do?
In surgeon's point of view, you infer from X-ray, which cannot be seen in any other investigation. If you are going to operate in this patient. You should look for any osteoporosis around the greater tuberosity. If at all, if she is having rotator cuff tear, you need to plan for the implant. Suture anchor, what type of suture anchor she will require, and all those things. Okay.
Okay. Moreover, you look for the type of acromion also.
Yes.
So in X-ray itself, you can make out. So whether it is type 1 or type 3,
yes,
the triangulation you can make out.
Okay.
Whether it is the cause of the rotator cuff degeneration. Sometimes the acromion may cause impingement on the rotator cuff, and that may get degenerated. So that also you have to look for.
Okay.
Next, what do you want to do?
I would like to take a MRI left shoulder. Sir.
MRI. Dr. Viba. Okay, what is this view?
This is a.
What section is it, and what weightage is it?
This is coronal sections.
Okay.
So T2 weighted images.
Okay.
In MRI there is a joint effusion, sir.
Okay. Now comment about the articular surface, and then about the muscle which is seen there. Are you able to see any muscle there?
No, sir.
One muscle is prominent there, coming from the acromion and curving laterally, wrapping around the head of humerus, going down distally beyond head of humerus. What is that?
That is lateral fibers of deltoid.
Okay, so
yes,
deltoid is seen.
Yes, sir.
What about your muscles which you are talking about?
I am looking for supraspinatus.
Where is the supraspinatus?
I could not able to visualize.
You are not able to visualize the supraspinatus. Okay. Then what other section you want?
I want sagittal sections.
You told rotator cuff. That means it's not only supraspinatus. What other muscles are there? What you want is this?
Yes, sir. Infraspinatus. For that, I will like to take axial views.
Okay. Is there any other view? See, you need serial sections. Then only you can see infraspinatus posteriorly, subscapularis anteriorly. All these things continuity you can see. Okay, now to comment. Where will you look for infraspinatus in this patient? Use your pointer.
Sir, for infraspinatus, I would look for the posterior superior at the greater tuberosity.
Okay, so the muscle which is on the posterior side, coming attached to the greater tuberosity is the infraspinatus. So is it there or not?
Here also, I could not able to visualize.
Some fibers are seen there in the first one, left side. Yes.
This.
That is infraspinatus. Okay.
Okay.
Then what about subscapularis?
Subscapularis in the lesser tuberosity.
Yes. What do you find in this patient? Subscapularis, where is it? Is it okay or not okay?
In this patient, subscapularis integrity is okay. Sir.
But there is hyperintensity inside the substance of the tendon, isn't it?
Yes, sir.
So there is hyperintensity signal in the substance of the tendon of subscapularis. Okay. Is there anything seen in front of the subscapularis? Anterior to subscapularis.
There is a hyperintense signal around the biceps tendon.
And that is head of femoris. I'm talking about insertion of subscapularis anterior to that.
So there is hyperintense.
Yes, that is one. So again, there is a fluid collection there. Yes. So fluid collection is there in the anterior aspect also. Okay.
Yes, sir.
Okay. So subscapularis, there is degeneration. Infraspinatus, it is partly visualized and appears to be involved in the pathology. And suspiratus, you are not able to visualize. So these three tendons are involved in this patient. And there is fluid collection also.
Yes, sir.
In the anterior to the coracoid and in the roof and everywhere it is, fluid collection is there. Okay. Right. Any other section? That's all. Okay, now what is your diagnosis?
What sections are important now? Which has been missing here?
A sagittal section.
Yeah, what will you look for it?
I would look for a tangent sign in the.
Yeah, what is it?
It is a. There is a should draw a line from both acromion and coracoid process angle. If the
See, you must look for how the muscles are. That is important. See, the quality of the muscle is very important, which has not been shown in any of these views. So whether there is any fatty degeneration or muscle atrophy, how much occupancy is there of the muscle in their respective positions, based on which only you can further go ahead. There are some amount of fluid collections present outside the capsule, maybe in front of the muscles or all. What do you think they are?
Bursal inflammation.
Okay, so you have to rule out any other infective pathology also in this lady. Okay. So how will you do it?
I would like to take biopsy.
You have to do normal
blood
investigations. So like counts, ESR, CRP, all these things. Okay.
You can even aspirate. You can even aspirate instead of doing a biopsy, right?
Okay.
Okay. Now, how will you treat this patient?
So it is a pure case of what you have told in the diagnosis after seeing all the MRI and all. But clinically, it was not there. Now, what you want to make a diagnosis now? What is your diagnosis now after doing all the investigations?
Left shoulder, stiff shoulder. Secondly, to rotator cuff tear. Retraction.
Rotator cuff degeneration. And possibly a supraspinatus complete tear, because we are not able to see the tendon. And if you have more sections, coronal sections, you may sometimes be able to see the retracted part of the tendon that we cannot see here. So now what will you do for this patient? What is the problem now? Why she has come here?
She came to OPD.
Stiffness of the shoulder and pain in the shoulder. Okay. Now you have diagnosed that there is a problem in the rotator cuff, and you have to address the stiffness. What will you do? Somebody attended the Spot Hospital CMU on Sunday last week. I don't know if you attended or not. So what was the magic that was made on that day? Without surgery, he performed it in the stage itself for 2 patients, similar patients. Dr. L. Prakash. He injected ozone and hydrogen into the joint, and within 10 minutes, there was global restriction of movements became global normal movements. It's not just like that. I am not making a joke. It's not a comedy. He did it for 2 patients. So without surgery, if that is possible, that is the demand of the patient. Why don't you try that? Okay, if you want to do surgery, what will you do?
I would do. First, I want to look for muscle quality through MRI, sir.
Consider that the rotator cuff is not efficient in this patient. Only deltoid is working. What is your plan?
I would measure the retraction, sir. Amount of retraction the rotator cuff tear is. If it is with the available image.
You mean to say that you want to repair the rotator cuff in this patient?
The bone.
Suppose it's beyond the possibility of repair.
I would go for a superior capsular reconstruction.
In this age?
Bone quality is looking good.
I want
sir.
one answer.
Non-operate.
Surgery. Deltoid is working. All the other rotator cuff are not working.
Reverse shoulder.
That's what I am expecting from you. So reverse shoulder arthroplasty is one viable option in this patient.
Okay.
If she wants
So
only
then
pain relief, what else can be tried? And if the patient is not affordable,
Humeral head excision.
what if it was, you can inject some.
She has not come for any extraordinary strength for the shoulder. Can try mobilization and anesthesia and anti-inflammatory measures. I think that will solve the problem. With physiotherapy, she will have good result. Rather than doing shoulder and
Reverse shoulder is a very demanding and very under anesthesia. Maybe very handy for this patient. So we'll complete this patient.
Rotator cuff tear and arthritis. Definitely, that is the time when I will be definitely upset about you. Fortunately, we were able to see. So that's what all the people were trying to say. So that you have got the tip, and that is what which irritates the exam. So now.
Any other cases there?
That's it.
Okay. Thank you. Thank you.
Sir, I request Professor Singara Vadivelu sir to felicitate the panelists. Professor Velmurugan sir. Professor Suresh Kumar sir. Parni sir. Break for lunch. Lunch is served in hall. Please be back by 2:30 for the next session.
most important thing is the host. Nepal to miss what happened most of the time. So you know what we are going to deal with it. That's more important. Usually what we need to do, we are my infections true anywhere between skin and soft tissue. How to diagnose meningitis? Orthopedic doesn't want to know meningitis, but see fever, altered mental status, shortness of breath, chest pain, put pneumonia diagnosis. But most important thing, you people do a lot of things there. Before putting an implant, how many people do urine routine and urine cultures? Urine cultures, not routine, urine cultures. Infection anywhere. So how many do urine cultures? Nobody. But in reality, we get a bread and butter from most of the time urine cultures, but do urine cultures without any symptoms. If you do urine cultures, 100 can go in. But we are not giving daily prophylaxis. If you do a brushing of the teeth because of the brushing, but you are not giving antibiotics daily. Bacteria in the urine is called asymptomatic score. Bladder score means the B stands for in the bladder, B stands for blood in the urine. 1 point. And patient has got abdominal pain. Yes. So abdominal pain. And there are two D's. So we put this score 2 points. So B of urination. This is called bladder score. Out 6 points, at 4 points the patient should have for assessing in urine culture. When you want to do a urine culture, just send urine routine along with urine cultures. Most of the time they're getting a call, urine culture, 1 lakh call. When I ask what symptoms, there is no. I'm asking urine routine. Look, so join anything, never do it. Back can happen.
take osteoarthritis, very important for you. Local examination, focus on the local examination. That is very vital for you. Ask for symptoms when it's going on. Then you need to look up at the adjacent joints also, not only the specific joint what the patient is pointing, look at the adjacent joint. And more important, hearing on overside compared to hearing on underside. Similarly, newborn, I do pediatrics also there. Difficult to recognize the symptoms in the newborn and children is pretty difficult. Similarly, elderly people also don't expect all signs and symptoms of infections in elderly people. High risk means always open fractures has got a high risk. Come the one. So don't the sample in formalin. If your pathology, one sample for culture. Culture won't cost mail for culture. That's more important for you. Then other things like PMP more on ESR and CRP group CME. WhatsApp group education portal is going on there. Written there. People got offended. Yes, ESR and CRP always take with a pinch of salt. The clinical picture, ESR and CRP coming join, but don't think CRP correlated with the So we need to about it. Infections with fracture less than 2 to 10 weeks, more than 10 weeks, and more than 6 months. That is called infected non-union. Osteomyelitis or vertebral osteomyelitis to you. Infection is usually less than 2 weeks. More than 2 weeks, we can consider as a vertebral osteomyelitis. This is also a lot of fixation devices. Sorry. So these are all the devices people are using it right now. Infections. The sinus is a typical one. I'm looking at it. These are all the implant. I'll show an implant in a minute. Next. So whether it's a bone and joints, the management principle is same, except the bone and joint infections. Always these things you need to come. So what is prosthetic joint infections? Why I needed what kind of overtouch sustaining it and success. mode. Purulent discharge. These two criteria me, if not other things like inflammation signs are classic signs of inflammations, or we need to think about ESR and CRP, but ESR and CRP alone does not make a diagnosis. That's more important. What you are seeing inside the theater, inside the operation theater complex, that is more important. That's why we read what you written in the notes, surgical notes. We want to she's a 60-year-old obese lady. Immediately within a month, January 20, operated. And February 2022, from the bilateral, I informed the surgeon of the phone orthopedic surgeon. He asked, oh, I thought cleaning means he'll do in the OP side, but the surgeon did that there also. After that, culture was negative. He given 6 to 12 weeks after he used it. So the surgeon knows well what to use it. Antibiotics for 12 weeks. Right now, my discharge is not, and I'm not able, and she's not able to walk. That is why she got admitted in another hospital there right now. And we did the stage 1. And stage 1, fortunately, growing some organisms there. So, and she's very happy. At last, I know what organism is causing disease. I do not know whether she's going. Previously, there's no infections he can escape. Now some organism is going. I do not know. So what is the diagnosis now? It's still mechanic. Muscle spasm, that's what the terms are used by other orthopedic surgeons. Even Beach Candy Hospital surgeons say maybe muscle spasm, do some good physio. PJI. I got the organisms now. It's PJI only, no? All of the above. So PJI definitions, against lot of definitions, lot of changes keep on happening with the PJI. But you usually look at the two things. Sinus present, that's more classic for me. In the absence of sinus, always whatever symptoms I told, pain, redness, tender, restrictions, movement, elevated ESR, CRP, all suggest problem or organism is growing. So this is a beautiful definitions of EBJIs, European Bone and Joint Infection Society. They told 3 parameters. Parameters, laboratory parameters, and radiology alternate diagnosis of infection. Similarly, laboratory markers, we need to get the organism. That is why you need to send multiple samples. Don't send one sample. If you are doing a stage 1, send minimum 5 to 6 samples. We need to get 2 to 3 samples growing same organism. That is classic of prosthetic joint infections. Only one sample is growing. The organism is not typical, maybe probable prosthetic joint infections. Nothing is growing, chances are a bit low. And finally, if you want to doubt, we need to go, previously people go with the technetium bone scans. The bone scans uptake is very high. Patient 40 ml. Don't do any swab cultures. Particularly when the patient is pus is pouring, immediately don't take the pus. Wash the pus, take some the sample from the tissue, or press on the deep or from important. And they without stopping antibiotic, don't send the cultures. If you are doing a prosthetic arthroscope. Then he taken to the tap water, put the flush on the tap water. I was stuck. I need to do the sterile water, or if the sterile water or alcohol. The last step after the disinfectant is over, we need to flush the disinfectant with the sterile water, or we need to do with the, what do you call, we need to deal with the alcohol. This person went to the tap water and asked, sir, I'm doing for this one because sterile water we are not purchasing for the last 2 months. Non-TB mycobacteria, common source, particularly first 1 month will be normal. Then 1 month later, the non-TB mycobacteria will come up. That's the reason they're getting infections. Not a problem of surgeon. This is a problem of arthroscopic cleaning. So you go and operate in a small place, and the arthroscope is not cleaned properly, not flushed properly. Whatever scope you are injecting, NTM will grow. And NTM is very difficult to get away with it. And whatever debridement, next time they debride it, I won't come. I did a very good debridement. It won't come back. Within 1 month, it will come back. Unless we put an appropriate antibiotic for NTM. ATT will not work. Your rifampicin, INH, ethambutol, pyrazine will not work. We need to put a specific medication, then it will subside. So arthroscopic cleaning is very important thing. Think about it. So you check with your housekeeping guy who is doing the thing. They will flush with the tap water. So that's the problem. If you want to get more healed sonications, unfortunately, none of the corporate hospitals also doing the sonications. This is a sonication method. We need to extend the implant. Then we put it in a ringer lactate solutions. Then we need to vortex, again put the sonications, again vortex. But this vortex as well as sonicator is not available. Even in the corporate hospitals I'm talking about, it's not available. Then imaging is other modality, particularly technetium scan after 6 months. You can do the. Yes, very difficult to pick it up. Yes, we can pick it up. That's good for you. These are all the sensitivity and specificity. WBC has got very poor sensitivity. ESR slightly better. CRP even more better, but not appropriate. Then again, whatever scans I told, that's better choice there. So this is a culture organism. Those who are sitting in the back, I'll read the organism is Klebsiella. And sensitive to gentamicin resistant, piptas resistant, amikacin resistant, cefotaxime resistance, amoxicillin resistance, ciproflox resistance, cotri resistance, your etapinum, meropenem, biapinum, cefoperazone sulbactam, everything resistance. What are you going to do? What will you do? Last option is there, no? Xavier is there, no? That also you don't want to do. Okay, fine. So previously 1940, no antibiotics, eat the root. 2010, antibiotics are not working. Again, go back, eat the root, or arrange a prayer meeting for these patients, or go for amputation there. That's what we need to do there. So problem is, that is why we said, don't put your septum and don't put your linezolid prophylactic there. So fracture means, first thing you look for the fracture consolidation, whether the fracture is united or fracture is not united. Similarly, the prosthetic joint is stable or prosthetic joint is not stable. Similarly, if the bone is there, whether the bone is intact or not, it's more important. Then try to eradicate the infections, do the source control. That is most important thing. Without source control, it's very difficult for us to do. Then healing of the soft tissue should be taken care. Preventions of the chronic osteomyelitis and functionality. The three things is history of infections at the site of infections. Difficult to treat pathogens. What I shown is a difficult to treat pathogens. Lot of good options. Ciprofloxacin, Cotri is the best drug. Unfortunately, it is not working. That's a bit difficult for you. So you people like this one, irrigations and debridement, and try to retain the implant. But as an ID doc, we want to remove the implant because biofilm form means a bit difficult to do the thing. Even if we had rifampicin, it is not going to work most of the time. So we need to think about it, what to do it. Ideally, this is ideal approach, but this is optimal approach because patient does not want these are all good postagent. Cotrimoxazole is other good. Gram-negative resistant to ceftriaxone is 80% of the time. Ciprofloxacin resistance is very high. If Cipro is good, who use the ciprofloxacin? Cipro is not resistant, ceftriaxone. Ceftriaxone resistant, cefoperazone sulbactam or piperacillin tazobactam. But piperacillin tazobactam we need to give 3 times a day. Cefoperazone sulbactam twice a day is fine. Similar to the meropenem, only it won't cover pseudomonas once a day. So we need to give opioid therapy with the minimal injections is possible. I'll come back and explain some of the antibiotics, what we are using little later. What is a gram-positive agent you are using most of the time? After surgery. Ceflox. Okay. Linezolid? After linezolid, anything has come? Yes. Bidacolin. Bidacolin is for TB. Tidozolid has come. Linezolid is 600 milligram BD. Tedizolide is 200 milligram once a day. The toxicity is not less. You people put linezolid for 6 weeks. The body is not tolerant. Person developing optic nerve. Don't think put linezolid, keep away. Linezolid is terrible drug to use. Don't think linezolid is a safe drug to use it. Linezolid is a terrible drug. Always keep the linezolid for the last 2 weeks. Even 2 weeks of tolerance is a bit difficult, but fortunately now tedizolide in Indian market, only tablet form, but tedizolide is comparatively linezolid. Linezolid means 600 BD, 1200. Tedizolide is 200 OD. So a lot of benefit is there. So these are all the oral options. Nowadays, infectious disease, 2 mantras come. I'll show in the 2 mantras. This is one of the mantra. Oral option is there. Oral option is the best option for you. Actually, we want to give IV antibiotics, but now previously we used to give 2 weeks because I need to put a PICC line. Because the central line will get infected, your peripheral line will be not working. So I need to put a peripherally inserted central line catheter. That is difficult. Only few hospitals are putting it, but PICC line is good. So couple of French studies that FCLA, when resistance to common antibiotic, they're trying with the page therapy. Local antibiotics, you want to always mix with the cement. Lot of things. Right now, aminoglycosides, vancomycin, you can mix with it. Other things, we need to adjust the suitability with the cement. That's most important thing. Don't go with all things. People are putting imipenem, meropenem in the cement. They are not going to work with the cement there. So we need to know what is working with the cement. Usually aminoglycosides will work with the cement. Vancomycin will work with the cements. Colistin will work with the cement. That's more important. And hardware, we got a scoring systems. If the scoring is more than 10, we need to remove the hardware. Whether to retain the hardware or remove the hardware, whether it's a fracture, whether it's a prosthetic joint infections, we need to put the scoring system there. Prevention, people always want to do pre-op what we need to do. Some of the orthopedic surgeons I know, they close the operation theater once the patient was wheeled in. Because if you see, we did the audit. Once the patient wheeled into the operation theater, how many times the door was opened? 43 times within first 10 minutes. I'm not saying the entire durations. 43 times. Simply still reason. That's why one of the lot of air exchanges keep on happening. You say laminar hair. Laminar hair will be lost once the person theater is opened up. So don't keep on shuffling the room. Don't keep on increasing the number of people in the theaters. So this is called the 7 bundle, but for me, only 1 S is very important. Take shower, that is more important. 1 S is short antibiotic. Don't think if I give cefuroxime, if I give linezolid for 5 days, 7 days, it will prevent infections. No, it increases your gram-negative problem. It increases the resistance. 1 dose of antibiotic, 1 hour before surgery. Stop it till I want to need. It increases the resistance. It won't prevent. The bacteria will get resistance. Very difficult to treat. So if you stop with 1 dose, even if the patient develops antibiotic-resistant infection, easy to treat. Easy to treat. If you continue the linezolid, continue cefuroxime, you are in big trouble. So in short, early means early infections, try to retain the hardware. Try to retain the hardware, do a proper cleaning, proper antibiotic selection so you can get away with it. 2 to 8 weeks always is a difficult situations depending upon the risk factors. More than 10 weeks, if the person is not healing, there's no point in keeping the joint. We need to go with the prosthetic joint. Usually in prosthetic joint, DIRE is a first step or single stage revisions, or you want to do a 1-stage exchange is an ideal thing for prosthetic joint most of the time. And finally, some of the patients are not affordable, or you don't want to lose the mobility, do the arthrodesis, that's fine. Or sometimes chronic long-term suppressive therapy, yes, together we can do it right now. That's also possible. So early means debride and retain it. Late means always remove the joint and treat it appropriately. That is more important. So nowadays, there's 2 things. Short is sweet. Yesterday, one of the groups I put it, one of the trial called Solario trial. Anybody read it? Solario. Short versus long durations for intraoperative infections for orthopedic implants. Short versus long. It's called Solario trial. Started in 2019. Yesterday, the results are out. 7 days of antibiotic is fine for implant. Once you remove the implant and put some local antibiotic stimulants, 7 days of antibiotic is fine. If you want to get away with long acting, for example, gram-positive, very difficult to give vancomycin daily, teicoplanin daily, PICC line, nobody is putting for me. Dalbavancin is available. Dalbavancin is once a week injections. Tedizolide is a once a day tablet. Dalbavancin is a once a week injections. A lot of gram-positive, but for gram-negative, I use cotrimoxazole oral tablet, minocycline oral tablet, Chloramphenicol. You people are using outdated. I'm using chloramphenicol, bread and butter for me. Chloramphenicol is an excellent drug, excellent penetrations into the joint. The anemia, neutropenia won't happen. So use these type of oral options. So one shot is sweet, not only for pneumonia. Pneumonia means 3 days. You have prosthetic joint infections, people are coming down. Previously 12 weeks, 24 weeks, 6 weeks, now 3 weeks. Yesterday, Solario says even 7 days is fine for that. Solario says 5 days is fine for it. So we need to know, that's why the duration is keep coming down. So short is sweet. Do not irritate the bacteria. Do not irritate the bacteria. Surgical prophylaxis means 1 dose. If you irritate the bacteria, bacteria produces resistance. That's the moral of the story. And oral is equal to IV. Whatever antibiotic has got good bioavailability. Linezolid has got good bioavailability, but toxicity is a concern. Cotrimoxazole, good bioavailability. Toxicity is not a concern. Long-term problem will be there. Ciprofloxacin, working use ciprofloxacin, levofloxacin. Unfortunately, in India, resistance is very high. Amoxiclav as a last resort because amoxiclav is not great. Penetration to the joint is not great. That we need to keep in mind. Ciprofloxacin means 750 BD. Similarly, piperacillin tazobactam means 4.5 grams TDS. Meropenem means 1 gram TDS. Use the maximum dose, minimum durations. Alexander Fleming during his Nobel lecture, what he told, people are abusing antibiotics is going to develop resistance in 1945, he told. So what is the mantra he told? Use the maximum dose, minimum duration. He told in 1945. We are reinventing in 2024, maximum dose, minimum durations. That is the best way to get away with your bacteria. So use maximum dose, don't underdose it, don't underdose it. This is a trial called OVIVA. It showed oral versus injectable antibiotic. Injectable antibiotic 5 to 7 days is fine, then change it to oral. But nowadays, injectable antibiotic 2 to 3 days, change it to oral. That's a mantra we are using it now. See the studies there. 2 versus 4 weeks, all are almost equal stage. IV antibiotics only 1 to 3 days, 2 days, 3 to 5 days. People are not using for 14 days or 7 days, provided good oral option. If there is no good oral options, we don't have thing. If the oral option is good, we can try 2 to 3 days of IV, change it to tablets, change it to tablets. I do not know how to draw this one, but ask something related to the infections. I'm happy to take it up. So those who want, this is a group, general group I'm running at. I thought of specialty wise group I'm creating. So this is an announcement I'm making for the orthopedic. Those who want to join the group, click the number and send the message to us. We create an exclusively dedicated orthopedic. You don't want to learn the general medicine, don't want to learn the general ID especially. If you want to learn infection in orthopedic practice, what antibiotic, if the ID is not available to you, yes. Because I do fracture related orthopedics in Sundar Medical Foundations and prosthetic joint with the SIMS there. Almost all prosthetic joints we do. We do only revisions, only our specialties there. And we do in Apollo also a lot of joints, particularly the spine joints we are leading with the learning. So almost all the joints I do. And we call ortho ID is come up now. The specialty of ortho ID is coming up. So we need to use ortho ID, not general physicians or general ID. So we need to get a specific opinion. This is a way we can get a specific opinion. Thanks for the wonderful opportunity. Any questions, I'm happy to take.
Thank you, sir. Is there anyone in the audience who has questions for sir? Please raise your hand.
You can shoot.
Thank you. I request Professor to felicitate the speaker. Have a good.
Nice. Come up.
Rifampicin, using rifampicin for dead space infections.
The controversy whether the rifampicin for the prostate joint, if you are MRSC, that point of time rifampicin, costly agents. If you are trying to do a DAIR, if you want to retain the implant and the organism is a staph aureus or staph epidermis, then that point of time you can use rifampicin. The dose you need to use is 600 milligram once a day or 900 milligram once a day. That's what we need to use it. So yes, we can use. But toxicity is always concerned. People won't tolerate. Closely monitor rifampicin. But nowadays, controversy, rifampicin is going to really a biofilm effect people are talking about. In infective endocarditis, we use rifampicin is slowly going away. Patent is retained, implant is retained, MRSA or even Staph aureus or MRSE, Staph epidermis, you can.
Sir, excuse me. Sir, is there any role in intraoperative local application of antibiotic?
They do. After the thing, they put even a small catheter inside and keep the catheter and pushing the antibiotics. We reviewed the literature, there is no role. But Siemens, you can. For example, if you keep a cement, you can mix with antibiotic, whatever compatible with that double, you can use it. But there is no installation that is not going to help. Keep a small catheter inside the synovial thing and keep the catheter out. They inject the vancomycin injections every day there. But nowadays, what the Solaria trial says, locally eluding antibiotics, that we need to put it in the cement or eluding things along with systemic antibiotics, 7 days, you can get away with the infection. That's what Solaria, but Solaria full trial is not out. Only initial results out. So everybody is jumping yesterday. 7 days is a good for orthopedic infections.
Thank you, sir. Next, we have another talk on bone and joint infections by Dr. Next, we have another talk on bone and joint infections by Dr. Suresh Kumar sir from Tirunelveli Medical College.
So good afternoon, everybody. So we'll be, since the initial talk is about bone and joint infection, so we'll be talking here about more about an exam setting where an ASCII is given to you and questions will be raised based upon a given situation. Next slide, please. Next slide. So some audience can tell me what it is. What somebody is telling? Yes. Yes, please. What is this? Bone scan. Absolutely right. This is about bone scan. So this is basically bone scan. Now tell me why this bone scan is important in the year of 2024 when every institution, every region wise you have MRI, CT, other higher modality of investigation is available. Do you still need to do a bone scan in a given case like this, orthopedic infection? MRI bone scan is relevant in this 2024 also in the sense that sometimes you not be able to do MRI when a given implant is placed in the patient. The MRI will produce a metal artifact. We are not able to get certain information because of the presence of the metal. One, that is the one important reason you can find out bone scan as an important tool for finding out infection. Number one. Number two, in certain cases, when you want to find out the infection much earlier, within 24 hours, 48 hours, when the MRI lags in time, MRI wants some time for the infection to settle and produce a reactional changes. Whereas bone scan, based upon the blood flow, it can find out the changes. So bone scan, as you know, for theory writing, it is three phases are there. One is called flow phase, early phase, and then there is a. So three phases are there. So one is the flow phase, other one is equilibrium stage, and then third one is excretory stage. The first stage is dependent upon the how much amount of isotopes are being flowing in the blood. Depending upon the vascularity, the flow will be increased. The second stage is the isotopes being taken from the organs.
And the third one will be retention of the isotopes by the region wise. When the retention is more, means there is some infection or some pathology is there. There is a concept behind the 3 phases of the radioisotope scanning. So what type of isotopes are being commonly used? Can anybody from the audience tell? What are the isotopes commonly used for bone scan? Technetium, very good. Then gallium and indium labeled, very good. Indium labeled leukocytes. So among these 3, the gallium and technetium almost they play a complementary role. That is, if you do technetium along with the gallium scan, information will be better. Rather, if you do in indium labeled leukocytes, the advantage is the leukocytes because they are antibody, they are something like anti-defense mechanism against the bacteria. They will load or they will localize only to the area where infection is present. So indium labeled scans are better for a infection control, infection diagnosis. But it is an investigation where you take the indium leukocytes and then label with indium. These are the things which are disadvantages for it. But otherwise, it is more specific for infection. So I told you there are 3 phases: the relevance of bone scan in the current setting and the isotopes which are used. I think you know what is hot spot, cold spot. You know that. More uptake is called as a hot spot. Now the common organism, as I previously told, it is a common organisms are being escaped. I will tell you in case of acute hematogenous osteomyelitis, Haemophilus influenza, H influenza is a cause in acute hematogenous osteomyelitis, which is common in the neonate or infants. The second one is the reproductive age group starting from 20 or 40 years. Neisseria gonorrhea is the commonest organism. And of course, nowadays the current trend is methicillin resistant staphylococcus aureus, MRSA, one of the common organism. Apart from this, certain conditions like salmonella is common with the sickle cell anemia. These are certain entities which you have to remember, and of course, it depends upon the institution and the region where you practice. So coming to antibiotic delivery system, which is presently we talked about, we know very well the commonly used antibiotic delivery system is the PMMA, that is a cement coated antibiotic. We have taken cement, about 40 gram of cement, and then mixed with antibiotic powder. Either it can be vancomycin, tobramycin, sometimes even fluoroquinones also used, gentamicin used. These are mixed in the theater and then they are made into beads, then applied to the infected area. You know very well, when you apply the antibiotic beads over the infected area, the antibiotic delivery to the particular area is very high, which will clear away the infection. It is said it is about 200 times greater when you apply by parenteral route. As we know, parenteral application produces liver toxicity, renal toxicity, and so many side effects. Whereas a local delivery of antibiotics without any side effect, and you are getting the advantage of clearing the infection. But the important disadvantage of a cement beaded antibiotics is you have to remove this cement beads at the end of 6 weeks. So you're putting the patient for a surgical risk, but again at 6 weeks time, which you don't want. So in this current scenario, now we have an antibiotic delivery system, which is totally absorbable, resorbable by the system. Can anyone tell what is the antibiotic coating resorbable system where there is no need to remove the antibiotic beads? Can somebody tell what it is? Huh? Stimulant, basically you are right, but it is only a commercial name. Right to call as a pharmaceutical name is a calcium sulfate cements. These are totally absorbable calcium sulfate cements, which you apply, and the antibiotic is delivered to the systemic, local system, and there is no need for any surgical removal of the implant. Stimulant is absolutely right, but it's a commercial name. Similarly, this is again one of the slides showing what is stimulant. You have the cement, mix it with the antibiotic. When you mixing with the antibiotic, remember, you have only add about 10% of the total weight of the cement only you have to add. Suppose you have only 40 gram of cement, you can add only 4 gram of antibiotic, not higher. Okay, so this type of antibiotic is mixed with the stimulant or bioreabsorbable system, made into small pellets, and it has to be applied over the area. So this is one of the X-ray where a stimulant is applied to the distal tibia. After 4 months' time, there is a good consolidation of the distal tibia infection site. So this is, I think there is no need for this because I already covered this antibiotic regimen. May I ask you one question? What is the antibiotic of choice for it's a MRSA infection? MRSA. Methicillin resistant staphylococcus aureus. What is the antibiotic of choice? Vancomycin, correct. One more? Clindamycin. One more thing is the clindamycin is also another good option. Apart from this gram-negative bacillus, you can start with any form of third generation, fourth generation cephalosporin. That is also good. This is again pathogen related antibiotic resistance. This is been covered. So I skip on this slide. So what is this diagram is about? Supposing if you ask if a given station is lice, what is this? I think it is written in the screen also. NPWT. What does it mean? So negative NP means negative pressure vacuum therapy. Negative pressure vacuum therapy, where a sponge is applied to the wound area and then adhesive film is trying to, as adhesive barrier is applied over it, a suction pump is attached to it. You know very well, because of the suction, the wound edges, the bacteria, secretions, everything is got sucked inside, and the edges also become closer to each other. So you'll be able to clear the infection as well as you are able to make the wound to heal also. Not only in case of a compound injury, this can be used for covering the soft tissue defect while dealing with a chronic osteomyelitis. So this may be asked in the question when you are having a chronic osteomyelitis case, given the exam, or femur, and then how do you manage a soft tissue defect? That may be a question also. So what is this reamer irrigator aspiration device? If I remember correct, I think last year before this question was asked in the MS Ortho theory examination, RIA technique. So what is this reamer irrigation aspiration technique? So basically, this is while reaming a long bone intramedullary system, we made with two problems. One is a fat embolism, other one is a thermal necrosis. Okay. So in order to avoid these two complications, AO has evolved into a principle where while reaming, an irrigation fluid is introduced into the reaming system. Because of the irrigation fluid, the pressure, the temperature is not rising up. Okay. Temperature is not rising up because of the irrigation fluid. Apart from this, the material which are reamed while reaming, the intra-endosteal surface, intramedullary substance are also aspirated. So you have a dual advantage. One, you are removing that, you are reaming it without making it more thermally dangerous because you are adding a fluid, and also you are aspirating it. So there is no question of fat embolism. This is a concept behind RIA technique. Subsequently, this is also the amount of material aspirated contains little bit of bone tissue, bone marrow, other things. These have mesenchymal properties which can be used to make the bone to unite. So this is a dual advantage. In addition to non-union of bone, this can also be used in chronic osteomyelitis where the aspiration fluid, irrigant fluid, can be loaded with the antibiotic of choice, and this will help in removing the infection. So in addition to non-union, you can all be used in case of chronic osteomyelitis of the tibia or femur. So what is this Lautenberg drainage system? This was previously Sir is telling about a closed suction drainage system. This is a system where intramedullary a catheter is placed, which is a dual lumen catheter. Through the outer lumen, the fluid is given or sucked. Through the inner lumen, the antibiotic is administered. You can administer the antibiotic as long as you keep it. Even once you start with the antibiotic, let us say broad spectrum antibiotic, after 2 days you get a report from the antibiotic, you can very well safely given over the system without any toxicity to the patient, systemic toxicity to the patient, a purely intramedullary one. This is also this is called as a closed Lautenberg drainage system. Though this classification, this is a very common. Cannot afford to go to the examination without reading this Cerny Medar chronic osteomyelitis classification. Now let me ask you a question, the physiological class, the last one. What do you mean by C host? There is prohibitive host. What do you mean by prohibitive host? We know the host, normal host and compromised host, we know very well. Normal host is normal human defense mechanism. A compromised host means either HIV or a diabetes or some form of What do you mean by prohibitive host? Anybody answer? What does it mean by C host? compromised. Results will be prohibitive. How much or you'll be having only a compromised results. That way it is called as a compromised host. Next slide. Similarly, in the anatomic type, you can concentrate on the medullary disease. Okay, now the previous one. So this is as named, it is called as a Brody's abscess. If a given case is given in the exam, don't tell the examiner this is only a classical case of Brody's abscess. As pointed out previously, you must only give a differential diagnosis. This is a osteolytic lesion in the metaphyseal region, well-defined margins, well demarcated zone of differentiation, osteolysis. So what are the other differential diagnoses you want to offer? Don't always commit to focused on osteomyelitis, because I am talking about osteomyelitis could be only osteomyelitis. It can be so many other bone cystic lesions, some other chondromas. These are many other possibilities. So don't always stick up to Brody's abscess. Brody's abscess, as you are aware, it is a subacute osteomyelitis when the defense of the individual is very high, or if the organism is low virulent, it can produce a subacute osteomyelitis. This is a classification. What is the classification name of subacute osteomyelitis, Brody's abscess? Anybody? It's called Glut-Gills classification. Now coming to this is a Gary sclerosing osteomyelitis. Initially it was considered and placed under subacute osteomyelitis. Subsequently, it was brought, it was not categorized as the form of osteomyelitis because the diagnosis is, etiology still uncertain. It is tend to be a low-grade anaerobic infection where sclerosis in the X-ray is the most predominant finding. Usually it doesn't much well respond to antibiotics. It needs a lot of time. So that is why it is placed in a separate chapter. There is also another variety which is called as CRM, chronic resistant multifocal osteomyelitis, which you go and read. Okay. Now, what is this diagram here? What is this X-ray is about? What is this diagram? It is sinogram. So, what is a dye injected in sinogram? Methylene group. Many dyes can be injected, but methylene group. What is the use of sinogram in the present day orthopedics? Is it commonly practiced in orthopedic department? Sinogram, when it is needed, when you have multiple sinuses, you don't know which sinus is the one which is taking you to the cavity. That is the time a sinogram is more useful. It is dye is injected 24 hours prior to the procedure, and you will be able to find out this sinus having connection with the cavity, and you will be able to find out the secostum there. That is the role of sinogram. Of course, modern day it is not much used. So these are the various methods to fill up the bone gap defect. Once you cure it, we know the saucerization curettage, you cure it everything, you find a cavity, big cavity there. Then how to fill this cavity? You can fill the cavity with the bone graft, which is called the classical Pavanius method of bone grafting. You can fill it with the muscle, or you can fill it with a free composite flap. A free composite flap is the one which is mobilized from a different distant site and anastomosed to the parental site. And then this may have skin, subcutaneous tissue, muscle, even sometimes bone also. A free composite muscle is something like all-in-one. So now we move on to RNTCP. Initially it is called the Tuberculosis Control Program. Now it is called Tuberculosis Elimination Program. The government has taken so many efforts to control and eliminate tuberculosis. The drug treatments have been changed. So now let me ask you a question. What do you mean by first one, RRTB, which is called the rifampicin resistant tuberculosis? What is the test which is commonly done in the college or somewhere to find out whether the individual, the mycobacterium is resistant to INH or rifampicin? What is the test which is called as CPNAT? What does CPNAT stands for? Cartridge-based nucleic acid amplification. The first topic is RRTB, that is rifampicin resistant TB. The second one is called as the MDR-TB, multi-drug resistant TB, where it is resistant to INH and rifampicin. Sometimes it may also have resistance of fluoroquinolone also. That is why I placed it in the bracket. The other one is a pre-XDR TB, which is having resistance to INH, rifampicin, and almost always to fluoroquinolones. This is called as the pre-XDR, extended drug resistant tuberculosis. The third, fourth one is the XDR TB, which is called as the extended drug resistant tuberculosis, which is almost resistant to almost all common drugs. The important addition here is the bedaquiline. It is resistant to bedaquiline. That is why it is become called as the extended drug resistant tuberculosis. Next slide. Previous. So this is a drug treatment strategy for drug resistant. The common one is called as a 2 months of HREZ and 4 months of HRE. The drug resistant tuberculosis, you start with the six months of levofloxacin. LFS stands for levofloxacin, and then rifampicin, ethambutol, and pyrazinamide. For the XDR or MDR-TB, it is 4 months of bedaquiline plus 6 months of multi-drug containing levofloxacin, clofazimine, pyrazinamide, and ethambutol. So this is the obstetric joint infection. If you find the major criteria, if your sinus tract directly connecting with the prostate, it is also considered positive. These are minor criteria. We have extended, we have so many biomedical markers, like starting from CRP, alpha-denifensin, and then leukocyte estrase, these are the other biochemical markers which help you in making a diagnosis of a prostatic joint infection. SAR was studying what is DIAR actually? It is called debridement, antibiotic, and implant retention. So whenever you find that your TKR is getting infected within three weeks or 4 weeks time, you open that, give a debridement, and then exchange the liner. In TKR, why do you exchange the liner? Why do you exchange the liner instead of exchanging the whole process? Is just exchange the liner itself. What is the use of infected? Yeah. So once you exchange the liner, you are able to approach the posterior capsule much easier. You will be able to debride it and wash it thoroughly in the posterior aspect of the knee joint much better if it remove the liner, and then freshly apply a liner, which is of course cheaper also and modular. So that is only if you are able to diagnose the infection within 3 or 4 weeks time. Supposing now the question comes, the patient reports to you late as 6 weeks or 10 weeks time or months later. Now the question is whether to do a one-stage revision or a two-stage revision. One-stage revision is almost always preferred by surgeon as well as the patient. But there are certain contraindications. So for example, if the soft tissue cover of the implant is not proper, if you are not able to decide what or not do a single stage revision, because you don't know who your enemy is. You have to find out who your enemy is. And your supporting stuff, that is the soft tissues around the joint, the vasculature, everything has to be intact. Go for a single stage revision procedure. Otherwise, you debride and put spacers. Nowadays, we have got articulating spacers also. These spacers are placed either in the hip or knee joint, will allow some movement for the benefit of the patient. And then you revise it at the end of 6 weeks or 8 weeks time, and then go for a original processes. Okay, next slide. So fine. I think that is my last slide. I thank you for your patient listening. Journal Orthopedic Associations, thank you very much for your patient listening.
Thank you, sir. Does anyone in the audience have any questions for sir? No? Okay. Thank you, sir. We will now move on to the next session on ward rounds. To chair this session, I'd like to invite on stage Professor Tolkapian sir and Professor Pasupati sir.
Selected 6% or they are voluntary.
Volunteer.
So anybody to volunteer for the first case? First ward rounds. This is almost like what you are doing in the ward rounds. It's an exercise for you to learn. This will be helpful for your exam.
யாரும் பார்க்க முடியாது. Come, come.
You can come to the stage.
So bowler bronze lane, sir.
Come to the stage.
Mention the name, followed by single surgeon or who is
bowler brawn bowler is a different.
Yes, one single surgeon or two surgeons?
Two surgeons.
Two, sir.
Bowlers,
Huh?
bowler, two surgeons.
Two people.
Who are they? Actually, both are not orthopedicians. One surgeon is orthopedic surgeon, another. So bowler is the father of modern orthopedic dermatology. Braun is father of local anesthesia, but he's basically orthopedic surgeon. This horizontal invented by Braun. The vertical frame and other two pulleys are invented by
Bowler.
Okay. Do you know what are the pulleys? Can you name it? 1, 2, 3 like that?
So here there are three pulleys, sir. The first pulley is for calcaneal contraction and distal tibial contraction, and the second pulley is for upper tibial contraction, distal femur contraction, and a third pulley is for foot drop. We do it.
Foot drop?
Foot drop.
So to prevent equinus contraction, actually prevention of the equinus contraction.
Is there only three pulleys or distal femur contraction? For distal femur contraction, we'll use the fourth pulley, sir. Actually.
In this case, what type of traction applied?
Upper tibial contraction.
Upper tibial contraction. How will you insert the upper contraction pin?
And inferior, posterior and distal.
Posterior and distal from medial to lateral?
And from
lateral to medial.
Lateral
to medial with the head of the fibula, anterior or posterior?
Posterior, sir.
Inferior and posterior, inferior and anterior. Why? It should be lateral to medial. Why not from medial to lateral?
To avoid the nerve injury when we are inserting the pin, sir. To avoid iatrogenic nerve injury, inserting the pin, sir.
Okay. What's the traction's name here? What are the traction types of traction, you know?
Skin traction, skeletal traction, this type of skeletal traction, sir.
Yes. Skeletal traction, how much weight you can apply?
Balance traction.
The sliding traction. If in case like we can elevate the patient's and foot end.
This is used as a fixed one or a balance one?
As a balance one.
Yeah, what do you mean by that? Balance. Anybody?
Example for traction. Thomas splint we can use as a fixed traction.
Yeah.
Thomas splint we can use as
Thomas splint is a device used for fixed traction.
Fixed traction. Traction against a fixed point. Here the tractions are in opposite directions. So it's called this tug of war like situation. This is called balanced traction. Any other? How will you increase the counter traction?
So we'll place two bricks at the foot end of the
Yes, you can elevate the foot end, then thereby you can increase the counter and can use mattress instead of bed.
Use for traction?
stirrup.
Stirrup?
Bolus stirrup.
So what are the complications we can get? Your bolus strap. There are some possibilities of
infection.
getting it infection, no?
Skin
It can
infection.
press over the skin.
Increase it.
Can move the skin that way. Is it applied with the bolus traction here?
No, sir. No.
This
Straight
traction is
in-
applied without bolus traction.
without bolus.
So we have to apply the bolus traction.
Bolus
Means there will be a
There'll be a
blocking screw. It will block the sideways movement of the splint. If that is not done properly, it can impinge over the skin and produce an ulceration there. No? So that has to be avoided. By spreading it also, it will give a uniform traction. That is the advantage of using a stirrup there. Okay, right. So the fourth pulley, what you said? There is one more pulley we can add, no?
Distal femoral.
Yeah. What's the advantage of using the fourth pulley? Calcaneum. It will prevent the equinus deformity. For preventing the equinus deformity, we will use the additional fourth pulley. Okay. So what other complication will expect in this?
If the pin is not properly drilled into its two anterior, we can still produce iatrogenic fracture.
Okay.
Heel sores. So when there is inadequate padding beneath the sole, there will be a heel pressure sore will form.
Yeah, pressure sore on the heel is very problem. Manage also. So what knee joint? Any traction and produce on the knee joint. What will happen? Yeah, you can
Because of,
produce laxity. How can you avoid that? Your calculation should be correct. You should not over distract also. And your balancing also should be correct. Should not be unidirectional. Bidirectional means it will be balanced better. Okay, right.
In the frame, you can notice there is the bend, the proximal area. Where should be the bend? How will you place the patient over the bent area? What part of the body should be there? What is the advantage of the bend? Arvind, anybody in the crowd?
Then give one more mic there.
Usually we are putting some bolster underneath. Why? At the time of surgery, we are
Relax the hamstring. Hamstrings relax.
yes to prevent the contraction developed by the hamstrings, thereby preventing the distal fragment movement. Okay, you're gonna contract after the skull tendon. Okay, next slide. Next, from the MMC.
Two more can come. From MMC or from Balaji? Anybody from Balaji Medical College? Please come. This is an exercise. We may be the exam. It will be useful for you. You attend here. Anybody from Balaji Medical College? Anybody from SRMC? Nobody is willing to come. This is very simple. Yeah, come. Two more can come.
Not even into PG, can I?
போட்டுமா
Ah,
உங்களுக்கு தெரியுமில்ல விஷயம்
no problem. Discussion.
அருண் கம்
Welcome, Gandhi. வாங்க. வாங்க, வாங்க. We are waiting for your time. Right time.
You have come.
கால் பண்ணிட்டே இருந்தேன், எதுக்குள்ள போனேன்?
So we are making wardrobes like this.
Okay. It was the man of Elizaro. Sorry.
Right person to ask question with. So what is this device?
Elizaro external ring fixator.
What is the condition for which it is applied?
Flexion deformity of the knee joint. Yes, sir.
Yes, is kept it. It's a unilateral problem only. Yes, sir. Pterygium knee. Any posterior soft tissue contraction of the knee skull. So we have applied. So what is the principle in applying this kind of? How will you, if a child is presenting with a pterygium knee, so what is your treatment plan? How will you start? Before starting applying this, any other thing you will do, or only directly will go for Elizaro only?
We have to. Yes, or a soft tissue pathology.
Most of the time it will be a soft tissue pathology only. Okay. Solely a soft tissue pathology. So you should know is the part of a isolated pterygium alone or a combination maybe a part of an ortho or any other joints, X-rays and look for any other associated problem. If everything is there, then you can do a soft tissue release. What is the idea of doing a soft tissue release? Either only you do the soft tissue release on the knee level or anywhere else. Before you release, always better. Any deformity correction, always little bit of soft tissue correction. Then you can apply your external device to have a better correction. Okay. This means always you have to only correction. All the corrections should be done only with external physical alone. So here also you have to do a soft tissue release combined with your Elizaro. So that's what we did in this case. Okay. But the soft tissue release is not only at the knee. It has to start from the ischium to the calcaneum. That is an important thing. Pterygium is a problem which is arising because of contraction of soft tissue from the ischium to the calcaneum. So you have to attend at 3 levels. One at the knee level, one at the ischial level, another correction. If it is present, you have to attend the calcaneal also. But luckily this patient extending up to the foot.
About basics. What is this? Hinge level, like a hinge. Where will you keep the hinge for the knee joint? What is the normal hinge for the knee? Normal mechanics.
In the knee joint, we have to keep the hinge at the femur epicondyle levels.
Epicondyle. You know, like where is the entry point for the DCS? If you do a DCS, there is a point, anterior 1/3, posterior 2/3. You know that? Entry point for DCS, or if you do that, that is the axis of rotation for the knee joint. But in knee joint, the tibia movement from the extension to the flexion, it moves away from the J shape along with the collateral ligaments. So here keeping a hinge for this case is sometimes if you keep it in some abnormal place, maybe if you keep it so much posterior, what will happen? You may extend it, maybe you get into the subluxation or dislocation of the knee joint. Very careful about using the hinge. So distraction, no, this is a gradual distraction. So what we are doing here is, like what is plasticity, elasticity, definition. Elastic is, if you stretch it, regain the original position. Correct? Yes or no? Elastic. Plastic is like if you keep it for a long time, it will increase length. Same principle we're using here. During Elizero, gradually distracting, we make it as a elastic of ligaments and muscles. Like what you're doing is a gradual distraction and keep it for a long time. It make it as a some stretching exercise. So it stretches all the posterior soft tissue along with the capsules and muscles, whatever the contracted tissues. Maybe like as I said, like a pterygium band from the ischial tuberosities or calcaneum, and also muscles into the posterior part of the hamstring and gastrocnemius. Posterior capsule of the knee also. So normally we used to keep the hinge anterior 1/3, posterior 2/3, and also like what is a wrist structure at the knee joint? Popliteal artery and nerve. So normally, if you want to distract, mostly you keep the hinge centering the nerve on this thing. We don't want to stretch on the nerve. Even if you distract here, there will be stretch will be more in posterior and anterior will be less. So always take care of stretching the nerve neurovascular structures. That is the basic principle for using a soft tissue contracture like correction by using Elizero. Okay.
What is accordion maneuver in Elizero? The regeneration is slow. The regeneration is slow. You have to achieve compression and distraction at the same time.
In a sequential manner, you have to do this accordion. Anything other than basic?
So what other complication other than the hinge placement if you have to end up in some subluxation? Any other complication you expect on the course when you distract? Yeah. So if the hinge is not, these forces will be on the wires. So if the hinge is not, ultimately somewhere you will get a fracture. Right? Then yeah, there maybe some fractures. Okay. Then figures. Yeah. Okay.
Clotos or weakness deformity in the
Yeah,
ankle.
the possibility. So the other joints, may develop. So those spanning the two joints are likely to, if you trying to stretch it, somewhat likely to produce a contraction. You have to keep stretching those. And then the vascular problem also you have to keep in mind when you going to stretch such a long contractures.
So when you make a ward rounds for this patient, what are the things you look for? How will you take care of the pin site? And what other immediately the day after your procedure? Next day, what are your options? Why there is a footwear on the toes? Why it is up, right?
To prevent equinus.
Prevent the equinus deformity. Right. So other way of avoiding this equinus deformity. Why you are getting equinus deformity? What is the reason? Anybody? Is it only gravitational or anything else?
Movements will be painful if in case it is the wires are passing through the muscles. Like the patient when it moves.
Yeah.
Very painful.
Yeah, your pins are passing it can tether your soft tissues also. That also can produce deformity. Suppose you are doing lengthening in this case. Here it is only correction of deformity. Suppose you are doing lengthening. In that case also you are likely to develop an equinus deformity. Okay.
Equinus is like attachment of gastrocnemius here. Suppose a flexion contraction, there will be a contraction of gastric part of the gastrocnemius. So what happens if you try to correct it? Like it's an indirect lengthening of the muscle can produce equinus. Always now, like we put a foot frame to prevent that, and also like if you chronic cases, long cases with flexion deformity, there will be a flexion contraction of the gastrocnemius. What is the action of gastrocnemius? It's actually plantar flexion, also knee flexion, assisting knee flexion. Okay, that's a main consideration for the Euchness contraction. So always we used to protect the foot with the footwear. Sometimes you put the foot frame also. Sometimes this is not enough to correct the Euchness. Euchness is very difficult to correct one. You correct the knee. So better you put the foot frame and also like do a gradual correction. Always use a temporary foot frame to keep it in the ankle to remove the.
So suppose lengthening the femur. So what other problems? Like what you happen in the foot? Anything happen in the hip?
The hip joint might sublexate or dislocate.
Subluxation of hip is also one thing we can expect. Any kind of deformity correction frame or lengthening frames in a Ellis road method, always you have to keep in mind distally the deformity of the foot, proximally subluxation of the hip is a common thing. So sometimes if you suspect a subluxation, what will you do? On distracting, you have started distracting, a limb lengthening you are doing, slowly you are getting a subluxation of hip. What will you be the next step?
Position the limb accordingly in the abduction and flex position.
You'll keep it in abduction. That will solve the problem. Then you will stop your lengthening, or what will you do? You can extend your frame, no? Frame can be extended up and you can include the above region so that you can avoid that. And you can continue your lengthening process. How much you can lengthen? Normal scenario. How much lengthening you can do in the femur? How much lengthening you can do in the tibia? 10 centimeter femur.
Normally, like we never do more than 4 or 5 centimeter normally, but you can take the total length of the bone. If it's a femur or tibia, don't do more than 20%. 10 centimeter bone, I'll do only 2 centimeter lengthening. Normally, what is the normal nail you will put for femur? 40, around 40. So it's a 40 centimeter approximately. If you take it, I'll do more than 4 to 5. Don't do more than 20% of the total length of the bone. Mostly you'll get a most complications like regenerate. You won't get a proper regenerate, or sometimes you may get a soft tissue contractures, other things. We never do a lengthening. You can do a bone transport. You know what is the difference between bone transport and lengthening? You had this name. What is bone transport? What is bone transport? What is lengthening? So these are confusing. Most of the time they will ask what is transport, what is lengthening. So lengthening is you are lengthening all the tissues, bone, skin, nerves, everything you're distracting. So suppose the child has shortened tibia. Right side is 10 centimeter. Here I'm getting a 6 centimeter of tibia. I'm going to lengthen the whole limb. Limb lengthening is a lengthening of the, if you cut the bone here, I'm lengthening all the bone along with the skin, soft tissue, nerves, everything we're stretching. We're not lengthening the nerve, but it's also coming to stretching and it will be accommodated. That's called lengthening. Okay, lengthening is lengthening the all tissues. Transport is, suppose both side tibia is almost 10 centimeter, but I had a gap. Between there is a no bone for maybe 4 centimeter. That may be a traumatic loss. It may be a tumor, if I exercise a tumor, or any other cause, like any congenital, suppose if we do any benign lesion, something like excision, or malignant lesion, osteosarcoma, something like proximal tibia excising, there is a bone gap. So transport is, you're transporting the one part of the bone to other part. There only bone is moving along with the frame. All the soft tissue will be static. Okay, so bone moving means, suppose if I move the proximal tibia to the down, what are the muscles attached to the proximal tibia? Gastrocnemius posteriorly attached and other thing. That will move. But if we are not lengthening, we are not doing anything with the soft tissues. So you know now the difference between bone transport and lengthening. You know the difference. Regaining the original length is transport. We are doing transport to gain the original length. But for lengthening, we are adding some more length to the patient. It's a basic difference. Okay. So I am telling the bone
Even
transport.
in the transport, we are doing osteogenesis also, because we are doing the transport means just we are not transporting the bone.
We are transporting the along all the tissues also. So it's called not osteogenesis. It's called osteogenesis.
So why I'm asking about transport, bone transport and lengthening. Okay, transport, initial length of the same, initial length and end length is the same for transport. And for the bone lengthening, the initial length will be different. So why I'm asking this? Bone transport, I can do even I have done more than 15 centimeter. Even 15 centimeter gap, small bone. If you give me a 4 centimeter of length of the bone, I can do a corticotomy and transport even 15 centimeter. Okay, you can be extreme, maybe you can go with the extreme line. Like even if you do bicortical, many options are there. But if I do lengthening, I never do more than 20% of the thing. I will calculate the bone length and safely I'll do 4 centimeter. Even children, if I do 3 to 4 centimeter, the child has 10 centimeter of shortening, congenital deformity. Like I have got some fibular hemimelia or proximal femoral deficiency. What I do, I'll do a 4 centimeter and interval. At the age of 4 years, I'll do one lengthening, growing like before spurt, growth spurt. And what the growth spurt for the male and female, 10 to 14 years for the male and 8 to 12 years. Before that, I'll do one lengthening and third lengthening, maybe 4 centimeter, I'll make it as 12 centimeter. I never do a single lengthening for this thing. Don't do more than 20%, it will become mostly you get a complications, more complications. Okay.
The exam they will ask the pin side care and they will advise to the patients at the time of discharge. All the things you should know. Okay. Next.
Yeah, pin side care is very important. Pin side care is more like
Then, as Gandhi said, you should know what is the bifocal, monofocal lengthening. When will you do bifocal lengthening? That I think you may be knowing that. So if the lengthening is done from 2 centers, here and here, that is called as bifocal.
Yes, bifocal, trifocal, subfocal are there.
So many.
Next, confusing.
Confusing is bifocal, trifocal. There is a corticotomy, there is a osteosynthesis. Osteosynthesis is you're making a new bone, union and making a new bone. If I cut the bone in one side, that is a monofocal corticotomy. Osteosynthesis monofocal. If I do 2 types, maybe osteotomy is bifocal, but synthesis is trifocal because you are making a union in other place. Maybe that may be maybe if you read, maybe you can understand. Okay, sir. This next one, sir. Like
this change.
Yeah.
Anybody? It's continuing, yeah.
Games games
2 more then.
Come.
The simple exercise, don't hesitate. Participating is better.
Next, Balaji ಯಾರು other I think 11 delegates from Balaji, I think.
Nobody is here today. Yes.
Come, one more come. Like you can call randomly, sir. No need to.
Just comment on this. Yes.
So is it external fixator, bipolar external fixator?
What kind of external fixator is? Is it a ring type of external fixator or any other type? Tubular?
Tubular, sir.
What tubular? What tubular? Any more things you want to add to the tubular?
So uniplanar, sir.
Yeah. But there are two things. Two tips are there, no?
To add additional stability, sir.
This is for adding the stability. Okay. So uniplanar fixator, but there are two tubes with pins with clamps for making it more stable. This is one way of making it more stable. Okay. Anything else? What do you call this? This is AO, no? AO tubular. Excellent, sir. We usually call this. So the clamps, what are the different type of clamps you are seeing, no?
Sir, above sir, T clamp, sir. You can see. Then AO clamps.
Clamp above and
then sir, AO clamps.
Okay.
Then
it's only AO clamp or Any other universe is there?
Have you seen this? Have you assisted any case of external fixator? So what are the parts of external fixator?
So one sample will be
So
there,
there's
sir.
a Shan's pin. Shan's pin is there. You know what types of pins? Shan's, what are the types of pins? You know, orthopedic normally you're using.
The Steinman pin.
Steinman pin is no threads. It's a normal,
Yes,
like
sir.
diamond tip. Okay, then.
Sir, Sans pin, sir.
Shan's pin is? Shan's pin is?
The distal part will be screw-like threads will be there, sir.
Screw-like. It's a threaded part
Yes,
of
sir.
a normal pin. What are the types of Shan's pin? Shan's pin, there are many types. So from the diameter and length, we can see. Normally, what we're using here is a 4.5 to 5 mm diameter. In Illustrator, we'll use a 6 mm conical. You know, have you heard of conical Shan's pin? The tip will be 5 mm and the edge will be like 6 mm. That's a tapering. Tapering will be more stable. So mostly we'll never, actually never use these kind of things. And for even X-Fix, maybe we'll use this. And Illustrator, we never use this pin, Shan's pin. And what are the other pins? Even suppose osteoporotic bone.
Denham's.
The Rams, no, the Rams pin. Hydra, same stain pin. What do you call first? Shan's pin types. I told you like it's a normal pin, taper code, and hydroxyapatite. Even now, self-drilling, self-tapping, all the pins are available now. Even self-drilling, self-tapping, new pins are available. Depends on the thread length and length, it will vary. Diameter. Diameter is important. Normally, we're using here is what diameter? Pin.
4.5.
4.5 to 5 mm for this is a universal external fixator. So, okay, one is pin. Then, so we talk about Shan's pin. Then next one, Derham. What is the Derham pins?
Thread in between the two.
Where will you use it?
Calcaneum or
Calcaneum or any osteoporotic. Maybe it has a threads to hold. Okay, yeah. So there's a one pin. Then what is this?
Tubular rods.
This is a connecting tubular rods. What is the diameter of this rod? So everything you should know. Because if you use any instrument or implant in the operation table, you should at least read before using, and should know all the diameters of the ring. Then what is this? Clamp.
T-clamp. T-clamp.
This is a universal external fixator clamp. T-clamp is here, and you consider that maybe you can. I don't know. It's a tube to tube connecting. It's a universal external fixator ring. You know the diameter of that rod. I think it's 13 millimeter. Just see that. Maybe it will accommodate other things. How it acts? What are the components of clamps? You know, if you remove the screw, it will come out. So you know how it's holding. If you tighten that, it holds. All the principle you should know. Okay, so there's only three parts only: pins, tubes, and clamps. The type of clamps is T-clamp is there, tube to tube, rod to rod clamp. All these things will be, you should know that. Okay, that is an implant. So what is the principle of using external fixator? What is the difference between external fixator and Illustrator?
In Illustrator, we use distraction stitches where we make a corticotomy to transfer.
It's a type of external fixator. This is also a type of external fixator. What is the difference?
You give
advantage.
Based on the duration.
This is more short duration.
Longer duration.
Short duration.
Yeah, the idea of applying this kind of external is to facilitate healing of an external wound. This will be applied only for a short. What are the disadvantages of this?
Fixator is a temporary fixator. It's not for definitive management. But the Illustrator is a definitive fixator. It's for we are using it for definitive management. Okay, this is for temporary management. What are the temporary?
When there is a
external wound,
compound wound fracture, where we don't have soft tissue cover to plan for definitive fixation, we can temporarily stabilize the bone with.
Yeah, we have to stabilize. Why we should stabilize? What's the advantage of the stabilizing?
It will aid us in treating the fracture, united fracture, and also it will give us
stability. Will get rid of the infection. According to parents. Okay.
So what are the ways by which you can strengthen this kind of fixator?
We
can are applying with this.
Look, you just divide it. The way of inserting the pin and the way of applying the rod. Stability. How will you increase the stability?
More pins closer to each other, sir, at one end of the fracture site will increase stability rather than.
Yes.
More, but okay, closer to the fracture, and it should be wider between the pins. That's important. If you add more pins, what will happen? One is stress fracture and vascularity. You will compromise the vascularity with the bone. So you have to balance. Then
Rods,
No, no, not that. Even in the pins. Yes, by particle purchase, then you can increase the diameter, then conical threads, then making hydroxyapatite like this.
So, as you asked, like how to increase the stiffness, what is the radial preload? Radial preloading. This actually you should know if you are applying X-fix. Anyone? What will you do before the pin? You drill it, pre-drilling. Okay, why do you want to do pre-drilling?
Pre-drilling also important.
So normally if you put a screw, not only the chance pin, if you using a plate or screw with drilling, normally you do 70 to 80% of the core diameter of the implant. Suppose if you use a screw, here we are using a 4.5 mm pin. What drill bit will you use it? 3.2 or 3.5. So at least 80% of the you do core drilling. What is radial preload?
So yeah.
Okay, if you drill it, the whole core diameter, if you insert the pin, the force along with the pin while inserting it will go radially equally in all distance. Suppose if we don't do pre-drilling, proper drilling, it will may end up into fractures. Or sometimes you may get a splinters. It will become loose and no use. So that's called preloading. When you read about what is preloading, loading will be, you can see the forces along the pin disperse all the sides equally to the place. That's called pre-drilling. What is axial preloading? These are the principles of Willis rope, like X-fix. Radial preloading and axial preloading. What is axial preloading? So after applying all the pins, to compress the proximal and distal pin and hold it and tie it with the rods. Once if you leave, it automatically give an axial load. So maybe you're not understanding if you're doing, if you apply first pin and second pin, while attached to the rod, you hold the both pin together and try to get it converging. So what will happen? There will be pressure and between the two pins. Once you apply and leave it, it will give an axial preload. It try to come to the normal place, so you'll get a compression at the thing. It will give a stability. Should definitely know about radial. And have you ever used Excel fixer as a definitely? It had a good reduction. All the fracture, like maybe good compression is there, not communicated. Sometimes very rarely, maybe less than 10%. Maybe sometimes you can use it as a definitive. Most of the time, we never use this as a definitive process. Procedure for wound healing and flap. Large volume of cases, we don't have time to operate directly. Use the X-fix without open injury. Any other place, like there's no injury. Compartment syndrome we never use. Why do you want to use the X-fix? Yes, maybe you can for spanning. Yeah. So pylon fractures, proximal tibia fractures, blisters are there. Very rarely, blisters also never use, and vascular injury. Sometimes dislocated knee. They want to do a vascular repair. So what we'll do, like for immobilization, you can't put a plaster. At the time, you can put a X-fix and vascular repairs. Sometimes.
So there is a pylon fracture. You are applying this external fixator. How will you make it as a definitive fixator?
Sir,
Arvind? Huh? Yeah, convert it into hybrid fixator. You can allow weight bearing in that situation.
Any periarticular fracture, in that case you can make it as hybrid after some time. So you can make it. Put it next. Yeah.
With the tube, how will you make it most
We have to add
increase the stability and adding more rods.
And near that's the principle. Using X-fix first pin near to, maybe this is also like long, this thing. Near, far. That will give stability. What is span? Spanning.
the distance between two pins should be as well.
Spanning. What is spanning? Spanning is between the distance between the skin and the rod. we need a space. If you give a long space, it's not much stable. If you keep it very close, we can't do dressing. Mainly, like we have to apply X-fix to do dressing and pin care, all these things, like we do wound care. So span should be optimum to get a good stability, and also like we want to space for working place for this. That's called spanning. Okay, excuse me, you should know that implants, principles, how to increase. Initially you told it's a biplanar, all these things. That also like you can use a biplanar, you can increase the stability, all these things. Okay.
Two more. Who want to come? How is that? What is this, pa? Everybody will be knowing this. Begin this. Start with this tree. Very fast.
Have you used this one?
Yes.
Okay. Still using it? Huh?
No, no, what else? Most of the time, the examiner will ask you to keep telling. Then they will only your mistake. Okay, come on, like that. Just to describe the Thomas print.
Thomas splint.
Yes.
There's two rods.
This
Huge.
H.O. Thomas. You are having difficulty in pronunciation. Simply you can say Hook Owen Thomas. Is sir or not? Sir means you have to definitely add that. It's very valuable for English speaking people. Sir, H.O. Thomas. Yes. Yeah.
It has two rods. One is medial side and lateral side, and rings at the proximal end. The lateral side it has bends to contour the greater trochanter.
To accommodate the
greater
contour of the greater trochanter. Okay.
And distally there is a double shaped.
So what kind of a traction it is? Yeah, traction using this. First of all, for what condition it was initially used?
Tuberculosis.
It was used for tuberculosis problem. Then later on only it was used in trauma also. Okay. Can it be used for upper limb or only for lower limb? Anybody? Only lower limb. But when it was invented first, it was used for upper limb. Then only it was started for using the lower limb also. Okay. Then, so what is the type of traction by using this? There are two traction. One is a fixed traction and one is a balanced traction. Already we discussed the balanced traction. So this is the fixed traction. Can we use a balanced traction with this? Possible or not?
How
Can your Thomas print act as a balanced traction?
possible? Is it possible to get a balanced traction? How Arvind?
Yes or no? It is possible or not? Yes, it is possible. Huh? How? One mic you can circulate there. Yuka. Yeah. Just taking a patient to get down and raise their foot. The body will be acting as a traction.
Where the counter gets? How
apparatus gets the counter, where it gets the counter.
Generally, where will you get the? You get a 3-point fixation, no? Where is it? One is here.
What is here?
One is in the middle aspect. Here, which part will be reaching here? It is on the ischial tuberosity. Okay, then. So how will you, what is this? Something is attached to this. What is it, plaster?
It's not
This is a creep bandage. This is a
Skin traction.
yes. Extraction apparatus. Is there any modification in this?
What's the precaution you should take in the applying the skin traction?
You have to do adequate padding. Okay.
Otherwise, what will happen?
There is a possibility of pressure sore. Okay.
Skin will peel off in old age patient and it will create pressure sore. Then the start point also important.
No.
Laterally, it should be below the head of the fibula. Medially, you can go up to the thigh, medial part of the thigh. Then you should prevent the external rotation. How will you prevent external rotation?
Like
Then postro, anterolateral. Anterolateral, it will go for external rotation.
Okay. So what are the observations? Suppose you are going in the ward, you seeing a patient with traction like this. What are the common observations? What are the problems he can get with this kind of traction? How long you can apply this? This is a temporary procedure only, no?
Transport.
For transport or for waiting for surgical procedure. You can do that. So the time what all observation you will do? What are the complication you will expect? One, already we said he can get a pressure sore or a allergic. The plaster can get allergic and he can get some skin issues. Apart from that, anything else can happen. Elderly patient, obese patient, loosening can happen. You have to take that. Then
swelling.
Yeah, swelling can increase. The swelling can push over there. Yeah, no, this ring, no, that can be. If there is a sudden increase in swelling, that can do some pressure effect. That can cause some problem, and you have to expect some DVT complication also. You have to keep it in mind, and they can develop a nerve palsy also. You have to look for that also. Okay, these are the common things you have to look. Okay, right.
You measure the appropriate size for the patient.
Yes, from crotch to heel distance, add 11-inch additional.
Okay, so it's holding in the trochanter and medial side, and you can add the length. How will you see the diameter? Most of the time, the diameter of the thigh will be bigger. Normally, shaft of femur fracture, if you apply, there will be hematoma. Sometimes it may not go. So, you have to do pre-self, like you can see that normally get a larger size to cross that side, and measurement should be like appropriate. We have only fixed like lengths, large, medium, all these things will be there. You should do appropriate and get the 10 centimeter length distal to the leg for the counter traction. Okay.
Go to next. Easy. Easy task.
Sabonis lab application, sir.
Comment. How it is applied. How will you apply a Sabonis lab? Comment on this particular application, whether it is correct or wrong. Relax, sir. This is
Knee should be in 10-degree flexion, sir.
Knee in? Why you have to keep the knee in flexion?
Knee should be in 10-degree flexion to relax the hamstring.
Mainly to relax the hamstring or anything else? So keep. Yeah, only capsule can go for contraction. Anything else? There are always some joints has to be kept in little bit of flexion to avoid contracture of. What are the other things the joint, man, other than capsule? Collaterals, no? The collaterals should be always kept in a long. If it goes for contraction, then it will affect the range of movements. Okay. So minimum 5 degree to 10-degree flexion is always optimal for a knee. Is it okay with the ankle? What is the position of ankle?
Ball of grade 2, the level should be below the ball of grade 2 and
No, the position of ankle in an above knee cast.
neutral.
Neutral. 90 degree. Here, you keep it in dorsiflexion. Anybody? What is the position of your ankle? There is also a little bit of 5-degree plantar flexion we can accept. Okay. And your cast should extend up to the
Ball of grade 2 and fifth metatarsal head should be palpable.
yes. Should be at the metatarsal level. Should not go beyond the toes. Extend the cast beyond the toes. Is there any indication for that?
Foot fracture associated toe extension slab should be.
Any tendon repair, any procedure you do that region, you can extend. Okay, right.
What is the material? Calculate this one. Plaster of Paris. What is the chemical like this? One question we used to ask in even undergraduate.
Calcium hydroxide.
Calcium hydroxyapatite. Just I'm asking, this is actually supposed to, I expect all should know this. I don't know, like 50%. It is telling calcium hydroxyapatite. It's a hemihydrated calcium sulfate. Actually, why I'm asking this question is like, I'm surprised to see even after, even my senior residents also sometimes they never know this. Like sometimes they ask, they'll ask calcium carbonate, all these things, right? You're supposed to know. If you use any material, you're supposed to know, read and do this. It's hemihydrated calcium sulfate. So that's one thing. Then after that, what is the reaction during a plaster application? You know, like after wetting. Why do you want to use the water? It's semi-hydrated. So making water, maybe it's giving exothermic reaction and releasing, and maybe it becomes set. And main thing I see a problem of during application of the plasters, people keep on rolling the plaster, applying a slab, rolling the bandage, all these things. So there is no two types of set is there. What are two types of sets in plasters? Maybe I'll tell the name hot set and soft set. What is soft set? What is hot set? Soft setting is if you apply a plaster, immediately it will stays there. So during the soft set, you should not move the plaster. If you apply over the knee joint, apply the plaster, roll the band, hold it whatever the position you want and keep it, and after that goes. That's called soft set. If you that time also I've seen people like keep on rolling, and that's the cause for the most of the time breakage of the plasters. You've seen all the plasters to go for breakage. So you hold it till it sets. After that, you can even use one more bandage to strengthen that. That's called soft set. Hot set is when will happen? Just guess. Soft set is immediately after application of the plaster, what we observe. Hot set is after 24 hours. It take even 24 to 48 hours. So that's why if you apply a cast, make the patient walk after 48 hours, even if you want to wait. About foot,
they asked if you apply the plaster, keep it in plantigrade, and always only apply for the plaster for the foot fractures, metatarsal fractures. This is thing. If you see the plaster, even like some good coats are there written. If you show me your plaster, how good you are in orthopedics. If you see some plaster who is applying, you will assess the surgical skill of the surgeon. Even if I see someone, if you're applying a plaster, you should know the basic principles. So you see here, if you apply the plaster here, here it's a mild plantigrade is there. If you go for rounds, if you see this, even if our professors and all will ask them to remove and reapply. They don't want this kind of weakness and all. Put it properly, plantigrade. And one more thing, if you apply for the any plaster for the foot, like metatarsal fractures, what are the things you look for is you have to get the beautiful arch. Medial arch, you have to get it. Posteriorly, there is a tendoicles. Both sides, there will be a paratendinous space. You have to mold everything. And dorsally, you should mold along with the foot. If you don't make the arch, the foot won't sit in the plaster properly. So there will be movement and people. Maybe next time, if you apply plaster for the foot injuries, apply this arch, make the mold arch and apply posterior tendoicles. It will hold all the places. See the how patients comfortable they feel after plastering. This under like will observe. Somebody apply plaster and comes for BK slab itself, will show nobody will apply like arch and all. That will be like round plaster and they will apply and come and the patient still have a discomfort and pain will be there. So applying proper bony prominences and apply more pad on this structures. Here like a fibular head is there, peroneal nerve is risk and the heel. Heel sometimes if you apply with the plaster for the cerebral palsy children, they'll have a continuous spasticity. They tend to develop ulcer on the heel range. So give a more pad, sometimes will open that place. Okay, these are the precautions to prevent and use the adequate padding. Always keep the soft roll. Whatever the pad 1 inch above and maybe can roll it. And the edges, we don't want the edges to may injure the skin. These are the things you have to take a prevention. Okay.
After putting the POP, you are discharging the some complaints, severe complaints. What will you suspect and what will you do?
I will suspect compartment syndrome. I will open the plaster of Paris.
Yeah.
Passive stretch pain. And I'll measure delta pressures.
That side of the compartment, right?
Pain, pallor, paresthesia, pulselessness, paralysis.
Pain is compartment syndrome is a disproportionate pain. Because that is the important thing. Disproportionate means like a patient can't tolerate that pain. Even fracture also, if you immobilize, the pain will go. Compartment syndrome, the many patients, they can't tolerate because ischemic pain is more severe. So disproportionate pain is there, like you suspect. That's the only thing that we can suspect. This. Okay.
Simple innocuous fracture, sometimes we may lose the limb. Okay, there's certain things happened in rapid also.
I have never seen the plaster compartment. We mostly will advise the patient attender if the pediatric is very dangerous. We have to tell the parents. Sometimes they won't come mild pain and all, but we have to talk to them about after plaster care, about the pain, everything. You have to explain to the patients. Even if we apply a cost, we never discharge the patient. We will CTV all the cases we apply plaster. At least we'll observe the patient for 30 to 40 minutes outside the OPD. Again, we'll call them and see and go. That's important. I have seen during maybe I did my PG in Raipata. This time I've seen few cases of native treatment, like they put a tight bandage for simple Galeazzi fracture. One young boy came with necrotic muscle and black color amputation. I've done few cases I've seen with a native bandage. I never seen a plaster application compartment syndrome, and sometimes not in our practice. But very careful about applying a plaster. Sometimes what happens, if the patient comes early to the treatment, suppose the injury happened, within 1 hour if you apply plaster, when will you get a swelling normally? If you get a fracture or any injury, that swelling will start appear after 4-3 hours, like inflammation swelling. If you apply bandage before that, maybe most of them will never see a patient earlier. If you see a patient earlier, first hour if you apply plasters, that makes chance of getting increased swelling and can do complication. Very careful about treating early injuries. Okay.
Next. What is cost index? What is that? Cost index. கொஞ்சம் பின்னாடி போங்க. Yeah. Yes, sir. Next was the cost index come. Yeah. Cost and yeah. Next. Yeah. Here is this name, cost index. In the forearm, it's not a cylindrical. Forearm, if you see AP, it's a wider and is very narrow. If you have the forearm under AP view, that's called cost index. Okay, so it's normally in forearm is 0.8. You can apply all these things to even thigh, tibia, wherever you apply a plaster. You should not apply a round plaster. It should be molding the limb. Proximally it's wider, distally it's narrow. You have to mold the limb, not the universal. That's called cost index. Normally it's 0.7, indicates apply. My forearm they will apply. Forearm fractures, normally apply, and after the plaster cost application, you have to hold and mold, get the wider of the forearm in the olar aspect, and the lateral view, which may be a smaller. That's called cost index. Okay. Google வா. 2 Google வாங்கப்பா. Google.
Skull tongue.
ஃப்ரண்ட்ல வந்திருக்கேன். ஃப்ரண்ட்ல வந்து நல்லா
Skull tongue.
Skull tongue.
Applied in the outer table of parietal bone. Sorry, temporal.
Where it is used first? The indication for skull tongue application?
Listhesis of cervical spine.
What's the indication for skull tongue application?
acute cervical spine, acute traumatic injuries.
Acute unstable cervical spine injury. It's to give temporary stabilization until surgery, and also for post-operative support also. Post-operative, are you giving skull tongue?
No.
Only pre-operatively.
Intraoperatively.
Pre and intraoperatively will give skull tongue applications, skeletal cranial traction. What's the anatomy, surface anatomy for application does? What's the pin? What's the name of the pin?
Parts of those skull tongue.
Cardinal stones.
Just like that you are applying, but without knowing, you are knowing applying the skull tongue.
The tongues.
It's like a crochet. What is the depth you are drilling? Sir, first you say the landmark.
External auditory meters.
3 finger breadth above pinna, sir, in line with the mastoid.
With mastoid.
How much above the pinna?
3 finger.
3 finger breadth and
in line.
Okay. How much depth you can go?
Outer
The outer table, how many millimeter?
Three to 5 millimeters.
No, 4 millimeter for adult, 3 millimeter for pediatric age group. Okay.
The weight, amount of weight
you can apply.
Only C1, C2 report is
Around
10.
10. 15 also you can apply. 15 also you can apply.
Sir,
What all the things will look after applying this?
Sir, the position of the head and neck. You have to elevate the head and neck. And insight whether there is any infections. The weight whether it is touching the floor or is suspended.
Any other complications, rare complications you can see with this?
Any worsening of the what are neurological symptoms to find after applications?
Can you get any nerve palsy with this?
What do you look at the face to identify something wrong going on or this?
Really, what routes you have to look for that? What is that?
Bell's palsy.
What test you do? That's it. Let's go forward.
What you are looking at that nerve? What's some nerve that will tell you that you are producing overtraction?
Every day
You have to watch for that. Okay.
Why you are getting the abduction more commonly? Any of the problem of the skull, why you are getting always the abduction is getting involved? Any reason for that? Yeah, somebody is correct. There is a nerve having longest intracranial course. So whoever is long, whoever is short, always have a trouble. Okay, either way, that's the reason. Okay.
Any worst complication you have with the patient with skull tongue?
We are placing the inner table cause.
Oh, that's okay. Okay. So respiratory paralysis, even a brainstem problems also, sudden death can happen. You have to be very careful and follow it.
Yes.
With this, we come to the end of ward rounds. Next, we have a short case presentation by Dr. Asher from CMC Vellore.
Hello. 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 Bye. 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 Hello. Bye. Oh. ஒரு அக்கௌண்ட் சென்டா உங்க பேமெண்ட் அது வந்து உங்களுக்கு மண்டே உங்களுக்கு அமௌண்ட் வரும். ஆமா ஆமா. ஆ, நாளைக்கு ஒரு சேர்த்து மண்டே மண்டே ஒரு நாள் கரெக்டாக வந்தாரு. அவங்க நம்ம மண்டே தான் அமௌண்ட் மண்டே 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 உட்காந்து ஆயிரத்தி அதுதான் கொஞ்சம் ஆமா ஆமா நாளைக்கு நாளைக்கு மிஸ் ஆகலாங்க மிஸ் ஆகலாம் மத்தியானம் நாளைக்கு நான் மண்டே மார்னிங்கே நான் இங்கே வந்து உங்களுக்கு அப்படியே கையோட வாங்கி என்ன பண்ணும் இல்லை நாளைக்கு நாளைக்கு கிடையாது அது அது ஓகே நல்லது அதான் Very note.
We now have a short case presentation by Dr. Asher from CMC Vellore.
Yes. Short history,
Yes.
short history and salient points, and if you can offer diagnosis or diagnose a differential diagnosis.
Sir. So, good evening, sir. This is an eight-year-old child, sir, who presented with a history of a fall 4 months ago. He had sustained a closed injury to his left elbow, for which he underwent native sprinting, a series of 4 sprintings, which lasted for 2 months. After the splint was finally removed after 2 months, the mother noticed that there was a deformity in the left forearm, left elbow, for which he was brought here. Birth history was relatively insignificant. Family history, he's the 3rd child. There's nothing else significant in the history. Yes, sir. No, sir. There's no increase in the deformity since the beginning of the onset of the deformity.
So after history taking, what do you think of?
This is it's an 8-year-old boy post-traumatic deformity of the left elbow. Sir.
It's a deformity of the left elbow.
Yes, sir.
Post-traumatic deformity is the primary diagnosis.
The complaint is a deformity based on the history.
What deformities? Or maybe history taking.
Yes, sir.
So an examination, only positive findings. Huh?
On examination of the patient was examined in a sitting position from anteriorly, laterally, and posteriorly. Sorry, sir. There was on examination, the attitude of the patient, he was at ease with both arms by the side and the elbow in slight flexion, the wrist in neutral, and the fingers at ease. Going to the local examination of the left elbow, on inspection, there was a deformity noted with a swelling on the lateral aspect of the left elbow. There is no other scars, sinuses. There is a hyperpigmented mark on the anterior medial aspect of the arm, which is corresponding to the previous native treatment. No other dilated veins. No other dilated veins. No other swellings are noted over the body or on the opposite limb. Moving on to palpation. There was no localized warmth. There was no tenderness present over the joint line. On checking the bony landmarks, there was a prominence of the lateral epicondyle on the left elbow. And on checking, there was no abnormality felt in the medial condyle or in the radial head or in the tip of the olecranon process. The 3-point relationship. Sorry. There was an increase in the 3-point relationship on the lateral limb as compared and the intercondylar distance as compared to the opposite side. When the elbows were
all these things, did you measure?
Yes, sir.
Is a marking and all?
It was done this morning. It was this
morning. It
morning. He had gone for lunch in between and comes.
Okay. அழிச்சிட்டீங்களா அத கையில மார்க் பண்ணிருந்தாங்கடா சரி okay no just I'm asking because examination they will see all the markings and all, just careful maybe mark and like measure it. Okay. Even limb length measurement, all these things you mark, and these are things they'll expect in the exam. Okay. Very difficult to measure without marking. Okay.
And there was an increase in the lateral limb of the 3-point distance with an increase in the intercondylar distance. Moving on to there was no distal neurovascular deficits. Moving on to the movement.
Inspection, palpation.
Yes, movements.
Anything you want to see in the palpation other than the bony landmarks?
Anconius triangle. There's any swelling there?
Other than bones, anything around the elbow you want to check?
The position of the triceps tendon posteriorly.
Specifically in elbow. So any trauma to the elbow, what do you look for? Like What do you think common around the elbow than other joints?
Muscles, it's the tendons, the tendons.
Other than bone tendons, anything you want to see here on the elbow, we can usually palpate.
Lymph node, I mean the lymph. Sorry. The ulnar nerve, sorry. The ulnar nerve on the medial.
Anteriorly, what?
Any signs of myositis ossificans, no mass in the cubital fossa of the elbow. Triceps also, in the distal tendons also.
The palpation in elbow is there is a soft tissue and bony palpation. Soft tissue look for all the you can see anterior, posterior, and all the spaces. Bony palpation is the landmark. Medial condyle, lateral condyle, ulnar tip of the olecranon, and radial head. How do you feel the radial head here?
Condyle as well as the supracondylar ridges. It's very important.
So supracondylar ridges is very important to differentiate between the malunited supracondylar fracture with other diagnoses. That's very important. You have to see the ridge should be thickened or something like we have any finding. That's more probably it's a supracondylar.
Yes, sir. To palpate the radial head, we go along keep the elbow at 90 degrees flexion, go along the lateral epicondyle, go more distally 1 centimeter, feel the dip, and after that confirm the position of the radial head by supinating and pronating.
It's difficult to palpate because of the prominence is more on lateral side. Okay.
Yes.
Felt normal side. So you able to feel the radial head in position?
Yes, sir. I was able to feel it, sir.
Yes.
Going to movements.
Movements.
Yes, sir. Going to movements. There's a flexion deformity of 30 degrees on the left elbow, which he is able to further flex the elbow up to 110 degrees. I have one. So yes, sir. I measured with the gonimeter. So I have it. Yes,
30 degree up.
Yeah, 50, sir. And he's able to.
He measured with gonimeter so that you have. Okay. So don't tell by normally doing clinical examination. Do 20 degree, 30 degree by eyes. The exam always if you do anything you measure it and do it properly. Don't tell 25 degree, 15 degrees under the exam. But you tell 15 degrees should be measured with a gonimeter. Don't tell by eyes it's a 17, 18, all the degree. Maybe you can tell 10, 20, but normally you do in clinical examination. Always in the exam, even if you use a gonimeter for every time, it's perfect. So use a gonimeter, he's telling like you used a gonimeter and measured 30 degrees so that I'll accept. Okay. It should not be 10 degrees, it's okay. If it's to be 20, it will be 40. If you present as 30, it's okay. Don't make it gradual error. So 60 degree FFD, if you present as 20 or don't tell that I says.
Yes, sir. And he's further able to flex the elbow up to 120, sir. And the opposite side is able to 120, so the other side up to 130. The other side is able to get 130, so there's actually a 10 degree difference in flexion. Yes, sir. So after that it's a bony block. So it's a hard block.
If you talk about the range action deformity, is that like you see here it's a fixed flexion deformity. After that the arc is 32, 110. After that it stops.
Yes, sir.
It's not normal. So that arc is painful or painless.
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 Yes.
Is there any crepitus during deflection?
There's no.
So everybody should ask questions. Or is there flexion? What is the end point? End point is suddenly they have a bony block or it's a soft end point like goes. So it's all the if we talk about the movement, you talk about the is there any deformity, flexion deformity or extension deformity? What is the range of the movement? Is it painful? It's any crepitus is there in knee joint is important. Crepitus means it's arthritic. Upper limits you will not like unlikely to get the arthritis. Then end point of the movement. Okay. So present the moment like
yes, sir. So there was a fixed flexion deformity of 30 degrees, and there was an arc of movement from 30 to 110 degrees, which was painless, pain-free, with no associated crepitus and or spasm.
Don't mention extension. Many people they still after FFD, there's no extension. Don't tell them. There is a fixed flexion deformity means it's no extension is there.
Increase on both in supination and explanation as compared to the others. Of around 1.5 centimeters as compared to the other side. There's wasting in the longitudinally there's no increase in the length of the arm or the forearm segments as compared to the other sides.
Here upper limb you don't want about total length. Probably they have to measure it for the length of the humerus and the forearm. That's okay.
So the arm
We're
length
not
versus the
expecting
forearm
anything
length.
except congenital deformities.
Yes, sir.
Here measurement, what we want to know it's intercondylar measurement, like difference.
Intercondylar was 1 centimeter, sir. Was 1 centimeter as compared to the other sides. The left side was more increased, had an increased the base of the intercondylar distance and the lateral limb of the triangle, the base as well as the lateral limb both increased as compared to the other side, sir.
Okay.
Yes, sir.
Lateral.
Medial side was simply
What happened to the tip of the olecranon to the lateral condyle distance?
the condyle to the lateral. There is an increase in that limb, sir. In that limb and along the intercondylar.
Anything can happen.
There can be an increase. There can be an increase, sir.
Even if the elbow is subluxated, it may change.
Yes, sir.
So
If there's a dislocation, it can be reduced, but
subluxation.
Subluxation, yes.
Dislocation may be
It'll-
dramatic.
it'll-
Okay.
yes, sir.
What we expect here. Okay.
Yes,
So
sir.
movement, inspection, palpation, movements, and measurements.
Yes, sir.
Over. Then any special test.
Special tests, varus stress test, we can perform in 30 degrees of flexion.
Instability.
Instability, but it was not positive.
Test with so much of flexion deformity.
It was not positive. I could not.
Don't tell.
And I could not measure the carrying angle for this patient as well because he's not able to fully extend his elbow.
So you can't mention about varus or valgus, cubitus varus or valgus. Okay.
Yes, sir.
Then what? Suppose if you have that, suppose it's
Tell me the points in favor of your diagnosis.
Yes, sir.
3 points. Yes. You completed the.
So my diagnosis was to be an 8-year-old child with post-traumatic.
What is post-traumatic?
Left distal humerus lateral epicondyle malunion or non-union.
malunion,
non-union.
list of the diagnosis.
That could be one of the diagnoses.
Wherever you write a diagnosis, wherever you write a diagnosis, wherever, like not only this child, write a diagnosis, the diagnosis should contain anatomical location, pathology, and problems. So anatomical location, suppose if you take this child, anatomical location is the left elbow. Correct. Even if you want to go particularly, there is a lateral condyle. There's a prominence is there. There's an anatomical location. What is the pathology here?
Traumatic.
So post-traumatic. Okay, so should write there's a pathology is there, anatomical location, then complete the diagnosis. Then finally, what are the problems he had? There is a fixed flexion deformity here, and there is a flexion deformity, like full flexion is not there. So reduction of total arc is there, and there is a prominence of lateral. Maybe that's a difference. So you have to contain. Now we tell you a diagnosis, complete diagnosis.
So an 8-year-old boy with a distal humerus lateral condyle.
I know, like lateral condyle in distal humerus.
Yes, sir.
You know,
That's it, I mean, lateral condyle.
So you are now worry about it's malunion or non-union. How will you differentiate between the malunion and non-union?
There's no pain. There's no pain in the range of motion.
It's non-union.
No pain for both parts.
For both.
Non-union, non-union, there will be no pain.
So a crepitus would be one more. Abnormal mobility.
Okay.
Yes, sir.
Do you get a abnormal mobility or not? Yes or no? Your clinical finding.
I was not able to elicit it.
So you can't elicit. Okay, these are very small, simple problem. If you should know once, it's easy to. So you can't elicit the frank abnormal mobility or the lateral condyle. So he's presenting as a malunion. You want to present as a malunion. Have you ever seen a lateral condyle malunion in your practice, like your presentation or this thing?
No,
Anyone?
no, sir. No, sir. Not usually.
Anyone seen
No, sir.
malunion of lateral condyle?
No, sir. No, it's a
Non-union?
non-union.
How many of you see a non-union of lateral condyle?
It usually comes.
I also never seen in my practice a malunited lateral condyle. So why there is no movement here? There will be a fibrous fusion between the lateral condyle because it always goes for radiological non-union, and clinically sometimes will get a yielding. Some may be painful if you move it. Maybe you can get a small yielding will be there, and always you will make it a fibrous union. If you open, always it's non-union. Maybe I didn't see the X-ray. The X-ray, maybe you can get a radiological diagnosis non-union. So if you get a case of lateral condyle fracture and non-union, always you present it as a non-union. The examiner will ask you if you don't get a non-union because it's a fibrous. You have to explain this. Don't present, it's a malunion. You don't see if you know that. Okay, it's a lateral condyle non-union of this.
I would like to confirm my diagnosis with the X-ray of the.
How do you differentiate between lateral condyle non-union with a supracondylar malunion? What are the points?
The points, the 3-point relationship.
It is very important to differentiate. These are the two cases commonly they'll keep it for exam: lateral condyle or supracondylar malunion. So 3-point.
The 3-point relationship is usually maintained in a supracondylar fracture. Movement, there will be rotation of the shoulder also will be sometimes.
Shoulder or nothing to do
because
with
it's internally rotated. The fragment usually be internally rotated in the supracondylar fracture.
Yeah, so we have to do more internal rotation. That is internal rotation and cubitus. Cubitus valgus in malunion supracondylar. Here we will get a cubitus valgus. Here is FFD is there.
Yes.
And what else? Extension.
Extension will be exaggerated in the
hyperextension in the hyperextension,
supracondylar.
internal rotation and varus. Here it's you'll get a valgus if it's extension of this thing. X-ray, read the X-ray.
This is a plain radiograph showing the AP and the lateral view of the left elbow.
The normal side X-ray.
This is the right side.
Madam.
Yeah.
See. Okay. Yeah.
So this is the plain radiograph of the AP and the lateral of the left elbow, showing the distal humerus and both the forearm bones of a skeletally immature child. I'm not able to comment upon the union of the lateral condyle. Lateral condyle is classified by Milch based on into type 1, type 2. Fracture line going through the trochlear group. This would be outside, so it would be a type 1. This would looks more like a type 2. Yes, sir. Yes, sir. So type 4. Yes, sir. This is going laterally, maybe a type 2, sir. Looks more like a type 2, sir. Yes, sir.
What is the use of Milch classification? What it inference you will get it Milch classification? What treatment? Prognostic. It shows the suppose the treatment is it may be undisplaced, partially displaced. That will give a treatment option. prognosis of the lateral condyle. Here, maybe radiologically, there is no classical features of non-union. Even still, sir, can you see that? Feel doubtful. Normally, if you see lateral condyle, always will start from the lateral condyle. Here, even still, there may be a continuity. Rotated. Normally, the common extents are attached to that. That will give a rotation of the lateral condyle 90-degree outer and always inward. What happens? Normally, the articular surface normally is pointed towards the fracture side. That will cause the non-union. That's why it never unites. Okay, here maybe, as you said, like I never seen before, maybe doubtful. I couldn't see any classical radiological features of non-union here. I don't know, once if you open, maybe you can get the fragment, but still, I didn't see like there's no continuity. Maybe we had to take an oblique view, internal oblique view, maybe you can see that, maybe the fracture line.
It's a very important view we have to take. Otherwise,
Maybe
lateral condyle fracture is so one of the missed lateral condyle fractures.
Difficult to diagnose lateral condyle fracture because clinically swelling will be there. Radiologically, very difficult to assess displaced or undisplaced. It's intra-articular fracture, mostly non-ossivate bone. So normally you take internal rotation view, or you can do arthrogram. And if the lateral condyle is there, mostly treatment is open deduction. We never do even close deduction, open deduction, fixation. Okay. So now what do you do?
So it's a general principle. In articular fracture, better to get an anatomical reduction. So if you open and see, then only you can reduce it anatomically. That is the reason why. As a process, arthrography is also very important initiation. Paraoperatively also you can perform.
If you have doubtful, you can do arthrogram. And most of the time, X-ray looks very simple. If you open, you can see the large displaced fragment inside lateral condyle. So lateral condyle, mostly if you suspect, radiologically it's very difficult to diagnose. The arthrogram you can use it, or otherwise maybe you can sometimes they'll use it for other images for taking a MRI or all the other things. But large fragment and displaced fractures, most of them requires open deduction. You want to this intra-articular fracture needs open and fixation. Okay, that's why
most of the time this open fragment also over hypertrophy because of the attachment of the extensor, and it will be rotated and it will be usually broadened. That's the reason why you get a broadened lateral condyle.
So now, what are the problems we will get in lateral condyle non-union? You told like there is a restriction of movement, cubitus valgus, then that's the 4 components for the lateral condyle non-union. There is a restriction of movement here. That's why like it doesn't have any movement problem.
Yes, sir.
Will it be a progressive deformity or a non-progressive deformity?
It will progress as he grows because there can be arrest of the growth.
So unlike your cubitus varus, condyle fracture is involving the growth. So there will be always a progression of deformity. You have to ask for that in history itself. And associated, what other problems will occur? Later on, if it is growing, it can stretch over the ulnar.
That's why 4 components is there. One is cubitus valgus. Second is instability. That one is range of movement may be affected. Then tardial nanopalsy. Tardial nanopalsy, it may develop even 20 to 25 years to take. Most of the patients we are seeing lateral condyle non-union, they usually have seen patients of 20 to 25 years. That much gradual, whenever the valgus instability, distraction, they'll tend to develop tardial nanopalsy. Okay, that's a long. So here, what are the problems here? Here is the movement restriction.
It's got restriction of movement, sir, with the deformity.
Is there any elbow instability?
There could not.
There's no restriction of movement and non-union. What did you do?
I would like to get further imaging. First, get a CT of the elbow, check for the state of the union of the.
So your diagnosis is not yet fully whether it is united or non-uniting or non-union. These 3 things are possible still. So you want to confirm that. What is the status of the fracture? So you go further initiation like internal oblique view and CT scan also.
Even, sir, can you see this is normal? Like it's the myositis or it's normal rotated distal humerus. Maybe that may be the cause for the flexion deficit. Because lateral condyle we never see myositis, mostly other injury.
Yes.
Some suspect this. So what did you do now? So why is having IV line now? Why is patient is having IV line? Ask that question. Now, why is having IV line?
I think he's admitted. At the moment,
Admitted to put IV line for all patients. Did you ask that first?
no, sir, I did not ask that. That's
Nalik operation, amma? No, why they put IV line? Don't you ask all these things questions? Suppose if you see anything. Okay. Okay. Observation.
I saw that. It was asked.
We operate now.
I would like to offer
So you do immediately open it will be nurses, but you want to wait for some time for something to improve. So what will be the complication if you do open direction infiltration?
Again, there can be
What counseling you do to the parents?
There can be a facial growth arrest. And,
anything else? What is the range of movement now?
It's almost normal within 10 degrees less than the other.
Do you think your surgery will improve the range of movement?
It could
worsen.
It
can worsen also. So that caution you have to always explain to the patient relatives, especially the parents. You have to be very careful. And most of the time, in an elbow problem, always better to make it very soft and supple. Available range of movement has to be improved. Then you can plan your treatment. Always. Okay. So you may end up in a stiffness if you are in hurrying your treatment. Better to wait. Okay.
Yeah.
Anything?
Here, to prevent the instability, what will you do? At the time of you cannot do grafting and all. It will end in the complication it may end in instability. To prevent the instability, what will you do?
We can keep a plaster
What is
post-operative.
in situ fixation in other means? In situ fixation. We'll do in situ fixation severe deformities in older patients. Patients, as you said, like if we come for tardial non-palsy at the age of 20-25 years, you do in situ fixation to prevent the further valgus instability and anterior transposition. That's not all. I told you, like each 4 components of lateral condyle non-union. Okay, so correction of deformity. Deformity is more. You can do a correction at the metaphysis level. In situ fixation is the fragment is wherever it is that we fix it to prevent further instability and now and anterior transmission of the ulna now. These are the components: deformity, instability, and ulna now palsy. Okay, lateral condyle. Important is one more thing is actually in situ is not just in situ fixation. You have to open and reduce to a certain extent, then you have to fix. That's in situ. That's a misnomer actually. You go and read. So one more thing I want to know about lateral condyle. One more important. Even if you do acute fractures or treating a non-union, dissect always anteriorly. Don't go posterior because the vessel supplying to the lateral condyle coming through the posterior aspect. So if you dissect any soft tissue on posterior, there may be a chance of AVN to the lateral condyle. Important with things during the surgery you have to keep in mind. Okay, thank you.
Thank you.
Thank you, sir.
Yes.
Our last short case presentation for the day is by Dr. Loganathan from Kannur Medical College.
Comfortable some loss of movement. Camera ada.
Male child brought to mother who is reliable in both food for past 3 years. So, um, no other significant history. Only deformity. It's a present at birth. 3, sir. No, sir. He had also deformity. He know delivery itself, sir, because he had deformity. He only came for second.
Child is not walking. What about speech?
Speech.
Speech is
Sir.
normal. What about IQ? IQ is understanding.
It's normal only.
Birth history normal, significant.
Birth history is a normal delivery.
No, any significant birth history, like neonatal admissions,
Yeah.
preterm, any asphyxia, admitted in neonatology, this something, anything is
No,
there?
sir. It's the deformity present at birth itself, sir. He had a
Genetic, any family person involved?
no,
What
sir.
about consent?
He had a sibling.
Marriage?
No, non-conceived marriage, sir.
Okay.
He had sibling. One brother, 3. He had no similar complaints, sir.
Okay.
So.
Where is he from? Child?
Andhra.
Andhra. Tamil தெரியுமாம்மா உங்களுக்கு?
பேசுங்க.
தமிழ் தெரியும். Okay.
He understand the Tamil.
சொந்தத்துல என்ன கல்யாணம் பண்ணிருக்கீங்களா? சொல்றாங்க. எத்தனாவது குழந்தை இது உங்களுக்கு? முதல் குழந்தை நல்லா இருக்காங்களா? ஒன்றும் பிரச்சனை இல்லை. நேர மாசத்துல பிறந்தாங்களா? 10 மாசத்துல பிறந்தாங்க. நார்மல் டெலிவரியா? சரி, நார்மல் டெலிவரி தான். அட்மிட் பண்ண பிறந்த உடனே அட்மிட் பண்ணியிருந்தாங்களா ஹாஸ்பிட்டல் எங்கேயாவது? அந்த குழந்தை அட்மிட்லாம் பண்ணல. எப்போ என்ன பிரச்சனை குழந்தைக்கு? ஓகே, அப்புறம் ஃப்ராக்சர் இருக்கு, கிளப் ஃபுட் இருக்கு, 2 தான். வேற கையில ஒன்றும் பிரச்சனை இல்லை உங்களுக்கு. கிளப் ஃபுட்னு உங்களுக்கு யார் சொன்னது? ஓகே, குழந்தை இப்போ எவ்வளவு வயசாகுது? பேச்சு எப்படி இருக்கு? நார்மலா பேசுறாங்களா இல்ல மத்த குழந்தை மாதிரி நல்லா உங்ககிட்ட எல்லாம் பேசுவாங்களா? ஓகே, இதுக்கு சொன்னா கேட்பாங்களா? புரியுமா எல்லாம் பேசுறதுலாம்? நடக்கிறது, குழந்தை நடக்கிறது உங்களுக்கு பிரச்சனையே தெரியலையா? 3 வயசு ஆகுது இல்லையா? ஒன்றும் நடக்கல இல்லையா? அப்ப அதுக்கு போய் காமிச்சிங்களா? பிடிச்சிட்டு நிக்கிறாங்களா? முட்டி டைட்டா இருக்கு. உட்காருவாங்களா? தனியா உட்கார வச்சா உட்காருவாங்களா? போட்டு முட்டி போட்டு எங்க எப்படி நகருவாங்க? முட்டி போட்டு தான் நகருவாங்க. ஸோ நடக்கல, பிடிச்சிட்டு நிக்கல. So see, what are the one you can elicit more history. And child is not non-working child at the age of 3 years, and child, no, even mother itself telling it's a club foot. So that's different. Club foot is a maybe secondary cause. Maybe try to find out the primary cause for that. Okay.
Yes, sir. Proceed. So you just the findings. From the mother reliable source, you have to tell the entire history, all these prenatal, natal, postnatal history, and other siblings history. All this are very important. Okay. Right. Now tell me the findings. Yes.
So attitude, inspection.
Yes.
The finding is that. So, as you know, like the couch, I had a 30-degree flexion deformity leg and 40-degree fixed flexion of knee, and the foot is adducted and equinus present.
So the problem attitude wise, your patient, you made the patient light and then exam. The patient has got a hip, knee, and there is a bilateral
and lateral deformity.
what deformity in the foot?
Congenital CD, bilateral CD.
It is a- So where are the deformities are present? In which part? You have to tell like this, Where is at where, equinus at where?
Forefoot adduction, midfoot varus, hindfoot equinus. Hindfoot equinus.
Equinus. Also, there is the increased arch, The arch is increased. There is any problem in the toes?
The crowding of the toes is.
Yes. Then some. Is there any anything? Oh, okay. There's only
So he got a
adduction.
treatment for that.
Metatarsal adductors obviously senescence. Yes. So what is the other problems?
So initially, he had treatment for that.
Yes.
For that they put POP. Then anatomy also done.
Procedures being done.
After that, they advised for that DB splint, Darius Brown splint, sir. But the patient not wearing that for past to 1.5 years, sir.
So you want to say it's a relapsed, completely cured, relapsed, or the resistant one?
No, so it's resistant CT.
Okay. So the cases where you'll get the resistant clubfoots. It is a idiopathic type 1 or the resistant clubfoot. What are the condition that will produce a resistant clubfoot? It's very difficult to treat. What are the condition?
So arthroscopy, AMG, arthroscopy.
Arthro?
Arthrogryposis congenita.
Okay. Then anything? Any other?
Any problem in the spine?
He had scoliosis.
Oh, yeah. You'll get a resistant. You said resist can produce clubfoot, which can be resistant like that.
Scoliosis.
Scoliosis. Yeah. So what spinal deformity is commonly associated with clubfoot? Secondary, you call it a secondary clubfoot. What is that?
Spina bifida.
It's spina bifida. Okay. So what are the other causes for this kind of resistant clubfoot? It may be arthrogryposis or anything else. Give me some syndromes, associated with some syndromes.
Yes. This looks like a complex problem. It looks like a myogenic type of. Upper limb is normal. Below the hip there is a flexion deformity. Knee there is a flexion deformity. And foot is looks like a CTV like features. Right, left side looks like CTV features, and right side is not significant. So I'd like to use for any. It's a syndromic. One thing is syndromic. Do a genetic workup and see for any spinal disruption. I've clinically said there's no spinal problem. Always I'm thinking like only lower limb involved. And the IQ is normal. Speech, normal. I don't know, like you have to assess the speech, other things also. Maybe it's cerebral palsy kind of this thing, but lower limb only is involved. Upper limb is absolutely normal. I'm thinking of any spinal problem. Like maybe you can evaluate the spinal, like these things, and genetic workup. And I don't know what is the power of the muscles. It's moving normally.
All the components, sir.
More than foot deformity, I find the knee is more affected. Knee is a fixed flexion deformity, and tight hamstring and tight gastrocnemius. Gastrocnemius can produce a varus, heel varus, because tight gastrocnemius can keep the calcaneum medial or lateral. Normally go for varus. So that maybe you can see in the CTV cases. It's a muscle cause. Muscle imbalance can produce CTV-like features. Right side is a minimum deformity. The left side is more looks like a
Right side already anatomy
What are the types of clubfoot? Classify like imagine it's idiopathic one. Other
there's idiopathic and secondary clubfoot.
Idiopathic and secondary.
Depending on the cause of the cause, it classified into
Idiopathic,
and
myopathic, and neuropathic, and atypical. Atypical be syndromic. Okay, what are the cause for myopathic clubfoot? Example: myopathic and muscle involvement. Arthrocryposis. What is the pathology in arthrocryposis? Normally, muscle will be
contracture.
Muscle will be like replaced by a fibrous tissue. No contractile element will be there. Can produce. That's very difficult to treat. That's called myogenic. What is neurogenic?
Neurogenic
Is a polio, now unlikely seen, and cerebral palsy. Neurogenic causes of CTG. And atypical. Atypical sometimes you have to find out. Very difficult to resist the treatment, and some syndromic cause also. First, you have to classify the clubfoot in the idiopathic, myopathic, and neuropathic, and atypical clubfoots. Then finally, then we can treat it. It is not idiopathic. Definitely, it looks like some syndromic associated deformity. You have to evaluate the child with the genetic workup and assess for the hip joint. I would like to take a pelvis X-ray, see for the hip joint stability. Sometimes may be dislocated because the imbalance. You have to work up, take the knee X-ray and see that there's a flexion deformity of the knee. Assess with the physiotherapy of the muscle power. It's normal. What is the power of like hip movement, knee muscles and ankle muscles? Then evaluate the child and treat it. Here, for me, clubfoot is not a problem because child is not walking yet. 3 years old child not walking is definitely a problem. You have to evaluate and make sure that if you correct the knee deformity, will the child able to stand? These are things you have to assess with the occupational and physiotherapy assessment. Probably have CP, cerebral palsy clinic. You have to assess with them and to proceed with this patient. For me, CTV is not a problem here. I think like CTV is not a primary cause. So first I would like to correct the hip, knee. Always you correct the hip, knee problems. Sometimes automatically foot will. Finally, if your foot is not plantigrade, any deformity is there, I'll go for foot deformity correction. Main problem is there in the hip and knee. So that may be a soft tissue problem, and maybe it may be a central cause or spinal cause. You have to find out the diagnosis and treat. Always think before treat, you get a diagnosis. Don't treat any patient without diagnosis. It happens. Like seeing the patient, sometimes you won't get a diagnosis, treat something like give analgesics also. Try to get a diagnosis and treat.
So
Okay.
suppose we ignore these other problems like hip. With only a bilateral CTV, just imagine in a 3.5 years old child, after the anatomy, she comes back with the lapse. What do you do?
So first, we'll do. We'll
no, leave it to a child. Uncommon, I'm asking. What do you do? A child at 3.5 years is coming with the lapse clubfoot bilateral. Then usually, now what do you do?
brace for weight for.
It has lapsed, it occurred. So what do you do? So spirit is going to help and you're going to correct the deformity again. So what is the purpose of spirit?
So we do surgery to release the soft tissues.
What surgery you do?
Okay, procedure. Okay, procedure we do. So release the soft tissue and do metatarsal tarsal corrective osteotomy for.
What osteotomy? So you do extended release. You don't do a posterior medial release. One posterior medial release. You don't want to do a posterior medial release now?
Do.
Yes. So what are the structures you will release in a posterior medial?
So the Achilles tendon, then ligaments, that delta ligaments, and
still two ligaments you release normally.
So calco ligament and delta ligaments.
Okay.
Talonavicular ligament.
Any case?
Oh, assisted.
Yes. Okay. So two capsules, very important, subtalar and the ankle posterior capsule. And then the ligaments, deltoid spring you have to release. And then you lengthen the other tendon, tibialis posterior and the FHL. Tip can release if you want. Then the TA is usually lengthened in this age group. No, you not do prenatomy here. 3 years, 3.5 years old. Then if it is not getting, then you go and do an extended lateral release also. So any other procedures, you know? So the child has got now a lateral lengthening with a curved lateral border. What do you do? Anyone?
Release the lateral stitches. Ligaments.
Any books? What is the procedures you do when there is a lengthening of lateral column?
Something to shorten the lateral column, no? What bone you will shorten?
Yeah, someone studying. Fusion.
Will fuse. Will fuse. This is
Either
the
you
start
can do an osteotomy involving the calcaneal keyboard, or you can do cuboid alone. Like that.
Never fuse a joint. Okay, that's a last procedure. Like that's a salvage.
Yes, the older children, yeah.
Growing child, I don't want to fuse a joint. You can have a calcaneal shortening, or you can do a navic like the lateral side navic. This one is there, like a cuboid. You can use a large cuboid is there. Mostly calcaneal also can do. What is the procedure name? That's what I'm asking. What is the lateral column shortening?
Dilwyn?
Dilwyn Evans.
CTV mostly treatment, like gold standard is a Ponseti early management. Up to maybe now they're using a Ponseti, even someone is presenting even 9 years also, like they'll use a Ponseti, then treat the primary causes. Ponseti is the gold standard treatment for the early treatment. Like if you want to do a treatment within even first week of delivery, like for the life also, like we started doing a plastering. Even now we plan to start on steady. Then we are applying every week plasters. How many of you seeing applying a plasters for CTV? Ponseti technique. Residents. I think I supposed to like see all residents should apply. We have a CTV clinic. Every week, Wednesday, we'll get 20 to 30 cases. So we'll apply each candidate, like each resident will apply 4 or 5 plasters. And we want to do every day. Now we want to apply a weekly plasters. They want to do on steady. Every day, first canvas, then 4-foot adduction. Like daily, you have to remove the plaster. At the end of the 1 week, we want to do a stenectomy. Some studies are there. I don't know some evidence. That's what we plan to start on weekly plaster. If you see the child after 6 months to 1 year, treatment is again you have to do a Ponseti. Ponseti is the gold standard. Do a Ponseti and assess after sometimes. Child may require a soft tissue release. Suppose age of 1 year to 2 years, 3 years. If the child comes at 4 years, 5 years, what do you do? 4 years, 5 years, maybe you can option of you can sometimes we in just you can see or some bony procedures like you can do. Minimal deformity is there. Already partially treated with the Ponseti. You have only 4-foot adduction. Minimal deformity is there. You can go with Dillivans like lateral column shortening and medial lengthening. You can do that. Severe deformity is there. Again, you can go for just correction. I prefer to do Ilizero because like just is like for me, it's a not tension wire. I use a tension wire to release. Maybe mostly I'll use the Ilizero for correction of the foot deformity. If you see the child between 4 years to 8 years or 9 years. So if you see child after 13 years or 14 years, all the foot developed, growth, everything is over. Bone remodel with the deformity. Now it's very difficult to do a soft tissue procedure. Go for now, the treatment is described. Still we try to do with midfoot osteotomy. We osteotomy try to correct the foot deformity without like fusing the joint. We try to correct the deformity and clear that. Actually, I never do a triple fusion for even 13 years or 14 years. We'll do a V osteotomy, correct the deformity, whatever deformity you want to correct, 4-foot, hindfoot, and these things. Then you can make it a plantigrade foot. Okay. So this is the algorithm for treating a CTV, Ponseti, soft tissue release, bony procedure or just or Ilizero, whatever the option. Then finally, fusion is the theoretical. You can do a foot deformity osteotomy and correct it. Okay. So if you see any foot case, whatever the deformity, you can divide the foot into 3 parts: 4-foot, midfoot, and hindfoot. Easy. So what are the deformity in 4-foot in CTV? There's a 4-foot adduction. What is the difference between 4-foot adduction in CTV and metatarsus adductus? Anyone? Both are same or different? Where is the pathology in CTB? Clubfoot.
Subtalar.
Subtalar. It's a talonavicular joint. There is a talonavicular joint orientation called CTB, clubfoot. In metatarsus adductus, it's in the metatarso-cuneiform joint. So that's a different entity. Metatarsus adductus. So treatment is different between metatarsus adductus and clubfoot. So that's a forefoot. What is the deformity in midfoot? What is a midfoot? Midfoot is talonavicular joint subluxation. Midfoot is a cavus. Cavus is a nothing but inversion of the foot, comparatively pronation of the forefoot with the hindfoot, the heel varus. You know, heel varus is the calcaneum is turned medially. Foot is also pronated compared with supination. Like suppose what is like how Ponseti describes, both are supinated. In foot, both are supinated. Forefoot is comparatively pronated over the hindfoot. That's called the cavus, eye arch. Normally, if you take your foot, rotate the forefoot internally, you'll get eye arch. That's called cavus. So that's why Ponseti make the first correction is that to correct the cavus to align the forefoot to the hindfoot. That's why elevating the first metatarsal high, you can correct the align the forefoot to the hindfoot, then only correct the metatarsus adductus, then heel varus. So that is the main clubfoot management. Okay, so you know, dividing the midfoot, forefoot, and hindfoot, it's easy for us to manage. Even whatever the complex deformity, easily you can manage. So if you want to like exam, like convince, first like you have to convince and try to understand and answer. Okay, how many foots in the bone? How many bones are in the foot? Sorry, how many bones are in the foot?
24.
24. Anyone? This is a question suddenly will ask. So maybe you can never count. It's easy. How many? 24? How many? Now counting.
English letters.
Okay, so this is a question like what I will do if a student comes, like first thing I'll convince, otherwise I'll confuse. So simple. Okay, so don't try to confuse. Like you may be clear about what I'm doing. I know that before my answer is 26. If you know that, next time if I ask, it's easy. Next time you know to think and count. Okay, even count, if I count, like easily count. Metatarsal 5, phalanx 5, proximal phalanx 5, distal phalanx is only 4. 19. Midfoot, how many bones are there? Cuneiform 3, cuboid 1, navicular 1, and phalanx. Simple. How many joints? Same thing, 26. So simple thing, like keep on reading and detailed about the anatomy, pathology, biomechanics, and read. Should confidently answer to the exam. And the exam means like you should confidently present like this, very difficult. If you want to confident, you have to at least assist, see the like surgery something, and read about anatomy, biomechanics of the foot. Then go and read. You should research. You are postgraduate now. No longer like you are like student where somebody will feed you and come and answer like this. You actually have to read more than us. Okay, so anatomy means where will you read anatomy? Suppose if you want to see about read about foot anatomy, where will you read? Go and search anatomy book and read. All the orthopedic anatomy will be like almost whatever they understood, they write. Read the anatomy, biomechanics. Even if you want to the biomechanics of the foot, what are the movements in the forefoot, hindfoot? You know what are the types of what are the movements in the foot? What is adduction, abduction? What is pronation, supination? What is varus valgus? These are the confusing terms. At this all this movement, what is the pronation, supination, and the foot? What is adduction, abduction? What is inversion, eversion? What is decuneus? These are the movements across. Each joint is like you know the decuneus accurate, ankle joint produce, ankle equinus, dorsiflexion, plantar flexion. Inversion, eversion occurs at subtalar joint. Minimum of ankle joint also moves. And forefoot adduction, abduction is in midfoot between the talonavicular. What we are doing a talar correction. What is the supination pronation? It's a forefoot movement. Forefoot metatarsal movement along with it. Everything while walking, foot is goes for supination. While landing, metatarsal pronation. All these things like beautiful biomechanics involves you read that then you love and read that, like how the all the joint rehearsal, how the foot moves, string face, joints are supple and get the okay. So do well. Thank you.
So
Thank you, sir. I request Professor Pasupati, sir, to felicitate the speaker. The panelists, Professor Mohan Kumar, sir, head of the department at Stanley Medical College. Professor Suresh Gane, sir, additional professor at Pondicherry.
So I thank all the faculties, those who has contributed for the experience for the exam going post-graduates today. We had a wonderful session today from the morning. We had how to examine a case. We had OSCE and long case discussion, pediatric hip case presentation was done very nicely. Then we had a shoulder presentation, how to examine a shoulder case, and students were also discussed. Evening we had all rounds and infection, bone and joint infection management. All these things are I think is useful for all of you. So hope you had a good treatment for your brain as well as for your stomach today. We will meet tomorrow again with a topic as a spine as a predominant topic, and we will have some implants and a tumor also tomorrow. So that is all will be covered and tomorrow. So have a nice sleep, relax, go through, just contemplate what you have learned today. That will be very useful. If you are staying together, you can discuss with your friends also. That will be helpful. As Professor Suresh Gandhi said, you have to read good books, that basics and other things also you have to read. So come prepared for a spine examination presentation tomorrow. Thank you very much. Thank you. Thank you very much.